And in fact, earlier we had a meeting with the Red Tape Authority and the proponents of ivermectin, and we informed them naman on the legal ways of bringing the product in for use into the country. Ivermectin is a known antiparasitic. It's not a new drug. This is an old drug used in the treatment of strongyloidiasis and onchocerciasis. It is it's also used for inflammatory lesions of the skin, like rosacea. Yung adverse reactions naman niya is usually mild, like fatigue, dizziness, nausea, and mga siguro medyo serious lang, mga bronchospasm. But in the doses that it is used for the antiparasitic, usually naman po mild lang ang kanyang mga side effects. However, in the Philippines, the commercially available preparation ay topical cream solution for human use. Lotion po ito ng available sa Pilipinas. Meron din pong oral and tablets pero for veterinary use lang at saka injection. Wala pong naka-register sa Pilipinas na for oral use for humans, Although in some other countries there are commercially available preparations in other countries na orals or tablets for human use. Pero sa Pilipinas po, walang naka-register. Kaya marami pong nagre-report sa amin ng mga doktor, ng mga pasyente. And for example, one product that we saw that was being sold online, bawal po kasi magbenta ng antibiotics online at bawal pong magbenta ng unregistered drug. This was an ivermectin capsule that was being sold online, which is unregistered. And it's not legal in the Philippines to sell unregistered products. Kaya naglabas po tayo ng advisory dyan. Meron din pong isang laboratory who was compounding and was asked to comply with quality standards just to make sure that yung mga ginagamitan, nireresetahan, ay good quality po yung gamot na nakukuha nila. We also got reports that people were using veterinary products kasi nga po ito yung available sa atin, veterinary ivermectin to treat themselves or to prevent COVID-19. So we came out also with the advisory for the public to please not take products that were approved for animal use. Iba po kasi ang preparation niyan, iba yung mga excipients niyan, iba yung kanyang contents na not always for human consumption. And of course, yung dosage would not be the same for animals as if they are for humans. And just to make it clear, there's no ban on the purchase and use of ivermectin. Ivermectin can be sold, can be used as long as it follows the indications and the product is registered. May CSP, meron pong certificate of product registration, and if products might possibly be useful in COVID-19, if there was an application lodged with the FDA, this will be processed quickly, and within the allowable timelines. Yan lang po. Maraming salamat po.
DG Eric?
Yes, ma'am.
Any update on the Chinese medicine Lianhua?
Ma'am, Lianhua has been registered with the FDA since last year. This is registered as a traditional Chinese medicine for mga pulmonary conditions. It has recently been delisted by the Dangerous Drugs Board as a dangerous drug kasi po yung ephedra. So hindi na po kailangan ng S2 prescription para po mabili siya ng pasyente.
Thank you, DG Eric Domingo. Last to present is from the vaccination program. We have Yusek Mirna Kabutahe.
Thank you, Madam Chair. Magandang hapon po sa inyong lahat at ang ating mga honorable members of the Committee on Health, our secretaries and officials of the National Government Agency. In behalf of Secretary Galvez, I am presenting the National Vaccination Operations Center Vaccination Report. To give you an overview of what we have already done, next slide please. So this slide shows the coverage of our total vaccinated priority group A1. These are our workers in the frontline health service. 8,353 individuals under this priority group A, which accounts for 54.6% of our total eligible priority group A1. And then yesterday, we already started the second dose of our vaccines because we started vaccinating March 1st among a couple of hospitals, and a total of 404 individuals have already completed their dose. This is in column 9. The next slide will show us the donut illustration of our coverage. This is the whole coverage, the whole master listed population, which shows that 54.6% have been vaccinated, 33.3% receiving Sinovac Coronavac, and 21.3% receiving the AstraZeneca, and we still have a 45.4% unvaccinated workers in the frontline health services. Next slide, please. This will tell us the percentage of priority group A given their first dose of COVID-19 vaccine. These are the blue bars, and the red bar shows the numbers that have not yet been vaccinated. The highest vaccination coverage among group A1, priority group A1, is NCR 4A and region 6. Next slide will tell us the vaccination of group A2. It has been recommended and approved by the IATF because of the surge in the NCR plus bubble, and a very good coverage already for healthcare workers vaccination in NCR. Simultaneous or parallel vaccination with the next group, this is the A2 senior citizens, have started in different hospitals which have not been used. So we have a total of 4,009 individuals under priority group A2 who have received their first dose of AstraZeneca vaccines. So all in all, we have a total of 702 individuals from A1. So both the frontline health workers and the A2 senior citizens given their first dose of COVID-19 vaccines. And again, to emphasize that it is in NCR that most of the senior citizens have been vaccinated. The next slide will tell us the consumption rate, meaning of the vaccines given to the different regions, how good is their use of the vaccine. No? So in the Philippines, we have an 80% plus, highest is in region 10, with a more than 100% coverage. This is explained by the fact that we were able to extract 11 dose from the AstraZeneca doses. And then we have some problems to do with Caraga and BARM. BARM mostly because of the security problems where they cannot ship their vaccines to the Sulu and Tawi-Tawi areas. The next slide will tell us the granular data on the consumption of our allocated vaccines. So we have a total of, on the third column, 702,362 vaccinated, which already includes senior citizens and a consumption rate of 85%. So we are need to push the remaining 15% of the vaccines that have not been used. And for our information, we have used one half of our 600,000 Sinovac, and we are assuring the vaccinees of the second dose. But we have used all the 25,600 AstraZeneca as first doses because there is assurance from the COVAX that we will receive the second dose by May at the latest. The next slide will tell us our inventory of our second dose of, this is the second dose of Sinovac. How many have already been given? This is in NCR, 404. So the others will continue, and we will have the reports coming in this week and next week for those who are completing their second dose interval of 28 to 32 days from the first dose. Next slide. This is our inventory. We started with 600,000, as I was mentioning, which included 2 doses of the Sinovac, and we have a remaining inventory of 20,100 as part of our buffer. They have all been distributed. The AstraZeneca, which arrived on March 4 and March 7, there is no more inventory at the central warehouse. We have a Sinovac arrival. This is the donation that arrived in March 24 of 400. We have already delivered 271,800. And just to mention that 75% of the vaccines will go to the NCR plus bubble. We have an inventory of 128,200. These are the vaccines that will be shipped to the south and by land trip to Region 2 and some provinces in Region 4A. Already yesterday and today on their way. And we have received the 1 million Sinovac last March 29. The inspection is going on, but we have already done the allocation. Again, 75% goes to the NCR plus bubble, considering that this is where the surge of the cases are. And the next 2 slides will just tell us pictures showing the arrival of the CoronaVac on March 29. Yan lang po.
PF.
May I be allowed to share?
Kindly check, sir.
Yeah. Can you see my Madam slide?
Not yet, sir. Ma'am Sylvia and Diane. Okay, go ahead, sir.
Madam Chair, Your Honors, thank you for allowing us to give you an update that we have provided also to the President yesterday. This will be the outline of my presentation. I will give you a global update of the perspective of the supply chain dynamics, so that you can Your Honors, you will be informed on the global dynamics of the supply chain of the vaccine. I will also give you a background of the status of the rollout and also the vaccine deliveries that will be coming in the near future. So as you can see, this update was taken by one of our consultants, the Boston Consultant Group, the BCG, that has been given to us by the private sector under Ayala and also under the group of the PDRF under BILUS. So this global update will give us always the perspective of how we will deal with the constraints of the global supply. So the global update on vaccination is that as of March 29, we have more or less 540 million doses that have been used for vaccination, and we have a daily job per day of 14 million. India now is vaccinating 2.2 million daily versus the 460 daily in the end of February, and Indonesia also accelerated by 500,000 in some days. For now, we have 702,362 healthcare workers vaccinated in the Philippines, including also some of our seniors. One is number two, this is very important, that the US right now, President Biden has said that May 1 will be the deadline for universal vaccine access, meaning they will offer the vaccination to the general public. And it is 18 states to begin all adult inoculation within the next 2 weeks. The studies are ongoing on population below 18 years old. So meaning, kung makikita po natin yung US, ito po medyo malaking problema po sa atin because the US under the Biden invoked the Defense Procurement Act, meaning they will forbid the export, not only the vaccine, but also the manufacturing raw materials. This made the productions of other vaccines nationwide, also globally, with some challenges. It has been reported during the global vaccine summit that some of the manufacturers are having restrictions on accessing the raw materials coming from the US. And also tension on supply remains as more countries have ramped up their throughput. I will show to you in the next slides the 4 countries that have the manufacturing capacity that they now concentrating on really inoculating their populations and hinder some export of their products. And then AstraZeneca inoculation, or let's assume the meaning of it is the Europe will be using more of AstraZeneca, and with that, the global supply will also be affected. And more importantly, that more variants appearing across the world. It's not only us that are really having that surge of the virus. Indian variant described as the double mutant, reportedly in more than 200 samples in India. With this, nakita natin po talagang the different variants, the Indian variants, the South African variants, also the UK variants and the Brazilian variants. It appears that the South African variants were more challenging among them all. And then, as you can see here, and with that global update, we were able to see and recalibrate our plan. Wherein during our meeting last Monday with Paul Dominguez and all the private sector and also with the DOH officials, we have seen that we have to recalibrate our plan. Considering that we might be planning that we will be inoculating annually, meaning our inoculation would only not be for 2020, but also for 2022, in order to eliminate the COVID-19 disease. And maybe by 2023, we should be ready for another pandemic. So for 2021, our strategy is containment strategy, meaning we have to achieve a steady supply of vaccines. We have to scale up also our vaccination through the mobilization vaccination to more or less 500,000 to 1 million per week. And then by June, when we have already enough access for vaccine, we can increase that to 2 million to 3 million per week. And maybe by August, we have an ambition plan of having 3 million to 5 million per week. And then also our main objective is not only to have the herd immunity, but also to recover our economy and also protect our economy. And our main objective is to have a better Christmas by 2021. When we visited India, we have seen a good perspective of how we will eliminate the disease. So they presented a lot of technology that coming from some sort of third generation vaccine. We said that they said that Covishield may be a first generation vaccine, but Novavax is second generation vaccine, and they're developing a booster that can be used for any vaccine, one-time, big-time booster that can be that increase our immune, and also one vaccine that can reject the entry of the vaccine from our nostril. So during that visit that we had, the concept of complete elimination of the disease came about, and we saw that there is a need for us to strategize to really from containment to elimination. And we can do that by active participation with private pharmaceuticals for vaccine security. That's why the president has given us the order to give the pharmaceutical company to the leeway to coordinate with their pharmaceutical partners abroad, so that in the end, in 2022, we can have that vaccine security. And then also, this is, I think, Your Honors, we have to dedicate our minds on really having health self-sufficiency for the next pandemic. I believe the universal healthcare that we have promoted and we have enacted, I think it's not yet not enough. I believe we have to work for Health Security Act, or maybe the DOH modernization program, in order for us to fully bridge the valley of death. When Secretary Carl presented the economic perspective of the COVID-19, he showed a lot of non-COVID deaths, and we can be sure that in that aspect, when we briefed the president, he made a statement to DVM Secretary to work for certain vaccine security. meaning we have to start doing and making our own. Because our past glory is that in 1939, we have to look at our history and past glory. 1939, we donated vaccine to China. So we wanted to know, I would like to know, to appeal to our good chair, who is also a doctor. It is high time for us to be health self-sufficient. That was the dream of India when they received their independence to the British government. And Ambassador Bagaching told me a story that one of the primary primordial objective of India, the then India, is to have food security, power security, and health security. And now we see India, that they have one of the cheapest medicine that we have and the largest vaccine manufacturing in the world. So now let's go to this is the perspective of the 540 million doses that to date has been inoculated. The deliveries that I will be presenting on the next slide, you can see that the five countries, United States, China, European Union, India, and also United Kingdom, has got the capacity to produce vaccine and to have a steady supply. With the increasing pace that we have, the most expected global effect on the global markets, that the supply of the vaccine will be constrained, because like US, they are planning to have an Independence Day against COVID-19 in July. And with that, the most consequential effect of that is that most of these countries will hold their supplies in order to have their own ramping up of vaccination to finish more or less on July. And we are expecting the easing of supply might come only during the third and fourth quarter, where our vaccine will be delivered in the near future. So this is the status of rollout and vaccine deliveries. Now we have a total of 1,233,500 being deployed, with 80% from the actual vaccines that we have. We have not counted yet the 1 million, considering what we are still inspecting the stability of the vaccine. And then total doses, we have already 2,525,600. And then we have a total, as reported by Yusek Mirna, we have a total of 702,372, which is basically the 85% over the targeted first dose, and also 46% over the total vaccines deployed, and 41%, almost half, over the total of healthcare workers that we have, the 1.7 million. And then also, in order to look at the weekly performance that we have, the first week we have, considering that we have some sort of limitation of the vaccination, we have only 35,289 per week. Then second week, we have already 173,000. And then third week, we have an increasing 185. And fourth week, we have 271,459. So meaning by April, we might be close to our target of having 500,000 a week. So we are already activated a total of 2,497 vaccination sites, and we have a coverage of more or less 771 cities and municipalities. Ladies and gentlemen, Your Honors, this will be the projected deliveries of our vaccine per month. But this is subject to change, as we have expected that there will be constraint on the global supply. So for now, we have already signed a procurement agreement with Sinovac for the delivery of 1.5 million for April. And then Gamaleya, they promised us to have a 100,000. But the DFA, Secretary Locsin, is working hard with the Foreign Minister Lavrov in order to increase that 100,000 to more or less 1 million to even 3 million. And COVAX, we will be expecting more or less 1 million this coming late April. So a total of more or less 2.6 million by end of April. In May, we'll be expecting the delivery of the AstraZeneca. The private sector ordered 2.6 million, and it will come in tranches. And Sinovac will promise us to deliver 2 billion, which we will pay already with our purchase agreement approved. And then Gamaleya, they told us that they can supply more or less 10 to 20 million in succeeding months of April, May, June, and July. And then also AstraZeneca, we have a 17 million order with the private sector or with the LGU. So the 2.6 million will be the early delivery of May. And also Moderna, we have 194,000 to be delivered by May. But this afternoon, I was called by Ambassador Romualdez that he just came from White House from an appointment with the State Department, and they promised that either Johnson & Johnson, Pfizer, or Moderna, we will have an early delivery by May. But most likely Moderna will add some deliveries by the second quarter, and we also increased the order of Moderna to another 5 million out of the 20 million that we have ordered already. And then also in June, we're expecting to have 11.5 million doses. And then also in July, we are expecting to have 13.5 million doses, considering that most of our deliveries, like J&J, Novavax, and also Moderna, will be having huge deliveries during those days. And then also in August, where our contract will be executed during the third quarter and fourth quarter, we are expecting to have 15 to 20 million doses per month. And then our target vaccination is basically, as I've said, April and May, 500 to 1 million. June and July, 2 to 3 million. So we are expecting to receive more or less 140 million doses, excluding COVAX. So this is the graphical representation of what we are expecting in the near future, wherein the rollout plan is to have a steady supply and then a steady rise in scale in terms of volume and administration. And then these are the status of our vaccine procurement. We have already finished the supply agreement of Sinovac for 25 million. Also have the advanced market commitment with the LGU and the private sector with 17 million. We have also finished the supply agreement of Moderna of 13 million and 7 million for private sector. And we were told again by the ambassador that our request for another 5 million is already approved by Moderna. More or less 2 million will be for the private sector and 3 million for the government. Novavax, we have still 30 million pending request with 15 million doses for private and LGU. Johnson & Johnson, we have 5 million. This is a one dose regimen which can be used by 5 million people. Gamaleya, we are ordering 15 to 20 million. Negotiation and payments might be ongoing. We will be having another meeting this coming Thursday. And then also Pfizer, we just met this morning, and we're still with the same offer of 25 million for third quarter and fourth quarter. So basically, the priority population of groups will be as follows. These are the priority group A1, A2, A3, and then A4 and A5. During our meeting with the president, he already approved the NITAG recommendation that we will have a combined inoculation already for A1, A2, and A3 this coming April 1. While the NCR is also already starting for the A2 and the A3. And then we are also recommending that, considering that A4 and A5, the president wanted that the indigent population, the poor people, be accelerated. That's why our recommendation is we will also combine A1, A4, and A5. And then these are the priority population for group as follows: teachers, government workers, other essential workers, also demographic groups, overseas Filipinos, other remaining workforce, and the rest of Filipino population. So these are our recommendations: simultaneous vaccine administration. So March we started the A1. Now we are 41, more or less 41%. Then in April we'll start the A2 and A3. We are also recommending when the vaccine will be coming on May and we have the enough throughput for them, we can start A4 and A5. And by July, when all the vaccines that we have ordered will be available, we can now start B1 and B6, meaning the general population or all adults can be given inoculations by July, starting July. So that's my presentation, Madam, and mabuhay po tayo na.
Thank you, Sec Galvez. Just want to inform you that we already passed at the Committee on Appropriation the National Health Security Act, sir. We do have part of the CDC bill. We already passed at the committee. So kindly help us na lang po in pushing that bills also in the Senate. Thank you, sir. Before we proceed, I'd like to recognize the presence of the following members. We have Senior Deputy Majority Leader Representative Bong Sontay. I've recognized already, I think, DSBH. Representative June Gato, Representative Robert Barber, Representative Alberto Pacquiao, our Deputy Speaker, Representative Wes Gatchalian, Representative Alexi Chutor, our Vice Chair, also our Vice Chair, Representative Dalia Loyola, Representative Ging Swansing, Representative Michael D., Representative Ferdinand Gaite. From the minority, we have Representative Franz Castro, our Vice Chair, Representative Joette Garcia, Representative John Ray Chanco, our Vice Chair, also Rep. Michael Defensor, Representative Mickey Villago, Representative Samantha Vargas Alfonso. We have our Deputy Speaker, Representative Christine Singson Mehan, Representative John Marvinieto, Representative Blanda Bolilia, our Deputy Majority Leader, Representative Onyx Crisologo, Representative Joseph Lacson Noel, our Deputy Majority Leader, Representative Angelica Natasha Co, Representative Eric Martinez, our Deputy Speaker, also DS Representative Rodante Marcoleta, Deputy Speaker, Representative Maria Teresa Collantes, Representative Sharon Garin, Deputy Speaker, Representative Cristal Bagatsing, and Representative Diego T. I would like to give a few minutes to Octa Research. I think they are requesting few minutes of their presentation. You have the floor. Anyone from Octa Research? I think they've requested a few minutes of presentation.
Yes, good afternoon, Chair. This is Ranjit Rai from Octa Research. I'm with our team, Dr. Guido David and Dr. Nick Austriaco. We want to thank the committee for inviting us. And in the spirit of sharing information, we submitted our short report for the consideration of the members of the committee. Secondly, we want to thank all the secretaries present today for their presentation and their leadership and citizenship during this time of crisis. So I'd like to give the floor to Chair, with your permission, to Dr. Guido David, who will share the slides. And we're providing some projections about the current state of COVID-19 in the country.
Okay, sir, you have 5 minutes.
Yes, sir. Yes, ma'am. Professor David, please share.
It's on the screen, sir. You can proceed.
Okay. Okay, thank you.
Thank you, Madam Chair, and good afternoon to everyone, secretaries, congressmen, representatives. We just like to give a quick presentation on the trends that we're seeing. This is the month-by-month analysis, or not analysis, sorry, it's just the month-by-month numbers in new cases, and we can see that in March, this is already higher than what we saw in August. This is the trend in daily new cases in NCR with the trend line here. And we can see that there is although the numbers are increasing, we are seeing a slight slowdown. There's an inflection point in the trend line. So we're seeing that the slope has actually started to turn down slightly lower, affected by the
Professor, I think tagahang po kayo. Can you get a better signal? Professor David? Professor, I have to cut you. Professor David? I think Reverend Father Nicanor Austriaco will take over the presentation. Professor David, you have a bad reception.
So, good afternoon po.
Just want to check if
Okay, good afternoon po. I can go ahead and take over from my colleague if we can continue sharing the slides, please.
Okay, please proceed, Father. Diane, can you let Father to share his slides?
No, so Professor, I don't have Professor Guido's slides with me. So unfortunately, I thought, let me see if I can get them from him.
Father, I have to cut you because we
Yes,
have a lot of
please
information.
go ahead.
Do the share screen po.
Okay,
The
we'll just
secretary can share the screen.
Can you just share the screen and I will just speak from here?
okay.
Sige po.
So thank you again. So I will continue where Professor David ended, Guido David. As you can see here, we have seen in the last, so as you know, the ECQ has begun a few days ago. And because of that, we anticipate making some projections into the next 2 weeks that the reproduction number, which is the number of individuals infected by one person who is identified as positive for COVID-19 will decrease. Remember that our target here is that the reproduction number should decrease below 1 in order for the surge to begin to subside. So our 8.6, which was last week, to 1.55, and hopefully, depending upon the IATF's intentions with regards to the ECQ and whether or not the ECQ will be extended, we expect the reproduction number to drop to 1.18. These are conservative in that we hope that the ECQ will be better than this. And if this is the case, is that because it is Holy Week, many of the laboratories that usually test for slowdown in capacity in the laboratories. Next slide, please. So this is a graph that indicates the COVID-19 bed occupancy, both at total beds and ICU beds in the NCR. And what you see, of course, is over the past several weeks, there's been a dramatic increase in occupancy, both for total beds and ICU beds, where both are expected to pass the 70% high risk threshold. So here you have projections. These are simple projections for the bed occupancy, and as you can see, they are projected to reach in a linear fashion by the middle of the month at 6,000 beds for the NCR. Next slide, please. So with regards to our projections, so these were projections that cases have actually exceeded our projections, which is why you see that we are experiencing a surge. This week, we are observing the R value, and we hope to publish more updated projections towards the end of the week. So this is again, these are the NCR projections. We point out that there will be Holy Week testing adjustments that will affect the number of cases, but we expect that we will witness a drop in the number of cases by the middle of April. Next slide, please. So thank you very much for your kind attention.
Okay, thank you so much. Again, I'd like to reiterate to our colleagues that they have to register at the chat box if they are not a member of this committee, because we have a committee on health thread, so you can just register. So as to the flow of discussion, we'll start first on the current situation. We'll start with questions are related to testing, and we do have members who registered, but I want to start the discussion by asking DOH first. Anyone from DOH can answer my query, no? So kanina po doon sa presentations, nakita natin yung pagtaas ng kaso natin. Gusto ko lang tanungin po ang Department of Health kasi since this COVID-19 started in March 2020, pinag-uusapan po lagi natin at sinasabi na paghandaan yung second wave or if there will be another waves, no, of the cases. Ito po bang pagtaas ng kaso ngayon that we have over 10,000 cases, ito po ba inasahan ng Department of Health? Anyone from the Department of Health po? Secretary Duque or Yusek Rosette can answer. Sec Duque or Yusek Rosette?
Yes, good afternoon, Madam Chair. I think Sec Duque is muted po ba? Sec Duque likes to answer, Madam Chair. He is muted po.
Madam Chair, let me just answer your query. Kung inasahan ba natin ito? Inasahan natin na tumaas ito nung nakita natin na towards a better illustration to support my response. Yung epic curve. Yan. Ito po, kung makikita ninyo, number one, Madam Chair, is the surge that happened in August. No? We can see, I think that's about towards the end of July and beginning of August 6, no? Yan po, nag-register tayo ng mga about 6,000 cases, no? On the average, 5,000 to 6,000 cases, no? And then beginning the end of, this was the time na nagkaroon po tayo ng timeout, if you recall that. The Health Professional Alliance Against COVID appealed to the President to grant the timeout by way of escalating the community quarantine then from GCQ to MECQ. Ano po? So nag 2-week MECQ tayo, and after that we already saw the beginning decline in the number of cases, continuing on a downward trend until about last week of October. Yan po makikita, last week of October, and plateau until about October, November, tumaas ng a bit January, first week, and then nag-plateau na po tayo until umpisa nitong February 18. let us review what the events were that led to the well, we expected actually, no, yung post-holiday surge nung Christmas Eve celebration, the New Year's Eve celebration, also the traslasyon, ano. Apparently, all these expected super spreader events, no, did not give rise to a marked increase in the number of cases. And, well, it did, but hindi naman ganun kataas yung increase, no? It's incremental. Until, of course, noong February 18, dyan, nakita natin ang umpisa ng tumaas, sumipa ng March 4. Ayan, sa bandang dulo, mga 1, 2, 3, mga 4th bar graph. Nakita natin, dito nag-umpisa na yan. No? Prior to that spike, we were hoping that the plateau was going to be sustained. But while we were plateauing during that period prior to the spike, we already ramped up our capacities. Our public bed capacity was ramped up to about 30% of the authorized bed capacity. And then the private sector naman, hospitals, we invoked the AO 2016 to bring it up to 20%. And then we were able to ramp up also our treatment, temporary treatment and monitoring facilities. Ito po yung mga isolation and quarantine facilities. No? Ito po yung mga ginawa natin. Yung ating pong testing ay patuloy na itinaas natin yung daily output natin. Umabot tayo sa mga 40 to 45,000. And also massively cascading our preventive measures revolving around the minimum compliance to the minimum public health standards. Doon po sa BIDA solution, yung atin pong ipinamudmod sa lahat po ng mga pamahalaan lokal at sa kanila pong mga komunidad. Ito po yung bawal na hindi nakamask, ang isanitize ang kamay, mag-face shield, dumistansya ng huwag iiksi sa isang metro, at alamin ang tamang impormasyon. At kasama po dito, kaaktibat nito, yung atin pong mask, hugas, iwas at ventilasyon ng PCOO at 7 commandments ng transport sector, yung Health Professionals Alliance din against COVID na naglabas ng kanilang 4 dapat. No? So ito po pinaigting natin lahat ng ating pong intensified compliance with the minimum public health standards. No? Kanya tingin namin, kaya na kamit natin yung plateauing kasi nga talagang itinodo natin itong mga hakbang na ito. Ang mga non-pharmaceutical interventions or the minimum public health standards. No? So ito po yung mga ginawa natin sa testing, sa TTMF, ating pong pinalawig ang kapasidad, ating pong mga hospital bed capacities. No? So ito pong sumipa ay, ang kaso ng sumipa, nakita din namin yung Okta projection. Kaya in a way, inasahan na rin namin na towards the end of February to about beginning of March hanggang ngayon po, rumagasa na nga po ang increased mobility. Nagbukas po tayo, nagluwag po tayo ng ating mga restrictions. Pangalawa, nagpalawig po tayo ng ating mga economic activities dahil kinakailangan din po talaga batay sa malakas na rekomendasyon na economic cluster. Kinakailangan po ay makabangon muli ang ekonomiya, makabalik po ang trabaho. Pero inaasahan po namin na nasunod pa rin ang lahat doon sa minimum public health standards. Pero nakita po natin ngayon, analyzing this, nagkaroon po ng panghihina sa compliance with the minimum public health standards. Tapos nagkaroon pa tayo ng another variable. Ito po yung variants, yung UK variant, yung B.1.1.7, at saka din po yung ating South African variant na B.1351. Ano po? So exacerbated by this plus increased mobility, ang ating pong weekend compliance with MPHS, yung pong turnaround time, ito po naging problema po ito talaga between the detection, isolation, testing, contact tracing, isolation, and quarantine. At ito po ay isa rin sa maraming kadahilanan. Sa tingin namin at batay din sa mga feedback ng ating po mga eksperto na dumagdag ito sa dahilan kaya sumipa po ang ating mga kaso. At of course, yung ating mga paghihina rin sa sa katuparan ng safety protocols sa mga workplaces, ano po, napakita po rito yung mga taong kumakain sa mga pantries, kumakain po sa mga kantin, nagsasama-sama ang mga tao. Siyempre kung nakain, nagtatanggal ng mask, nagkakahawaan, ay ito po ang isa po sa mga maraming kadahilanan na akin na pong na-enumerate.
Thank you so much, Sec Duque. So we'll start with questions related to testing. We have members registered. I'd like to call on Representative Mickey Violago.
Thank you, Madam Chair, and good afternoon. I have a question po for DOH. Good afternoon po, Yusek Rosette or kay Secretary Duque. My first question po is about the data accuracy. My worry is, ang dami na po kasi nating testing facilities today, and even the hospital, they have their own testing lab na po. Paano po nyo nakukuha lahat yung data every day? Binabato po ba ito?
With the permission of the chair, can I please request Director Thea de Guzman to answer this? She's really more into the data management of the reported cases. Director Thea.
Director de Guzman, you have the floor.
Good afternoon, Madam Chair. So para po malaman kung paano po namin nakukuha yung datos, no? So every day, the laboratories at the end of the day are mandatorily required to submit its line list ng kanyang mga laboratory results. So lahat po ng result, kailangang ipasok po dun sa tinatawag naming COVID-19 document repository system. We have seen an improvement po, no? So dati, we see 10%, 20% of laboratories not being able to comply. Now that has drastically reduced. We see some 5 to 8 laboratories not complying recently na lamang po. So in terms of completeness, ito naman po ay nakukuha natin. We have also seen lessened delay na kumbaga kung ano po yung resulta ngayong araw, papasok na po yan sa Department of Health. Yun lamang po, kailangan din lang namin ipaliwanag na kung ano man po yung natanggap namin, for example, hanggang Sunday ng gabi, yan po ay nililinis namin ng Monday dahil national data po ang pinag-uusapan natin. Pag sinabi po namin nilinis, sinisigurado po yon na yan ay mga PCR positive. And ikalawa po, we do what we call deduplication. Para kung si Alethea de Guzman, 2 beses po siyang nasa line list, isa lang po yung bibilangin namin. And that is what we report the following day po. Madam Chair.
Okay. My next po is kasi po napansin ko din, so ilan ng percent ang nag-comply at ang hindi nagko-comply? Pwede po bang malaman? I think nakamute po kayo. Nakamute po ba kayo?
Thank you. I was muted po, ma'am. Yes po. Right now po, we're seeing less than 5% of the laboratories not being able to comply po, no, to the daily submissions. We do have 1 or 2 laboratories na minsan nakikita po namin may counting delay po sa pagsasubmit ng datos. Minsan inaabot po ng 2-3 araw na mag-submit. But these are more exceptions to the rule rather than yung usual po natin. And what we do doon po sa mga laboratories that are not complying or not reporting regularly, we ask the help of our Centers for Health Development, the DOH Regional Office, to find out bakit po nagkakadelay or bakit po hindi po nila nasasubmit agad. And Usually po after issuing them the show cause orders and identifying the reasons, they comply after naman po, ma'am.
Thank you po. And I also noticed na mostly ang case natin nasa Luzon area lang. Kaya nagwo-worry po ako. Kasi baka walang report mula galing Mindanao or sa Visayas. Kasi mostly po nasa Luzon lang yung area na meron tayong high ng cases. Kasi baka na po napag-iiwanan na natin yung Visayas and Mindanao. That's why I'm asking, gaano yung data accuracy ninyo at kung gaano kadaming nagko-comply sa inyo. Baka kasi po, akala natin safe sila, yung pala hindi.
Yes, Madam Chair, yes. The Luzon area will account for most of the cases po because most of the laboratories are here. But as presented po by Yusek Berhere a while ago, even in the Visayas and Mindanao regions, nakakakita na rin po tayo, ma'am, ng pagtaas ng kaso. In fact, yung meron na lang po tayong nakikitaan ng negative 2-week growth rate ay region 7 at 8. Subalit, yun po ay bumabagal na. Ibig sabihin, dati po ang decline ng cases nila, negative 11, ngayon po parang negative 4 na lang. So, we are seeing cases in the Visayas and Mindanao. It's just that hindi lang po kasing bilis yung pagdami ng kaso.
And then my last question is for Secretary Duque. Secretary Duque, baka po pwede nyo kaming matulungan dito sa district ko tungkol po sa aming mga CHO offices. Ano po? Kasi po, ayaw pa rin nila ng testing, using the PCR. Kunwari po, Secretary Duque, ako po ay may kasama, nagka-COVID siya dahil nilabasan siya ng symptoms. So siya lang ang ni-required na magpa-RT-PCR. Yung kasama niya po, hindi pa din. Kasi what I'm trying to tell is, yung tao is willing to take the RT-PCR. Bakit tinatanggihan ng CHO? Yun po unang question ko. Pangalawang question ko po, sasabihin ng CHO, wala ka naman symptoms eh. So you don't need to take the RT-PCR. Okay, andun na po ako. Pero sasabihin ni CHO, mag-antigen ka na lang. Alam niyo yung stress na binibigay natin dun sa tao dahil sinasabi niya na magkasama po kami. Pero ba't ayaw mo akong pansinin? Kasi wala ba akong symptoms? Kaya ayaw mo akong pansinin? I mean, yung burden na yon, yung stress na binibigay natin. And besides, when using the antigen, magbabayad din yung tao. Pangalawa po, RT-PCR, pag nag-positive siya sa antigen, RT-PCR po, ipapaulit, babayad na naman po. Sana po, Secretary Duque, tulungan nyo kami na maipaliwanag din sa aming mga City Health Office po na baka pwede rin naman na kung willing naman na yung tao na magpa-RT-PCR, at may contact talaga siya sa nagka-COVID, baka naman po pwede na magawa ng ganong solusyon. Kasi po yung karamihan po kasi lumalabas pa sa district kasi tinatanggihan dito po sa amin, sa city namin. So ang gagawin namin, lalabas kami. Paglabas po namin ng city namin, mas natatakot kami kasi lumilipat na kami sa ibang lugar. Paano po kaya yon?
Kung Mickey, that will be your last question.
Yes. That will be my last question for testing.
Salamat po, ma'am. Meron po tayong malinaw na panuntunan pagdating po sa testing. Tinatawag po natin dito risk-based testing. Kapag isang tao naging positibo at nagkaroon ng contact tracing at natukoy yung mga close contacts, dapat yung mga nakasalamuha ay i-test din para nakakasiguro po tayo kung nagkaroon po ng hawaan. At ganun pa man, kahit na mag-negative sa RT-PCR, kailangan to pa rin yung 14-day quarantine, ma'am. No? Ngayon, yun naman sa usapin ng paggamit ng antigen test, kapag nag-positive naman sa antigen test, again, based on our guidelines, okay na ho yun. Ibig sabihin yung test na yun will be already accepted as is. Ngayon, however, kung negative ang antigen test, yun po, based on our guidelines, kailangan po magkaroon ng confirmatory test using the RT-PCR. So, bigyan niyo po sa akin yung CHO at kakausapin po namin. para bigyan paalala, padalhan namin ng ating po mga guidelines para magabayan po ng tama at hindi po malagay sa alanganin ang inyo pong mga constituents.
Thank you po, Secretary Duque. Kasi po, pinagko-quarantine lang pero hindi pinagtitest. That's the big difference. Ano po? Sana po kasi sasabihin ng CHO namin, according to DOH, hindi daw, until wala kang symptoms, you don't need to take the RT-PCR. Is that right?
Yeah, okay din naman, ma'am, na tapusin yung quarantine, 14 days na kahit na hindi na mag-test, lalo na kung sa lugar na very far and few and far between ang mga testing laboratories. So pwede naman talaga yung i-quarantine at after 2 weeks, kung wala naman sintomas, after that ay pwede na pong palabasin from the quarantine.
Thank you po, Secretary Duque. Pero sana po, mabigyan din ng pansin na mabigyan sila ng test. Kasi hindi ko po alam kung ano po ba ang ano natin. Nagtitipid po ba tayo? Kasi parang maling paraan to ng pagtitipid. Kasi papagamitin mo rin naman ang antigen, magbabayad din yung tao, mag-RT-PCR, gagastos uli yung tao. So parang nadodoble lang po. Sana po, bigyan ng pansin lang. Yun lang po ang point ko. Mabigyan lang ng pansin yung mga taong gusto magpa-RT-PCR dahil may contact sila doon sa mga taong nagka-COVID para at least po mabigyan sila ng...
You will do, Your Honor.
Sec Duque, in relation to that question, I think hindi lang yung reporting and recording ang concern natin. There were reports on fake COVID-19 results. So what is the DOH response on this anomaly? Palagay ko po as last month or 2 months ago, there were reports in Boracay presenting a fake RT-PCR. And recently, may trending po in Facebook conversation. I don't know how legit yung kumalat sa Facebook na meron pong pwedeng makuha without testing. So result na ang nakukuha and they paid for 1,500 to 2,000. So it seems na meron lang silang template na ginagamit. Ano po ang ginagawa ng Department of Health on this matter?
Yeah, thank you, Madam Chair. Ang alam ko, that has been investigated, although I don't have the results right now with me, but I'm going to ask the health regulations team. Maybe Yusek Vergere might have the latest information on this with the permission of the chair. May I ask that Yusek Vergere be recognized?
Yusek Rosette? Yusek Rosette?
Yes, Madam Chair. As yesterday po, ASEC Santiago, who heads our laboratory management network, had a meeting with the PNP and the other agencies so that they can resolve this fake test results and the preponderance of these online offerings for this fake laboratory certificates. So we will be getting the information, ma'am, and we will be submitting to your office, Madam Chair.
Thank you, Yusek Rosette. Next to ask question is Kong Stella Kimbo.
Right. Thank you, Madam Chair. Magandang hapon po, Sec Duque.
Good afternoon, ma'am.
Yes, I'm just taking off from Kong Mickey's interpellation. So can you just, Sec, categorically state kung ano po ba ang DOH policy on testing? Is it true po ba? Because I heard some reports that there has been a recent change in policy where testing is now limited only to symptomatics. So can you confirm if this is correct news?
Yeah, we prioritize, no? Well, two things, no? One, kung for example, there's a overseas Filipino coming back. The policy, insofar as testing is concerned, is to do swab on the 6th day post-arrival. If the test result is negative, they will be asked to continue the remaining period of the quarantine in their PTMFs in their local government unit. But the basis for our testing is anchored on the exposure of the individual and the presence of symptoms. Kung walang symptom, ang aming pong policy ay to keep them in quarantine for 14 days. If they are symptomatic, they are tested and they are kept for 10 days, and after which they will be allowed to leave, but making sure that the last 3 days approaching the 10th day, they already are asymptomatic. So yan po ang ating policy.
So in short po, yes, testing is based on symptoms.
Yes, ma'am.
Reason for why I asked that is because tama naman po, di ba, na the confirmed number of COVID cases, the base of that is those that were PCR tested. Ibig sabihin, yesterday meron tayong 10,000 plus new COVID cases, and the base, the total set, is those that were PCR tested. Tama po?
I'm sorry, can you say that again, ma'am? Sorry, medyo my connection was just...
I'd like to understand the reporting of confirmed cases. So,
Yes.
can you confirm that the base, meaning the denominator, is all those that had PCR tests? In other words...
Yes, ma'am. Correct.
So, Sir Sec, are you aware po that many of those that are COVID positive were either antigen tested, in other words, hindi na sila nag-PCR, because, for example, there are entire families that all have COVID. They all exhibit, for example, COVID symptoms, but only one of them was actually PCR tested. Or there are certain cases where they were all confirmed using antigen tests. So that's my worry. It would seem like there's a growing number of COVID positives who were tested not on the basis of RT-PCR but rather antigen. So in which case, hindi po sila nasasama sa reporting ng confirmed cases. Is this something that you are aware of?
Yes, Your Honor. It's a gap that we recognize, and this will require a policy review as to when the antigen test results will be counted if positive. No? So this is something that is going to be addressed by the concerned office, and the RITM, which is our technical arm in terms of testing, we will get the recommendation with regard to your very well taken point. But the important thing is pagka kasi ang immediate response natin dito is to really isolate and quarantine. It doesn't stop with testing.
So, Sec, your admission of a gap is tantamount to also admitting that the numbers are underreported. Kasi hindi natin nakukuha yung nako-confirm on the basis of antigen tests, for example, or on the basis of just simple assumption. Kasi kung ang head of family ay na-PCR test at siya ay COVID, at lahat sila ay merong COVID symptoms, they just assume that they're COVID positive on the basis of their symptoms, right? So,
we have to have, Madam, sorry.
Isn't that a big concern? No? So considering that we already have a surge in new cases, but because you had agreed that there is this possibility, there's this big gap here where many of those that are positives are not PCR positives.
Yes, ma'am.
So what steps are you taking? That's one. And number two, ano sa tingin ninyo? How underreporting is?
The policy of the department is really on the RT-PCR assumed as the gold standard of testing, number one. Number two, the antigen testing, I do not have the data as to how broadly this is being used. So I need to get more study or data on the use of antigen testing. But perhaps for the more detailed response, I would like to ask Yusek Vergere to respond to this particular query with the permission of the chair.
Yes, Yusek Rosette. But Kong Stella, that will be your last question.
Siguro ma'am, i-add ko na lang po, no? Napakataas ng positivity rate, which is 18%, which may indicate na talagang we are under testing. Again, it relates to this behavior that is being observed na talagang antigen testing ang ginagamit to confirm cases. But anyway, sige po. Let's
yes. Madam Chair, yes, good afternoon po, and good afternoon, Congresswoman Stella. Yes, you are right that some of the local governments are using antigen test for them to confirm cases. But based on the guidelines of the Department of Health, antigen test can only be used as a confirmatory tool for COVID-19 if and when there are outbreaks, because there is a high prevalence in the area. Therefore, the sensitivity and specificity of this antigen test increases when there are outbreak cases in an area. So when they use it right now and they use it as confirmatory, hindi naman po sila hindi na ma-manage ng DOH. These are the cases that we classify as suspects and probable. So when you are a suspect or a probable case, these individuals, they have the COVID-related symptoms, or like for example, in a household, only one got RT-PCR and the rest antigen, sila po yung close contact na magkakaroon ng symptoms pero hindi na RT-PCR, we still count them. Pero they are part of that classification na suspects and probable sila. They are not confirmed COVID-19 cases. So yun po yung ginagawa natin. They are not reported dun sa case bulletin, but we have the numbers for that and we also manage them. So if you would observe po, even in hospitals, we'd find that there are confirmed cases and there also are confined or admitted suspects and probable cases of COVID-19.
Thank you, Yusek Rosette. I think last year, yan na po yung pinag-uusapan natin when we allow the antigen testing, yung danger of report. Danger of yung gaps natin on reporting, like validation of antigen test who tested positive and hindi naman siya naka-undergo ng RT-PCR. And then because walang symptoms, naging complacent yung isang individual, pwedeng hindi siya nag-isolate, hindi siya nag-quarantine and not even reported, no? So yun yung isang bagay siguro na dapat tingnan ng Department of Health na with 10,000 cases right now and kanina the number of antigen tests was presented, I think, by Secretary Vince Dizon. No? So ang dami nila, like millions of tests had been done. Pero ilang percent doon yung na-confirm natin through RT-PCR and how many percent of them yung hindi na na-record or na-track ng local government unit. So I think very important, USEC and SEC, no, that you look into that matter. Especially, everyone is using antigen test kasi yun ang pinaka most accessible and affordable to our constituents, no, to Filipinos. I'd like to call on Representative Lianda Bolilla next to ask question.
Madam Chair, I chatted the ComSec already that the question I'm supposed to ask has been asked already. So I give way to the next interpellator. Madam Chair, thank you.
Thank you, Kong Lianda. Last to ask question on testing, we have our Representative Carlo Zarate from the minority. You have the floor, sir.
Thank you, Madam Chair. Magandang hapon po. Dudugtungan ko na lang yung tanong din ng aking naunang mga kasamahan. Dahil ho talagang mahalaga sa pinang testing. At in fact, may relasyon ito doon din sa contact tracing. So, as mentioned by Secretary Duque, based on the interpellation of the Honorable Kimbo, they have to revisit that policy. So, alam nyo naman, hindi naman siguro bago ito. Ang usapin ng ang sabi po ninyo ay gold standard nga dapat ang RT-PCR. In fact, last year pa natin pinag-uusapan din yan, na dapat gold standard ang RT-PCR. So ngayon, even doon sa recommendation po ninyo para mag-ramp up ng testing ay dapat isali na ang antigen. So, kailan po ninyo baguhin yung policy na yan? Kasi as it is now, it appears talaga na there is an underreporting of cases, Dahil most of these cases, for example, at the House of Representatives, we do antigen tests, almost daily during my sessions. At so, yung mga nagpa-positive dito, kung hindi na siya nagpa-RT-PCR, hindi na siya mabibilang. So, yun yung first question ko doon, Madam Chair, in relation to a change of policy. Because we are looking at a surge number now, 10,000, but in reality pala, baka 20,000 ito or 30,000 or we don't know, dahil RT-PCR lang yung binasihan natin. So, can we get a reply from Secretary Duque, Madam Chair? What will going to nationalize the policy of testing?
Yes. Thank you, Madam Chair, and thank you, Kong Zarate. First, yung reporting ng cases, this is really more of a policy gap. And not an implementation gap. Because as correctly pointed out by you, Secretary, lahat naman ng mga suspects at saka mga probable cases are also being managed accordingly once they are in the quarantine. Yung antigen po, I just want to make a clarification. This is going to be used now that there is an outbreak. At ngayon pa lang yan, yung presentation po ni Secretary Vince Dizon, the testing czar, na to ramp up testing by 500,000 antigen tests is precisely to underscore that this is used during an outbreak. So hindi pa natin ito talaga ginagamit as a national government. Thank you.
So, Madam Chair, is the Secretary saying that hindi pa natin makonsider that there is already an outbreak of infections, considering that nasa 10,000 na nga tayo. We haven't reached this kind of number last year, na nasa kasagsagan tayo ng kaso ng COVID-19, Madam Chair.
I think
meron pong napakamalaking outbreak. As a matter of fact, we have reported this almost every day that this has surpassed our first outbreak in August. And continuing, ang laki ng itinaas, we have 10,000, 9,000, 10,000 yesterday, and 9,000 prior, siguro mga 4 days reporting as high as 9,000 plus. But just to reiterate, kaya po natin gagamitin ito mga testing na ito para to complement dahil nga medyo nagkukulang tayo. So we need this antigen test to complement. May I just ask that the chair recognizes the testing czar, Secretary Vince Dizon?
Yes,
Madam Chair, with the permission po of Secretary Duque. Madam Chair, I think the points po of Congresswoman Kimbo and Congressman Zarate are very valid, but maybe we can respond to them on two fronts. The first po, yung sinabi lang po ngayon ni Secretary Duque, yung pong decision po ng IATF nung nakaraang linggo lang na i-augment yung testing po natin sa NCR, Cavite, Laguna, Rizal, and Bulacan is really meant to address the current surge in the NCR plus area. Bakit po importante yung naging recommendation ng experts at ng IATF? Dahil po ngayon, ang sitwasyon po ngayon dito sa NCR Plus is ang PCR testing po ngayon ay kahit na madami na, I think NCR Plus we're hitting about 25 plus thousand, close to 30,000 a day. It's still not enough po dahil po sa inherent limitations po ng PCR testing. And there are two very important limitations po, no? Especially during a surge like this. Number one po is yung proneness po niya sa delay because of infection in the lab and infection of the personnel in the lab. Nakita din po natin to last year, no, nung nag-surge po tayo nung bandang mga August. Marami po sa mga laboratorio natin noon, lalo na sa NCR, talaga pong halos nangalahati o less than half ang naging capacity nila dahil yung mga labs po mismo ay na-infect. It's just the nature of the PCR test, no, paano siya ginagawa in the laboratory setting. Ang ikalawa po at napaka-importante, dahil po dun sa inherent limitation na yon, nagkakaroon po ng slowdown sa turnaround time, no, sa paglabas ng test, no. If for example normally lumalabas ang resulta ng hindi lalampas ng 24 hours, kapag po nagkakaroon ng ganitong surge at maraming nai-infect ng mga laboratorio, umaabot po ng 48, minsan hanggang 72 hours. This is still much better po nung nakaraan, no? Dahil nung nakaraan po, linggo po ang binibilang natin. Pero in order to manage a surge like this, napaka-importante po nung bilis ng turnaround time. So given those two issues po ngayon, no, in light of the surge, minarapat po ng mga experts natin na gumamit ng antigen. Bakit po? Dahil po ang antigen, hindi kailangan ng laboratorio para i-conduct yung test. Pwede po natin gawin yan sa point of care, sa hospital setting. Pwede po natin gawin yan sa baba, sa barangay. At ang resulta po ay mabilis ilalabas. Minuto lang po ilalabas na. Pero meron din pong guidelines ang DOH na which still require a confirmatory PCR test, especially in the case of a negative antigen test. So ano lang po to, this is really on an operational basis, yung kung saan po kami yung involved, no, with our other members of the NTF and of course Secretary Duque. Ito po yung minarapat ng IATF. Ngayon, yung second issue po is I think a more policy-oriented issue, which is the reporting. I guess the policy question po, and correctly so, as asked by Congresswoman Kimbo and Congressman Zarate, ang antigen positive ba ay dapat rini-report as a confirmed COVID-19 case? Right now po, the answer to that is no. Pag ikaw po ay nag-positive sa antigen, hindi ka po rini-report as a confirmed COVID-19 case. But ano po yan, no? This has to be decided at the policy level because of the technical nature of the question po. So we will really need to work with the experts and with the Department of Health to make this decision kung dapat po ba o hindi dapat isama sa confirmed cases ang isang antigen positive na case. I hope that helped, Madam Chair, Congressman Zarate and Congresswoman Kimbo. Thank you po.
Thank you.
May I continue, Madam? Yeah, thank you. And this brings me to my next point, no. So if there is really a parang underreporting, I'm also worried because there is now a surge in the NCR region plus, no, and the neighboring provinces. But we are also looking at an increased positivity rate in other regions, no. For example, in the Cagayan Valley region, that's a 24% positivity rate, no? So, yung sinasabi po natin ngayon, in relation to testing, we have 239 labs. At itong mga laboratory na ito ay mostly nasa NCR or nasa Luzon region. So, ang next ko na question, Madam Chair, dahil kahit last year pinanawagan na natin ito, these laboratories are private laboratories, no? Iilan lang dito yung public. So, ang panawagan natin noon na kung gusto nating malaman talaga ilan ang nagkakasakit, ilan ang infected, at paano ito matugunan, na magkaroon sana ng free mass testing, no? ay ang tindig pa rin ngayon ng IATF and even DOH, ano pa rin, expanded testing, no? Based on those na tinatawag nilang risk-based. So hindi ba sila nababahala if this will continue to be the NCR only but in the other regions dahil napakamahal ng testing ngayon, no? Ang pinakamura halimbawa sa Davao region is 5,000 if you want to get it within 24 hours, no? Kahit na yung antigen, that's 1,200. Mahal ho yun, no? So kung hindi ho libre ang testing, talagang ang ating mamamayan, matatakot silang magpa-test. And we will never know and who to trace, no? And who to isolate and who to treat. So yun po ang gusto kong malinawan sa atin pong mga official, Madam Chair.
Thank you, Kong Zarate. That will be your last question. Yusek Rosette or Secretary Duque? Can you reply to Kong Zarate's?
With your permission, I would like to request to recognize Yusek Barrere.
Yes, Madam Chair, and good afternoon, Congressman Zarate. Dun po sa tinatanong nyo, no, the rapid antigen test will be officially reported for this period that we have this increase in the number of cases, and as what Sec Vince and Secretary Duque said, it's going to be used as part of our outbreak response. As to those people or individual who doesn't have any access at all to RT-PCR, sabi nga po natin, we are trying as much as possible to have this laboratory access for everybody. But for those individuals really without access or poor access to testing, the most critical point would be, or the most critical thing that we need to do is to quarantine them. Quarantining them for 14 days and then monitoring them so that we can cut the transmission. Now, if we have access, that would be better for us. But if we do not have access, again, quarantining the person for a complete 14 days will be sufficient enough to cut the transmission.
Yusek Rosette, does that mean na hindi na kailangang mag-confirmatory? After you said kasi it will be reported as positive cases yung rapid antigen natin. So no need mag-RT-PCR sila?
Yes, ma'am. In our guidelines and based on from WHO recommendations, when there are areas with increased incidence or there are outbreaks like what we are having right now, you can use the antigen test as confirmatory already. So we do not need any RT-PCR to confirm them. But if you are going to use the rapid antigen test in areas where there are low prevalence and you use them for asymptomatics maybe or screening, you need the use of the RT-PCR for you to confirm that test.
So that's for selected areas in the Philippines like the bubble or NCR plus.
Yes, Madam. Madam Chair, we are going to use the rapid antigen test in the NCR plus bubble as has been recommended also by WHO.
Yusek, paano magre-report ang mga private facilities antigen? Do you have a process right now or a system? Kasi LGU, madali lang yan. They're reporting directly to you. But kasi nga sobrang accessible yung antigen, no? They can just buy from the suppliers and others nga are doing it kahit hindi mga skilled health workers, no, to do the swabbing. So papaano ang process natin and system on reporting?
Yes, Madam Chair. We already have an existing laboratory form, the case investigation form, which was revised and issued by DOH months ago, already included the rapid antibody test and the rapid antigen test. Unfortunately, compliance to reporting for rapid antigen test and rapid antibody test until now is still very low. So for those implementing units like hospitals who doesn't have laboratories, they still need to submit kasi every time naman po may magpapatest sa bawat laboratory o bawat hospital or maybe in the RHU, they do the case investigation forms. And this is where we are going to get these reports so that we can collate them and report them as well.
Thank you, Yusek. In relation to testing, I'd like to ask, I think napag-usapan na natin ito, Yusek, the status of saliva testing, yung validation that RITM was asked to do, yung ginagawa currently ng Philippine Red Cross. Yes, Yusek.
Madam Chair, can Secretary, are we going to call Director Celia po?
Yes, Madam Chair, I think the appropriate person to respond is Director Celia Carlos, because this is an issue with regard to the results of the validation that was done by the RITM on the use of saliva tests in lieu of oral and nasopharyngeal specimens.
Thank you, Sec. Director Celia.
Good afternoon, Madam Chair. The RITM already completed the validation of the use of saliva as a sample for PCR, and we were able to collect 1,600 plus samples with a sensitivity of about 84%, of which 250 were positive samples. The specificity was 99%, positive predictive value 95, negative predictive value 96.7, and percent agreement of 96.5. So in general, the use of saliva as a sample appears to be promising. However, there needs to be some standardization in the way the process is to be done. Like there are many methods of collecting saliva for the test. Some just drool it out, some spit. And there are different types of collecting material. So all of those need to be standardized. And there are different kits which are used for extraction, kits for PCR. The problem is many of the kits in the market are licensed for nasopharyngeal swabs or oropharyngeal swabs, but not saliva. So they have to be registered with FDA to be used for saliva, because using these kits for saliva will tantamount to off-label use. So per our country's regulations, the manufacturer has to register the kit for use as saliva. And then there has to be...
Yeah, Director, if I may cut you, when do we expect that protocols or standards to be used on saliva testing?
There has been discussions between the different agencies involved in the development of the guidelines. And as of today, the guidelines are almost final. They are being vetted by other experts in laboratory science. And in our discussions earlier, we hope to finalize the guidelines by tomorrow.
Okay. Thank you. Kindly share that guidelines to the Committee on Health, Director Carlos.
Yes, ma'am. It will be the DOH, which
Yes.
will be the source of the final guidelines.
Yes. Yusek Rosette, you mentioned to me that the only establishment allowed to, or laboratory allowed to use a saliva test is Philippine Red Cross. Am I right?
Yes, Madam Chair, for now. For now, Madam Chair.
Kasi there were, I think, mga kits, saliva kits available in the market. So, I think we need to police them, no? So, nabibili rin siya katulad ng antigen test. Okay, so at least aware ang ating mga kababayan, naka-live po tayo Facebook na hindi po ito acceptable, no? Only Philippine Red Cross ang allowed at this moment. Okay, would like to call on Representative Sara Elago.
Good afternoon. Thank you, Madam Chair. This is still related to the demand for free mass testing. Sinabi po ni Secretary Duque noong December 9, 2020 na pinaghahandaan na nila kung magkano ang kakailanganin na investment para sa free mass testing. At sinabi rin po ng DOH Secretary na ito ay isusumitin nila sa Pangulo upang mapondohan. May we get an update on this, Madam Chair?
Madam Chair, may I refer to Sec. Vince Dizon for his rejoinder.
Secretary Dizon, you have the floor.
Thank you very much, Madam Chair. Thank you, Secretary. Congresswoman Ilago, thank you very much for the question. I'm not privy to the December 9 meeting, but I will try to respond as best I can. Right now po, according to the experts advising the IATF and also based on best practices throughout the globe for COVID-19 testing, we are still convinced that the best approach is really a risk-based targeted test policy. And this is reflected currently in the current guidelines from the DOH, where there are classifications on when to test someone. And those guidelines are based on, number one, yung risk, which involve either exhibiting symptoms or direct exposure to a confirmed COVID positive patient. Meron din pong ibang mga guidelines na na-mention tulad ng screening natin po sa mga dumarating sa Pilipinas from abroad, especially guidelines naman po para sa mga area kung saan mataas po ang prevalence o ang incidence ng COVID-19 tulad po ngayon na nangyayari sa atin dito sa NCR+. But to the best of the IATF's knowledge based on the prevailing science on COVID-19 testing, risk-based targeted testing is still the best approach. Salamat po, ma'am.
Maraming salamat, Madam Chair. Ngunit nais ko rin pong linawin, kasi hindi po nasagot yung aking tanong kung napag-aralan ba kung magkano yung kakailanganin para nga sa free mass testing. Kinakailangan po ito upang matiyak din natin na napapalawak natin ang lahat ng mga pagkakataon upang gawing abot kamay at abot kaya para sa ating mga kababayan ang COVID-19 testing na napakahalaga para sa overall na strategy natin pagdating sa containment ng pandemic, prevention ng spread nito. Nagkaroon po ba ng pag-aaral? Do you have now a ballpark figure for the possible investment for free COVID-19 testing? Bukod po sa kung meron ng pag-aaral, kung magkano ito, ito po ba ay naisumite na sa Office of the President as you said in the statement last year?
If I may answer, Madam Chair, yung pong budgetary requirement, I'm still having it, I'm getting a breakdown kasi yung 10 billion, ito po kasama yung testing at saka vaccines for 2021 budget. But I'm still getting the breakdown. No? But suffice it to say that yung testing naman po ay libre dahil po cargo ng PhilHealth po ito. Babayaran po ng PhilHealth ay lahat ay sakop ng PhilHealth. So, yan po ang masasabi ko sa ngayon. Pero yung bayad naman sa PhilHealth, depende rin yan kung yung laboratory ay donated by yung kits by the national government. Otherwise, kung hindi, ang singil sa mga public laboratories aabot ng mga 3,800 pesos, 2,077 kung donated kits. No? At kung halos lahat naman gastos na ng gobyerno, ang ma-reimburse lamang ng PhilHealth ay kung di po ako nagkakamali, mga 900 pesos na lang. So ito po ang impormasyon na akin po maibibigay sa ngayon, but I'm testing needs of the country.
Thank you, Sec.
Maraming salamat, Madam Chair. Marami pong umaasa dyan sa libreng COVID-19 testing. Bagamat Sako po ng PhilHealth, no, yung testing sa ating mga public health centers. Halimbawa po sa NKTI, meron pa ring out-of-pocket expense na nasa 391 pesos. At hindi po ito biro, no, para sa ating maraming kababayan na ngayon ay humaharap din sa kawalan ng trabaho at kawalan ng mapagkakitaan. Kaya napakainam po, no, kung lubusan nating maitutulak ang libre at abot kamay na mass testing para sa lahat. Maraming salamat, Madam.
Thank you, Kong Sara. Last to ask question related to testing is Deputy Speaker Bernadette Herrera D. You have the floor, DS.
Thank you very much, Madam Chair. Actually, very quick question because I had an incident last week wherein meron tayong mga OFWs na hindi sila na-test on time. So, na-stock sila doon sa hotel room nila for like additional 5 days. So, ang concern ko dito, ang sabi, nagka-glitch daw yung Red Cross or una puno yung Red Cross and all that. So, how do we address that? Because we're paying for the accommodation of the OFWs. They were about 15 OFWs stuck in that hotel because nagka-glitch yung testing daw of Red Cross. Now, my question is, number one, wala ba tayong maraming testing centers that can accommodate all our OFWs coming in? Number two, paano pag nagka-glitch? Do we just allow the testing centers to, get out of that? Considering we pay for the accommodations, the food, and everything of the OFWs, and these are like 15 pa lang to, dun sa one case na nakausap ko, and they were stuck there for an additional 5 days.
Madam Chair, Testing Czar can very well give his rejoinder on this particular issue.
Kong BH, magandang hapon po. Ma'am, unang-una po, totoo po yun, nagkaroon po talaga ng problema ang Red Cross. Nung nakaraang linggo, there was a outbreak in the port area laboratory of the Red Cross. Ang nangyari po dito talaga is medyo na-delay. Hindi lang po yung sa OFWs, kundi pati yung testing po sa ibang area sa in order to process them faster. And in response to that, when
this happens, and then bakit ang dami naman ng labs then who can produce in a few hours yung resulta? So bakit hindi ka agad napalitan ito? And it took that quite a number of days bago pa magawa ng paraan ang bagay na ito. I actually had to call their attention bago.
Opo, ma'am. It's really it was a very difficult time last week, no, when kasi po ang right now po the OWA has a agreement with the Red Cross whereby they're the ones processing the OFW specimens kasi nga po sila lang po yung may malaking capacity to do so. But
yes, please, and the liabilities, of course, the testing centers also should carry some liability dito sa bagay na ito. I know that we're helping each other. Kaya lang pag hindi rin tayo nagiging efficient, government resources are suffering.
Opo. Well taken po and completely understand po, ma'am. It's just that we are also experiencing some issues with payments to Red Cross for these specimens by the PhilHealth. So kami po ni Secretary Duque and Secretary Galvez, we're trying really to manage all the compounding issues involving this, no. So, but ma'am, you're absolutely correct po, and we will look into possible kung ano po ang pwedeng magawa ng mga testing centers para naman medyo maano naman po yung ating mga OFWs. Salamat po, ma'am.
I look forward to that because syempre yung OFWs bilang lang yung araw nila makasama ang pamilya nila dito eh. Tapos pag uuwi pa sila, masastuck pa sila ng matagal sa hotel, hindi natin sila natutulungan. So thank you for that. I hope you can address that. That's all, Madam Chair. I just wanted to bring that up for our OFWs.
Maraming salamat po, ma'am. Thank you po.
Thank you. Yes, thank you, Secretary Dizon. I would like to remind everyone that our flow of discussion is by topics, no? So we're done with testing. Next is on contact tracing, and then next will be On management and treatment, we'll discuss hospital capacity, human resource, and drugs. Kasi I've been reading some comments in Facebook. They thought some of the guests, like Dr. Landrito and other experts, were not given the floor to speak up. No, so we will call you later on when we discuss the ivermectin portion para po dun sa ating mga guests. Then, the medical center chiefs that we've invited will ask you to speak up later on when we discuss on the hospital capacity. So, please stay with us. We'll now call on Representative Carlos Zarate, the first to ask question related to contact tracing. You have the floor, Representative Zarate.
It's very unfortunate, Madam Chair, na sinabi kanina ni Mayor Magalong na practically, technically, walang nangyayaring contact tracing, no? Dahil yun ngang contact tracing efficiency rate, for example, in National Capital Region ay nasa 1:7 lang, no? Or at the average sa buo is 1:7 to as low as 1:3. The ideal supposedly is 1:37, no? If it's in urban centers, and 1:35, I think, if nasa rural area. So at this point, Madam Chair, no, dahil merong sa tingin ko may nexus talaga yung mass testing and contact tracing, no, in the numbers that we are looking at now. Kung ilan ba talaga yung nagkakasakit at ilan yung dapat i-isolate. So meron namang binanggit kanina si Mayor Magalong na mga way forward, no? But ang nakita ho natin pinaka main problem dito is yung walang uniform, no, way of tracing yung possible infected persons and the persons na meron na sila in contact with, no? Plus, of course, yung sinabi po ninyong kanina na problem doon sa data collection and encoding. So, ano po ang bibigyan ng priority rito, Madam Chair, no, Mayor Magalong, in the light of these surging cases, no, of COVID-19 cases now?
Can I request? Okay, thank you po. Maraming salamat, Madam Chair, Your Honor. First thing is we need to capacitate again our local government units. Isa po yan. Uulitin na naman ho natin, hoping against hope, na ikakaskade naman ho sana ng ating mga local government sa kanilang mga munisipyo. And at the same time, for the local chief executives to finally, decide that they should be kasi iba ho talaga pag leadership driven ng contact tracing. Mas naiinganyo yung mga subordinates po na mag-contact trace, and at the same time, they're well supported. Nandyan din yung kanilang mga technical tools, tulad ng kanilang mga computers. At the same time, yung mga software, although yung mga software binibigay natin ng libre. Second is yung gusto natin hong paigtingin at sana mapatakbo na natin yung ating digital contact tracing mobile application. And I'm referring to Stay Safe. After finally resolving it, after so many months, finally, naayos na po yung ating mga gusot dito. Certain issues na pinag-awayan po ng iba't ibang mga ahensya pagdating po sa digital contact tracing application.
Salamat po, Mayor Magalong, Madam Chair. But certainly, Mayor Magalong, you will agree na itong surge ngayon, for example, these 10,000 plus cases, no? Hindi lang posibleng mas marami pa ito dahil nga ang ating contact tracing efficiency rate ay nasa 1.3 lang, 1:3, no? So ibig sabihin napakarami nung hindi natin na-trace at posibleng yun sila ay mga positive din sa COVID-19 and naging spreader din yun, no? Not only in the NCR but in some other regions. Pwede po bang maging ganun ang sitwasyon na kung hindi talaga masusolusyonan itong pag-increase ng ating contact tracing efficiency, Madam Chair?
Okay, Madam Chair, Your Honor, totoo po yan. Totoo po yan. Kung noon po siguro nung mga original version ng ating COVID-19 virus is 1:4 o 1:3. Bawat isa, 3 yung nai-infect niya. Ngayon mas marami na, siguro 1:7, 1:8. There was even an instance na nakita namin, umabot pa nga ho ng 1:15 ang isang particular na case. So kung ang mga local government units nakafocus lang dun sa kanilang 1:4, in short, household lang, after that, wala nang gagawin. Yung ating mga contact tracer, they won't go beyond the first generation. Then ibig sabihin, marami tayong hindi pa nako-contact trace, marami pang close contacts that are roaming around, potentially infecting other people, and the local government unit do not know anything about it. Let us say, for example, dapat ang kukunin niya sana for this particular day, she has 3 cases. Sa 3 cases, dapat ang average natin na dapat nakuha, assuming na hindi na natin kaya yung 1:37, let us say 1:20. So 3 cases, at least 60 people, 60 close contacts. Pero tinan nyo yung difference naman. Out of the 60 close contacts, ang nako-contact trace mo lang is 12. O let us say 15, 1:5 ka na lang. So in short, you're looking at 45 people that are unaccounted, roaming around the streets, potentially infecting other people. Assuming that yung 45 close contacts, ang positivity rate natin is 10. Ibig sabihin, 4.4 people roaming around the streets, potentially infecting other people. Sa isang araw lang yan. Gawin natin 10 days siya. Ganyan lagi ang threat. So 4 times 10, that's 40 people in 10 days, potentially infecting other people.
Thank you, Mayor Magalong. So that's yun po yung sinasabi natin, no, yung connection, nexus between mass testing and serious contact tracing, no? Kahit nag-test ka ng marami, kung wala namang serious contact tracing, Madam Chair, no? Itong surge ngayon na nangyayari sa National Capital Region and nearby provinces will potentially happen in other regions, no? So dahil kung ganun din na hindi pala pinatutupad, no? And dahil kung maalala ko, Madam Chair, no, nag-allocate tayo ng pondo rito for the hiring of contact tracers. Malaking pondo 'yon. Tapos it turns out ngayon ang report ng ating contact tracing chart, wala palang nangyari doon, no? Practically, walang contact tracing na nangyari. So dapat po siguro talagang kung mag-ramp up man ng testing, ay seryosohin itong problema sa contact tracing, Madam Chair.
Ang Zarate, just want to remind you that will be your last question.
Yes, Madam Chair. I'm just wrapping up and I just want to get a response from Mayor Magalong.
Mayor Magalong?
Hindi ko kasi pwedeng i-dichotomize natin. Iba lang yung testing, tapos yung contact tracing. Bahala na rin siya sa contact tracing, no? Dahil magkaugnay ito lahat, Madam Chair.
Mayor Magalong?
Your Honor, thank you, Madam Chair. Your Honor, hindi naman siguro tama ho yung wala hong ginawa. Marami ho tayong ginawa. Marami ho nagawa rin yung local government units. There was even a time na umakyat to. Kung titignan nyo ibang local government units, they were doing, iba sa kanila, they were doing 1:40. Yung iba, kaya lang, mas maraming gumagawa ng mababa ng contact tracing. Kaya it pulls down the entire cumulative na contact tracing ratio. Pero marami hong rason. Unang-una ho, dati ho 50,000 tayo. Ngayon ho, dahil because of budgetary constraint, bumagsak na lang ho. 70% out, 30% na lang. That reflects 15,000 na lang na contact tracers. So na-overwhelm ho ang ating mga contact tracers. So isang contact tracer, ang dating hinahawakan niya 2. Ngayong araw na to, na-achieve niya yung 2. Tomorrow, tinamaan siya ng 5, nadagdagan ng 5. Ang na-accomplish lang niya 3, so meron na siyang 2 kagad na. The following day, meron siyang 6. So nagpa-pile up lahat. So nakikita nyo, ang daming 0-0 na close contacts dahil overwhelmed nga yung daily number of cases. Alam niyo, kasi isa rin is probably intentional. No? This is what I observe sa ibang mga local government units, intentional, cheating, dribbling, probably are the most appropriate words. You know? Sometimes what they do is, they make sure na, ito kasi nangyari, lalabas ho sila sa media, lalabas ho sila sa news, na mataas yung kanilang mataas ang kanilang kaso. Naalarma sila, nagpapanik sila. Siguro it impacts their economy, impacts their industry, especially yung tourism. So ang gagawin nila, mag-uusap sila ng local ng health officer nila, magsasabihin nila medyo easy tayo ng konti sa testing at sa contact tracing. So with low contact tracing, low testing, then low cases ka. Sulat ka na lang na after 1 week, bababa ka agad ng cases mo. That is impossible, no? Kung consistent ka sa testing, consistent ka sa contact tracing, it takes some time para bababa yung cases mo. In fact ho, kung ano yung nakikita ho nating situation ngayon, biglang lumabas ho yung data, 100 cases today. Yun po yung case na yan, it reflects the situation 10 to 15 days ago. Ganun po yung impact, yung kanyan, yung consequence niyan.
Mayor,
2 days ago pa ho.
on the resolution of our speaker, Resolution 168, and the House of Representatives voted to adopt that resolution of having a single unified system on contact tracing. And you mentioned on moving forward regarding the Stay Safe Philippines, no? When do you expect to resolve the issues between the DILG, DOH, and the ICT so that we will be able to use that system?
Okay, Madam Chair, it is already resolved. It was resolved.
Okay. Good to hear.
Safe to DILG instead of DOH na donate na po sa DILG. So ang arrangement po, magkakaroon po ng memorandum of agreement on the maintenance. And second po is the ICT will cover the subscription po through its existing Amazon account. And then at the same time, moving forward, baka magkakaroon na po siya ng exposure notification na rin na feature. Kasi ho ngayon, as of today, ang Stay Safe lang ho, parang logbook lang yan. Para lang ho kayong pagpupunta ko kayo sa isang establishment, nagsusulat ho kayo pati ihuhulog nyo yung piece of paper. Ganun lang po yung functionality.
Yung data repository natin, saan yan? Supposed to be dapat sa Department of Health. Since nasa DILG, how do we link the data collection or yung storage ng ating data to Department of Health?
Well, the reason why it was donated to DILG because ma'am, DILG is the lead agency in contact tracing. So sila rin po mag-handle nung storage po yan, yung database, a certain program dyan po sa CDRS, there's a system sa DOH, ang tawag po dyan CDRS. Diyan po nire-record po sir, nire-record yung lahat ng mga cases, positive cases ini-input dyan. And at the same time, yung ibang mga essential na features po ng COVID kaya, inadapt po ng CDRS. So yung CDRS po, nakalink po yan sa Stay Safe. Kaya kung ano po yung lumabas na positive patient sa CDRS, nalalaman po kagad yan. Pwedeng madaling i-retrieve po yan ng Stay Safe. Yun po yung link na yan. Yung dalawang system po yan.
I think we've invited from ULAP. Do we have Governor Kuwa? Or anyone from League of Municipalities or DILG? Governor Velasco?
Yeah. Yeah.
Yes, sir. You have the floor since DILG and the LGU na po ang gagamit and hopefully lahat po ng local government units natin will use the staysafe.ph platform no on contact tracing. Ano pong thought ninyo dito sa current development? Finally, we'll be able to use that.
Well, we welcome that, Madam Chair. And since it's a directive coming from the IATF, then we are supposed to follow that. And we welcome a unified system. So whatever systems we are using for contact tracing will just be integrated in the Stay Safe system, Madam Chair.
Thank you, Governor Velasco. Mayor Magalong, how do we compel LGU to use that data collection tool? No? Kasi you mentioned kanina, isa yon sa challenges ninyo.
Okay, last year po, nagkaroon na po ng memorandum circular ang DILG requiring all local government units to adopt Stay Safe as an officially recognized contact tracing application. After that po, medyo mahina po yung response ng local government unit. December last year, I talked personally to Yusek Bernie Flores to reiterate it. To reiterate it. So, ang nangyari niyan is January 3, nagkaroon na naman ng reiteration. Alam niyo, nung September, when we launched Stay Safe, maabot lang ho ng 800,000 ang kanyang subscribers. Nung January, nung ni-launch nung ni-reiterate po natin to 8 million. Madam Chair.
Thank you, Mayor Magalong. Next to ask question, Representative Franz Castro from the minority. You have the floor, Kong Franz.
Yeah, thank you, Madam Chair. So most of the questions naman po natanong niyo na po ni Kong Zarate about contact tracing. So gusto ko lang pong malaman very curious lang ako halimbawa at Madam Chair and Mayor Magalong. So how does contact tracing work? Halimbawa po pumunta ka sa isang store, nagsulat ka doon ng contact tracing. So ito po ba dinadala agad nila sa DOH? So gaano po kabilis yung pagta-transmit noong mga written na mga...
Tingnan nyo, to be honest with you, talaga hong walang relevance po yung papel na yun. Kung itatago ka ng establishment, which is the usual case. Andun lang ho yan sa establishment. So,
okay.
Dapat ho talagang ang mga establishment natin, they stay safe QR code.
Okay.
Assuming na yung local government has its own digital contact tracing application because last year, meron naman mga LGU na nag-develop ng kanilang sariling digital contact tracing application at nag-gain ito ng traction. Then what we ordered was that they should integrate their system into Stay Safe or with Stay Safe. Tulad do sa Baguio, we have our own pero integrated po sa Stay Safe.
Okay. So mukhang kayo lang po, Mayor Magalong, yung ganon siguro, yung inyong mga establishment ay naka-link doon sa Stay Safe. So karamihan siguro ng mga cities and municipalities ay hindi. Pero yung sa amin halimbawa
naman,
sa Valenzuela.
Madam Chair, Your Honor, marami rin pong naka-comply.
Marami rin, okay. So marami rin siya naka-comply. So yung last question ko, 10,000 related ito sa kakulangan ng test and contact tracing.
Yeah, isa rin po yan sa reason kung bakit tumaas po yung ating kaso is kung hindi ho na-contact trace yung mga close contacts, syempre they have been roaming around. They're just roaming around the streets, potentially infecting.
So, yes.
Yun po yung
di ba? So, ideally, Mayor Magalong, Madam Chair, yung 10,016 natin sa ideal na 37 ang mako-contact trace, dapat may 370,000 tayo. Di ba? Na maka-contact trace based dun sa ideal. So, ilan po ba yung na-contact natin from the, halimbawa sa 10,000 na ito, meron ba kayong data?
I'm sorry,
wala.
I don't have any data,
okay.
Your Honor.
Sige. Okay, thank you, Madam Chair. Yun na lang po. Thank you po, Mayor Magalong.
Thank you, Kong Franz. Now we'll go to the discussion on management and treatment. We'll start with the hospital quarantine isolation capacity and their current status right that we've invited so that our members will be aware of the current status. I think we have the Philippine Heart Center Director, Dr. Joel Abanilla. Director Joel?
Yes, I'm here.
Briefly lang, if you can share the current status po ng Heart Center, si Director po has been forwarding me every now and then the status ng operation of Heart Center. So mas maganda po siguro na marinig from you kasi we are live on Facebook po.
Thank you, Your Honor, for this opportunity. Now, I would like to inform the House of Representatives that we are mandated by the government to reserve 30% of our bed capacity to COVID. But we would like to inform you that we are now having 56% of our bed capacity that is occupied by COVID. Our ICU, COVID now reserved for our heart patients are scared, no, and not so many come to us. So some of these wards that they are occupying of having symptoms, and I cannot admit center, and they have to wait also at the emergency room, and they have to make balasa. Kasi initially he was placed in a cohort room, now until a private room was made available to them. So it is that bad, no, for hospitals here in Metro Manila. I think the same is true with most other hospitals in the area.
Dr. Gap?
Good evening, Madam Chair. Good afternoon, Madam Chair. Thank you for giving us this opportunity to share what's happening here in PGH. I guess all center chiefs will be saying the same thing, but specifically for PGH, we're a 1,500 bed hospital. But because of the health protocol guidelines for patient distancing, we are now around 805 implementing beds. And of this, we have allotted 270 already for our beds. That accounts for almost 50% of the bed allocation that we have for COVID. And we are still trying to open up more wards. Currently, our census is 235. We are limited by infrastructure problems such as oxygen ports and availability of the areas, proper areas for taking care of ICU patients. The status of our patients is that around 35% are in severe and critical condition. In fact, in the wards of PGH, we allot around 4 to 5 beds as ICU beds, meaning patients are on respirators in the wards, just to extend our ICU capability, because our 20-bed ICU has been all filled up. So we are extending more, around 12 beds for ICU care. There are 12 patients in the ER who are COVID. 6 of them are on respirators, and we are waiting for patients to go home so that we can bring in patients. The healthcare status has improved because of the early implementation of contact tracing and isolation, and maintaining the health protocols that we have mapped out for our healthcare workers. They're starting to come back now. We've had a total of 315 healthcare workers who got infected. Fortunately, only 4 were severe, and most were mild or moderate. So, but none got intubated. No one passed away. We will increase our bed capacity by another 25 beds in the next week or so, if the number of patients continue to come up.
Thank you, Dr. Gap. Salamat po for sharing that. I'd like to call on Director Dr. Vincent Balanag of the Lung Center of the Philippines.
Good afternoon to everyone. Thank you for giving us the opportunity, Congressman Helen Tan. So I think it's the same situation for the Lung Center. At the start of January, we were having just 20 COVID patients with 70 beds available. But right now, we are already 115 COVID cases, and we're practically 100% full already, and a lot of patients waiting at the ER, usually 10 to 15, waiting for their chance to be admitted in the hospital. And waiting can take anywhere from 1 day to 3 days. So that's right now the situation. In terms of facilities, we have enough ventilators and high flow nasal cannulas. There are problems in terms of the medications for COVID, like remdesivir, but it's fortunate that we had our new delivery for this. But we have run out of tocilizumab, and I think that's the big problem for all hospitals at this point. No, there's also an increase in the number of our staff getting COVID, and the level is now the same as what we had during the spike last August 2020. No? But we are fortunate to be able to do routine testing of our staff, both COVID and non-COVID, every 2 weeks, and for our non-clinical staff, every 4 weeks. And most of those identified as positive are usually asymptomatic and just isolated, and fortunately, none have a serious condition. We had a total of 209 staff having COVID, but most of these right now are already recovered with one death. In terms of vaccination, we have 85% acceptance of our vaccines. We have received supply for Sinovac and AstraZeneca, and we've already started the second dose of the Sinovac for our staff. That's all. Thank you very much.
Thank you, Director. I'd like to call on the Director of NKTI, Director Rosemary Liquete.
Good afternoon, everyone. Thank you for calling me. I think the situation in all the specialty hospitals are the same, except, or maybe we are more affected because we are a transplant center and we have immunocompromised patients. We have dedicated 106 beds actually for COVID, and we are full, more than that. And then with the full capacity of these dedicated beds, we still have 54 patients waiting in the emergency room. And this of these 54, 33 of them have come out positive already. So where do we put them except at the emergency room? We have the ER extension, you know, the history of our tents. The tents, nalalagas na po lahat yung marami doon. So we have been swabbing also. We have been swabbing all our patients' admissions and also their bantay, because some bantay also become positive. Now we are swabbing all of the employees, and every day we get like 5 to 10 employees being positive. Overall, we had already 188 healthcare workers positive. If we add the 10 today, it's already 190. We also do swabbing of our hemodialysis patients. You know, we have 64 stations, and we cater like 240 a day patients. And then now we are getting like 10% of this, hindi pa kompleto, no? But we are getting now 10% of these dialysis patients are positive, asymptomatic positive. So we are now cohorting our hemodialysis patients as to how to put them, how to place them like last shift, or we cannot dedicate another hemodialysis area for them. We actually have, but it's already full. We are waiting for the facility at the formerly Pearl's Garden to open up maybe later this April, and that would be 20 stations to be dedicated for COVID. What Congressman pay of our patients. The Department of Health had a cap for government hospital to charge 3.
Director, I think nawala po si Director. We'll call her again later. Next, I'd like to call on the Director of East Avenue, we have, I'm sorry, Jose Reyes, Dr. Emmanuel Montana, Jr.
Secretary of the different departments. I made a presentation po I submitted.
Director, kindly make it quick, no? Concise po yung report ninyo.
Yes. For the hospitals, for the testing, we have molecular, it was not mentioned, but we have a molecular gene expert. We can do that 30 tests a day, and we had it starting January 25, 2021. As of now, the Jose Reyes is a different hospital for unlike PGH Lung Center, that they are COVID dedicated hospital. We are catering to both COVID and non-COVID cases. So for the testing, we have test rate is 7.69%. The negative is 92.31. For the vaccination, we have a big acceptance for our employees. We have vaccinated 98.2% of our employees as of now. For Jose Reyes, we have isolation facilities that would be opened April 8th. This is the DOH, Quezon Institute Modular Hospital Facility, which is 98 bed capacity for moderate cases and 10 hospital bed for severe and critical case. This will be equipped with advanced critical care equipment and both supported by Jose Reyes Memorial Medical Center staff and employees. We will also have the isolation facility, the Quezon Institute also, community quarantine at 48 bed. The proposal for Jose Reyes would be to use this as an isolation facility for COVID positive cases and make Jose Reyes as a non-COVID hospital to cater to patients, because we may be able to forget those patients who are cancer cases, those who have emergencies, and they get worse because we are now looking into COVID cases and we might forget. We should have a hospital specifically for them. After Jose Reyes Memorial Medical Center also is the National Center for Geriatric Health, which will cover our geriatric patients. For issues on healthcare workers, we have a growing number of positive in isolation and exposed that are now in quarantine. Isolation for healthcare workers even competes for hospital beds for mild to critical. The sick includes not only the frontline services, but also the support staff. But if we cannot take care of the support staff, some of our services are really affected. Number of applicants with the surge of the COVID is decreasing. There's also the issue on the promotion of nurses. So the human resource, at present we have 41 current active cases of healthcare, but most of them are now recovering. So for our therapeutics, the diagnosis intervention, the point of care tests and other issues for equipments is still on procurement problems. The procurement issues for the medicine is the continuing availability. It is out of stock and you want to go to another supplier, you have to apply again for a compassionate special permit per company for a particular generic drug. And due to the sudden surge of patients, there are problems also in the procurement delays and the stocks. And so we also have hemoperfusion cartridges, the problem with the cartridges, because it's not only the price, but the cartridges, we need 4 per patient. So for pulmonary support, we have high flow oxygen, ventilators, BiPAP, and as of now, some of the supply issues for the needed use for them. And with that, I would like to thank you, Madam Chair, in behalf of Jose Reyes Memorial Medical Center.
Thank you, Director. I'd like to call back Director Rosemary Liquete. Yes.
Yes, sorry for that. So I was talking about the 391 of the copay of the patients. The Department of Health has a cap for government, 3,800. But I think for private hospital, like 5,000. But then 5,800. So the patient has to pay 391. Actually, that's a minuscule amount because upon computation, we ought to charge the patient like 4,500 because we have no donated machines and we procure our kits. In the early part of the COVID, yes, we were able to get some donations of the kits, but recently or even thereafter, we all bought our own kits. So the machines are ours, no? We have no machine donation. I want our Kongs to appreciate that our patients at NKTI, they need highly intense management. They are on dialysis. They have so many comorbidities. Thus, the admissions, their length of stay is definitely longer than any of the hospitals. So maybe comparing to heart center, ours is much longer. So we have a very poor discharge rate because they're all long playing. Thus, we cannot really discharge our COVID patients right away. They still have to continue their dialysis like 2 to 3 times. So they stay with us. So I appeal to our NCR patients also to help us with our dialysis patients. Yes, with success, sometimes we can transfer some of them to Tala because they have lots of dialysis machines. But then with the influx now of patients, of dialysis patients, do not accept them anymore if they are positive. So that's our dilemma. So thank you very much.
Thank you, Director. I'd like to call on the Director of East Avenue, Dr. Alfonso Nunez.
Members of your committee and all the government representatives. For East Avenue Medical Center, East Avenue Medical Center, during the lull periods of the COVID pandemic, we established a serried building which is able to house around 250 beds on top of the non-COVID beds that are available in our hospital. That numbers around 600. We were also able to operationalize during that lull time a molecular laboratory to increase our testing capability of not only of our patients, but also of our health workers. And during this time also, we have collaborated with non-government organizations and government organizations to acquire protective and life-saving equipment. And this we have prepared during the lull period, during the additional manpower for our COVID areas. At the moment, out of the most of these patients are of the severe and critical type. Our ICU beds at the moment are 93% utilized, and our assigned critical and severe beds, these are beds outside the regular and standard ICU area, they are already 97% utilized. Isolation wards and isolation rooms are 83.7% utilized for an average total of 87.2% utilization. Our life-saving equipment are still okay. Our mechanical ventilators are 47.5% utilized, and our life-saving high-flow nasal cannula is 51.7% utilized. And this is comfortable, and we have additional stocks available in our hospital. As to our healthcare workers, from the start of the pandemic, East Avenue Medical Center had a total of 527 healthcare workers that has been infected by the COVID-19 virus. And we have now 151 active cases, while 373 has recovered. We have actually 5 deaths related to COVID-19. We want to report that all active cases, 100% are mild to asymptomatic. We have actually experience an increase with the healthcare worker rate of infection together with the rate of infection of patients in the community. Now, some of our issues and challenges, well, we still have patients waiting at the emergency room, numbering anywhere from 30 to 40 patients. And we are to comply with the IATF resolution number 104, increasing our capacity from what we are having right now of 43%. We want to increase this to 50%. And we are utilizing and maximizing the One Hospital Command Center to transfer patients from our hospital to other referral treatment centers that can house mild and asymptomatic patients. But one of the challenges is that these patients do not want to transfer to these treatment and quarantine facilities. Also, as part of our step-up contingency plan, we are in the process of constructing an additional 15-bed ICU for COVID-19 patients. We are now cohorting patients to increase bed capacity and in order to accommodate more patients. We are now expanding our COVID ER area to accommodate more patients. This expansion would entail an additional 20 to 30 patients that can be handled in the emergency room. We have requested actually extension and support for our contractual healthcare workers, and this was readily granted by the Department of Health. We have also requested manpower augmentation from other regions, and as of yesterday, we have augmentation coming from the region of Pangasinan and from Batangas, helping our agency in the fight against the COVID-19. Right now, we are converting our basketball area for quarantine of our healthcare workers, and we are now contracting hotels for quarantine of our healthcare workers. We want to increase our capacity for testing, and these are currently remdesivir and hemoperfusion cartridges, because we have found out that hemoperfusion is one effective management tool or method that can save lives. And we are now continuing with our vaccination program. We have so far vaccinated 78.2% of our healthcare workers, and we are continuing with our second dose. We started yesterday until today, and we plan to finish the second dose until next week. Thank you, Madam Chair.
Thank you, Director Nunez. Preside.
Good afternoon, Madam Chair. Good afternoon to all honorable committee members and to our colleagues in government. I come from Quirino Memorial Medical Center. I'm the medical center chief, and I would like to express very similar sentiments from other hospitals as well who have been managing COVID-19 patients. We are very similar in terms of patient mix to Jose Reyes Memorial Medical Center and also to East Avenue Medical Center, in the sense that we are not a truly COVID dedicated hospital. We are we respond to even non-COVID cases. We have also tried very hard to expand our COVID-related beds from an initial 30% to as much as 50% of our bed capacity. Unfortunately, due to lack of space, this can be very difficult, especially because we have to distance our beds as well. So we cannot really comply with the number of our usual number of licensed beds. Right now, we have also had challenges in securing vital medications for COVID-19, such as tocilizumab and remdesivir. These are medications that are in short supply right now, or either short or zero stock in the local environment. So it has been difficult for us to manage our patients appropriately. Our patient mix right now, predominantly we have a census of long-staying patients that are mostly stroke patients. And those are stroke patients that are very difficult to step down to the TTMFs because many of them need a lot of care and cannot do self-care on their own. And therefore, they are not qualified to these step-down units. So they stay with us and they keep our beds. We also have several elderly patients with several comorbidities that we also take care of. And because of our reputation as a maternity hospital, we also have several pregnant COVID-positive mothers who deliver, and we cannot also step down these patients to the TTMFs because they of course, due to this situation. Right now, we have one of the largest emergency rooms in the country. Unfortunately, we still see a lot of patients congesting our ER. At any given day, we have also an average of 30 to 50 ER waiting patients, almost 20 of them to almost 30 to 50% of these patients waiting in the ER are actually COVID-positive patients. For our healthcare workers, we are increasingly using this isolation facility as our healthcare workers have also increased in number in terms of COVID positivity. Right now, we have 54 active cases among our staff. And counting from the start of the pandemic, we've had more than 300 of our own staff down with COVID-19. But most of them, if not all of them, except for the ones active now, have recovered already. We are in the process of completing the rest of the floors of our multi-story building. Bayanihan and ADB have provided funding for the completion of 50-bed ICU and a 60-bed ward for COVID-19 patients. And I hope we can catch up so that we can serve more patients. Thank you very much.
From Rizal Medical Center, the OIC Medical Center Chief.
Blessed afternoon, Madam Chair, and to the members of the House of Representatives. For our census as of today, we have dedicated 117 of our bed capacity to COVID. Currently, we have 10 patients with COVID awaiting admission and 7 non-COVID cases. We have gene expert that we use to confirm for our patients, and for our healthcare workers, the RT-PCR is done by the Red Cross, and that's once a week. For one of our strategies is that we have limited admission of non-COVID cases, and also we have limited our operations to extreme emergencies and malignancies. We have hired additional 59 healthcare workers as funding provided by the DOH. With regards to vaccination, we have vaccinated 79% of our healthcare workers, and we are continuing the vaccination for the second dose of Sinovac. With regards to medicines, we have received 5 million sub-allotment, as mentioned by Yusek Vega earlier, to procure the remdesivir and tocilizumab. For equipment, we have high nasal flow systems, but only limited in number. We also have mechanical ventilators and BiPAP.
Okay, we can now proceed on the questions of from the following members. We have Kong Miki Violago. Do we still have Kong Miki? If none, Kong Stella Kimbo.
Thank you, Chair. Sec Duque. I spent almost the entire day last Sunday, I and my staff. We kept calling the one hospital command center because we were trying to look for 2 beds because 2 of our constituents felt like they really needed hospitalization. But none of us was able to successfully talk to anyone. So either busy or wala pong sumasagot. Are you aware po of this?
May I, with the permission of the chair, for Yusek Bong Vega, who heads the One Hospital Command Center, to respond to this query.
But Sec, have you heard of this complaint, Sec?
Oh yes, in fact, I have already brought this to the attention of the One Hospital Command, to which I was told that they really, and I think they are in the process now of expanding their capacity in terms of managing more calls, because they've gone up from, I think, 30, 40 calls to about 350 calls per day. So maybe the Yusek Vega can give us the progress that has been made to address precisely this very serious concern that you have raised. So with the permission of the chair, Yusek Bong Vega, please be recognized.
Madam Chair, can I be recognized to answer the query of Representative Ma'am Kimbo, Honorable Kimbo?
Yes, please proceed, User Kavek.
Yes, that is a very valid complaint, ma'am. In fact, when we started off with the One Hospital Command last year, and we set ourselves in the MMDA complex, we wanted to make sure that we will have a very good coordinated care, especially among COVID patients and the referrals. At that time, we were only receiving 66 to 70 calls per day. But apparently, when the surge happened this few weeks ago, we were receiving as much as 388 calls. And the numbers that we have posted to the public is that we don't have any kind of forward calls towards other units, because our setup, hospital command, by making sure that we have the necessary personnel and IT and call agents, and we've started to organize subscription to a PLDT for more sophisticated telecommunications. I do note, ma'am, that hospital command.
So as of Sunday, how many personnel does this command center have?
We have 15, ma'am, right now working on 24/7, but we have augmented this already to about 30. But the problem really is not with the personnel, but rather on the number of telephone lines that we have. You see, ma'am, once you call the Globe or the PLDT number, if it keeps on ringing, it means that really we are noting this kind of setbacks in terms of the trap calls. So we are trying to improve this by making sure that we have more landlines and a PABX system to have a call forwarding towards the different agents who are...
Same excuse. But please, Sec, po, ano po ang nawalan na ako ng gana kumain or hindi na ako makahinga? Hindi ako makatawag sa command center ng DOH. Sa mga hospitals na nasa paligid ko, tila puno. Anong payo ninyo sa akin, Sec?
Sorry, Sec Duque. It's for the secretary?
Yes, it's for the secretary.
Sorry.
Yes, thank you. The process, Sec Stella, is to have a functional barangay health emergency response team. And they're supposed to process all these referrals. So we need to really ramp up the capacities of these birds. Alam niyo naman po ito, yung birds ay sila po ang nakatutulong sa navigation ng ating pong mga pasyente.
Sorry pasensya na. Ang tanong ko personal, magkaibigan na tayo matagal na, 2 decades na, Sec. Kailangan ko ng hospital ngayon, wala akong mapuntahan, ano ang payo ninyo sa akin? Kasi halimbawa, bigyan ko po kayo ng example. I was able to talk to Dr. Amy of Amang. Wala po siyang mabigay sa akin na solution. When I was telling her about the 2 beds that I needed, sabi niya, wala talaga ako mabigay sa'yo. Then sabi niya, why don't you call this number? It was only forwarded to me. Meron pong home service So is that something, halimbawa, that you would recommend? Ngayon may kumakalat na gano'n na service. Pero ngayon, iniisip ko naman, how do I know that those are legit doctors, etc.? Hindi ba maganda na kung tinanggap na natin talaga na kulang ang capacity halimbawa dito sa NCR, ano ang alternatives? So halimbawa A, meron bang sistema ng referral to home service? And then B, halimbawa, pwede na tayong gumawa ng makeshift hospitals. Baka naman pwede na tayong mag-upgrade ng mga isolation centers, di ba? At katulad ng ginawa ng Italy and some European countries na talagang makeshift hospitals na talaga ang tinayo nila. Or number 3, hindi po ba there are some private sector companies halimbawa that actually have clinics with beds? So are these, are these private sector facilities, can they be actually tapped? So yung tatlong yon, can you comment on those na ano bang pinag-iisipan ninyo na mga possibilities na mabilis nang sa ganon ma-expand ang ating capacity na mabilisan? So ulitin ko po, referral system for home service. Number 2, is it time to have makeshift hospitals? For example, upgrade isolation centers. Or 3, can we tap into private sector facilities, whether in companies
purposes? But ang percent ang severe. So for a total of about 1,600 of the active cases of about 115,000 thereabouts. So every time I call up, even the president of the Private Hospital Association, di ko alam kung andyan siya, he can confirm this, si Dr. De Grano, about 93% mild, asymptomatic na mga pasyente. So if we allow this, talagang mabibilaukan. That's why the One Hospital Command Center, and that's why in the time that we really ramped up our capacities, but talagang mga mangyayari sa ramping up namin kung lahat ng mga mild, pupunta lahat make sure that the birds are functional. They cannot just be token birds, and nice on paper. Pero kaya kailangan talaga dito po talagang importance of the referral system. That's why ito talaga pinalalakas po natin.
So hindi po ba, Sec, with all due respect, nasa kamay niyo naman po yan, di ba? Kasi hindi ba, bakit yung tinatanggap ng ospital, hindi ba at your end, that's something po that you can address.
Yes, ma'am. Tama po kayo. We will do that. First and foremost is to really do capacity building for our One Hospital Command. And then number 2, yung pong sinabi nyo na modular hospitals, as a pipeline na yan. And I think the USEC Bongmega can give you an update of how many modular hospitals are being set up. And this is done in coordination with Sec Mark Villar, DPWH. Sec Bong, with the permission of the chair, baka naman pwede po nga sabihin ninyo kung ilan ito mga modular hospitals about to open already this April. Thank you, Madam Chair.
Sandali lang po. Question na lang po, pwede.
One last question kung Stella.
Sec, pwede bang humingi ng more categorical answer dun sa tanong ko? Desperado na po ako. Hypothetical COVID positive. Mag-home service na ba ako? Kasi itong mga nababasa ko na nag-o-offer pa ng home service, ang offer doon, all-in, etc., 300,000 naka-indicate doon. Ano ang payo ninyo sa akin? Bilang kaibigan, is this something that you would recommend?
Yung meron po kayong naman doktor, hindi ba? So the professional advice of the doctor has to be heeded, no? So you can discuss that with your physician. Meron naman mga ibang LGUs, I understand, have already resorted to telemedicine. So that telemedicine, I think QC is somewhat ahead, no, in terms of the maturity of their telemedicine system. So I won't be surprised if the Marikina LGU might have already started with telemedicine of their own.
So,
nakakatulong po yan.
The home service is not frowned upon. Tama po ba?
Para sa akin, ensure that only those severe critical cases are accepted or admitted. Kasi talagang that to me is the underlying problem of overwhelmed health systems capacity. And the One Hospital Command Center is doing its best to address this referral systems. We really have to get that's the real objective. And we are working towards that, ma'am. Thank you po.
Thank you, Kong Stella. Before I recognize Yusek Vega, I share the sentiment of Kong Stella calling the One Hospital Command. I think na-heads up ko na po ang DOH on that based on my personal experience then, no? Medyo to tap on the private hospitals or clinics, especially in the ground, so that we can utilize their services, no? But I also agree with Secretary Duque on patient navigation should start from the local government unit, no? Ako, based on my experience, patients who are at home or in the district and provincial hospitals, siguro lang we want to units and compel them to follow the proper referral system kasi most of the patients talaga pag sinabi na hindi nila kaya, walang capability ang hospital, burden ng patient to find another hospital where to go. So wala talagang nag-a-assist sa kanya. Actually, yan yung isa na benefit should be doon sa universal healthcare law natin. But kailangan talagang paigtingin sa local government unit po yung tamang pagkalinga at pagmamalasakit sa pasyente. At ituro sa kanila papaano gawin yon. Kasi marami po mga government hospitals sa local, hindi talaga po nagna-navigate. I can attest to that. Araw-araw po yan na aking kinikater eh. So siguro lang dahil hindi alam ng pasyente saan pupunta, kaya nangyayari po ito, no? And the One Hospital Command should be a good platform po, no, to attend our patients na walang matatawagan, but maybe you need to strengthen that. So moving forward, siguro hindi naman kayang lahat i-accommodate ng Department of Health. I know, no. In fact, devolved po ang health, no. Naka-devolve supposed to be, mas strengthened dapat sa ground. Siguro lang ay to follow ano talaga yung dapat ginagawa nila, function at this time. We're talking on COVID patients lang ngayon, but what about the non-COVID patients? Yun yung, I think, malaking problema natin ngayon. We have available isolation facilities. Kanina sa presentation ni Sec Villar, he said there were like 23,000 isolation facilities already built. And we have like ICU infrastructures or facilities soon to open. Can we hear from anyone, from Yusek Vega or Secretary Mark or any?
Chair.
Yes, Yusek Bong. Additional question, are you considering at least at the regional level magkaroon tayo ng command center also?
Yes, ma'am. That's what we are trying to do right now. Specifically because we have seen the rise in the number of admissions and referrals here in NCR. And we actually already set up the regional One Hospital Command in Region 3 and Region 4. And this is also the pathway that we can do coordinated care and referral to these regions. So at the moment, we are also planning to set up one in Cebu and in Davao to make sure that we are all connected. But the IT infrastructure that we should have must be upgraded so that we will have a better telecommunications.
Thank you, Yusek. Do you have dashboard right now monitoring yung capacities?
Yes, ma'am. The op center that we have in MMDA, we have a dashboard. We can actually see all the hospitals at a granular level, even down to the provinces, the beds, the occupancy, and some of the TTMFs that are being used and are not used. So we do have a dashboard, ma'am.
Yusek, kasama po ang private hospitals doon. Are they required to submit real time yung available and occupied beds nila?
Yes, ma'am. All public and private hospitals, they're mandated with their own data managers to make sure that they encode the daily, every 4 hours at this time, the current and timely updating of their occupancy and vacancy. So both public and private, they do it, ma'am. And we have the dashboard on there.
Okay, thank you, Yusek Vega. Next to ask question is DSBH. DS Bernadette Herrera D. Do we still have DS? DS?
Yes, yes. Yes, hello.
You have the floor po.
Yeah, thank you.
Hospital capacity and isolation quarantine.
No, okay na ko, DS, na Share Helen, na-present naman kanina ni, I received kasi information na maraming available na quarantine facilities, but it was presented kanina na hindi. Possible, yun nga yung sinasabi ni Stella, I also received the same message na with an ambulance, tapos parang a 300,000, complete facility na siya. Can we also do this sa DOH? Parang, di ba, we give mobile dental laboratories, we give mobile clinics. Can we do a mobile COVID facility na pwede nating iparada or pwedeng meron para lang may mapuntahan yung ating mga pasyente?
Mobile hospitals. I don't know if our director for health facility expansion program is on board, Director Gorgolon, or if Yusek Bong can perhaps respond to the possible setting up of mobile hospitals. Yusek Bong, alam ko meron na, but I don't know to what extent.
I think Director Gorgolon is on board.
Madam Chair, can I be recognized to do a rejoinder?
Please proceed, Yusek Vega.
Yes, ma'am. The query on the mobile hospitals, I think since last year, we have worked with the Department of DPWH through Secretary Mark Villar that we need to come up with expansion of health facilities. And one way of doing this was putting up a field modular hospital. And the first field modular hospital that we did that was operational, it was in Lung Center. This is a 44-bed field modular hospital capable of handling moderate and severe cases because this has actually an oxygen delivery line and with a negative pressure with vacuum. So definitely it's not mobile, but we can actually dismantle this and set it up in another place. In other words, that's the concept because this is a fast kind of construction, 45 days, and we have that. So we were able to conceptualize that last year. We operated Lung Center this year by January, and then Tala came by the end of March. We were able to operationalize it. That's another 44-bed field modular hospital. And the third is we are going to open up the expansion again of this field modular hospital in QI, which is actually 110. But if Manette was saying kanina 98 based on the number of beds that he has right now. So the fourth would be in Batangas right now. They're going to inaugurate this in middle of April. So in other words, since of last year, we already conceived and conceptualized that there is a need in terms of the expansion of the health facilities, and we had to do it fast. And this is the reason why we're coming up with this kind of facilities in Region 3 and of course in the NCR. And there are proposals to put up more in Lung Center and another proposal to put up more beds in QI. These are non-mobile, it's kind of fixed, but it can be dismantled and restructured in another place, ma'am.
Well, the reason I'm asking that is that we have several dental vans na binigay natin sa mga LGUs. We have several, hindi ba pwedeng i-convert yan temporarily? Like itong kumakalat na text that Stella was saying is that we have home service for COVID treatment, ambulance with 5 nurses, oxygen, fully equipped with ventilator machine, plus dextrose and antibiotics. Yung mga bagay bang ito, is it something that DOH can explore? Kasi kung maraming mga sasakyan na ganyan, dahil katulad kahapon, kagabi sa Quezon City General Hospital, I was trying na may ipasok akong pasyente doon. Kaso sinasabi nga yung tent 2 is puno na and they have 12 ambulances na may COVID patients na rin. So is this something that we can explore? Kasi marami tayong mga ganyang sasakyang available. Baka pwede naman siya i-convert na yung maging COVID treatment siya.
We have actually we're using the dental van as more of the laboratory use, and of course for an outpatient use, but never as a hospital based, wherein you have to treat moderate and severe, because it's kind of critical in terms of the usage of power and everything. No? So we've been using the dental van, ma'am, for diagnostic purposes. You can put an X-ray machine there, you can put a laboratory equipment, and you can put an X-ray and make use of that, and also as an ambulance. So that's the most that we can do for the dental vans.
I see. Oh, I'm just asking kung ano yung pwede pa natin. Basta we have to think of more innovative ways to address this. And sana nga kung mas marami pa tayong modular na mas maliliit or container vans that you can transfer. Sana we can do more of that kasi kulang na kulang talaga. Like right now, I have another patient na hindi ko mahanapan. Baka meron mga medical directors dito who can accommodate one patient na kailangan daw ng ICU, please, nung ating hotline. So yun lang. So please explore all possibilities of having more modular hospitals. Thank you.
Yes, ma'am.
Thank you, Sec Vega DS. I think Director Abanilla from Heart Center wanted to comment on the lack of hospital rooms or beds. Director Abanilla.
Yes. This is a very big concern right now. I can understand the worry of Congresswoman Kimbo and Herrera and everyone else. In fact, we have been fighting this battle of having vacancy in the last week. Hirap talaga, no? Maawa ka na lang. But as laid out by Dean, I think yung mga mobile na all this modular prefab, mabilis nila gawin yan eh. Just in a matter of days. Of course, you will have also the issue there of healthcare. Well, augmentation na yan ng DOH. Also, we have suggested that maybe some hospital can temporarily be converted as purely COVID dedicated to have available rooms. I know it's really a quandary where to bring patient who is serious. I have something to say about yung pauwiin. It's not easy as that. Easier said than done, but a lot of agree with. Hirap na hirap kami magpauwi sa kanila. No? So and there are those that can quickly or rapidly deteriorate. No, so we do test on them. So if there are borderline, if they're in question, we hold them. Maybe we do our inflammatory markers, our chest X-ray, or CT to see if these are the patients who will most likely deteriorate. So we need to hold them. But that's just the issue lang of availability of rooms. What is the fastest way to provide? I think in the right track na ang DOH. Bong, that idea, Bong, just pursue that. I think that is really the solution.
Thank you, Director Abanilla. I would like to hear from, I think we have the spokesperson and PRO of Private Hospital Association of the Philippines, Attorney Jihan Natividad. Share with us. Attorney Natividad. From P Happy. Are you with us? Attorney. Anyway, we'll call her again. Last question is Representative Bong Suntay. Chair Bong.
Yes, Madam Chair, clarification lang. Because earlier, dun sa report, sinabi, sa NCR raw, ang total bed utilization is 66%. Pero from our experience, gaya sa amin sa Quezon City, most of the hospitals that we call on, pagka kailangan namin ng na yung hospital. So, which is occupied na.
Yusek Bong. Yusek Vega.
Yes, yes, ma'am. Madam Chair, can I be recognized to answer the query of Rep. Honorable Bong Suntay?
Please proceed, sir.
Honorable Bong, if you notice the 66%, that is an aggregate number of the HCUR, meaning to say beds of the level 1, beds of the level 2 hospitals, and beds of the level 3. This is also together with the number of ventilators and the number of ICU beds. So when we say that you have an HCUR of 66%, it means that this is an aggregate use of aggregate this, and you say the level 3 hospitals, that's where it's practically different. Because when you say level 3 hospitals, these are the big hospitals that we have in government and in the private sectors. We are seeing a high risk category here, especially with the level 3 hospitals. And with the ICU, it is also very high. It's also high risk. So in other words, when you try to disaggregate the numbers of the HCUR and focus on mainly on level 1 or level 2, medyo may lugar, there are spaces for occupancy. But when you say level 3, and these are the bigger hospitals, that's where we have problems in terms of the vacancies, because it is high risk. So that is the way we actually present this metrics of the HCUR.
Okay, now our predicament is a lot of our constituents would call on to us and ask for help na meron mga pasyente sa mga different barangays na kailangan madala sa hospital. Where can we get real-time data to know kung saan hospital namin sila pwedeng dalhin? Because we feel so helpless as the families ng mga COVID infected patients na hindi namin sila matulungan at hindi namin alam kung saan sila padadala eh.
Yes, sir.
So where can we have real-time data?
Yes, sir. The real-time data that we have right now is the One Hospital Command, because the main objective really of the One Hospital Command is to make sure that we can have a coordinated care in this pandemic, which actually started last year. But with this present surge that we have, we are adjusting to this and making sure that we will be able to serve the public more by doing more.
But Yusek Bong, the problem with yung One Hospital Command natin is I share the same experiences as Kong Stella. You know, we try to call it, pero sobra talagang hirap to get through the line.
I share your predicament, sir. Talagang sorry talaga, sir. At this time, it's a surge. We are overwhelmed. Kasi dati noon, 66 calls, 100 calls, kaya ho namin. But when the calls were receiving, because of the number of cases actually doubled than August of 2020. So we had to adjust there. And we are doing this by making sure that we are able to get the appropriate persons to man our facilities, mga call center agents, and the necessary IT connectivity po, so that we will have a better kind of connection with the regional One Hospital Command and the different hospitals around. Ang hirap po kasi we are just using 3 numbers, and these 3 numbers are both PLDT and Globe, and it's always busy because the agents are engaged. So I'm terribly sorry for this, sir. This kind of predicament, we're really sorting this out with the Department of Health.
So Yusek Bong, when can we get an improvement on the services of yung one hospital?
Soon as, sir,
the
once
changes that you're saying.
Yes, as soon as, sir, once we will get the necessary personnel for call for us agents and making sure that they are able to receive the calls. And once PLDT can upgrade our systems with the PABX and connections with all the different hospitals around. So ito yung upgrade po namin, sir, sa IT kasi mano-mano pa tayo kami sa MMDA po. So we're
ano katagal ho yun? Because if it's PLDT, can someone from the DOH coordinate with PLDT for the urgency of having more lines? Tapos yung sinabi nyo nga, adding more personnel. Can Secretary Duque provide additional personnel? Dahil importante ho ito eh.
We're providing now, sir. We're actually screening the personnel now. And we have already sent our request to procurement at the Department of Health. And once the contract will be signed by the procurement, then the PLDT comes along. So the earlier it can be done, the better it will be, sir.
Madam Chair, last question. Baka we could get an answer from yung procurement ng DOH kung kailan nila pipirmahan.
Or that, as early as the Admin and Finance Management Office is processing all of this, and we can sign it anytime.
Okay. Sige, Madam Chair, thank you very much.
What would be your last question?
Thank you, Rep. Bong. Thank you.
Yusek Vega, ang DICT po ba tinutulungan kayo? Setting up like a call center na yung One Hospital Command?
Yes, ma'am. In fact, we have already asked DICT to connect our fiber optics with them. But we are based in MMDA. And the fiber optics of DICT is across the MRT line. So it took time for us to make sure that we get the necessary permit for DICT to connect their lines with the lines of MMDA because it's on the other side of the MRT track. But we already got the permission of course, the MRT and the different concessionaires of the MRT that we will cross the fiber optics towards MMDA. We're now in the process of doing that, ma'am.
But your manpower cell phones na pwedeng ma-access kasi yun din USEC yung pinaka-accessible. And
yes,
then from the province, sir, platform na ginagamit nga nila, Facebook eh. Mas mabilis sa kanila nagme-message sa Messenger. So we can use other platforms pa.
Yes, ma'am. Once we will have the PLDT upgrade, we can do messaging through Facebook or other social media.
But Yusek, kailan po ang target ninyo na?
Because that is the demand of the public. But the limitations is that we need to have the access from PLDT and the hiring of new personnel. But as soon as we do this,
I hope the expanding services po ninyo.
Salamat po, ma'am.
Maraming salamat, Yusek. Next to ask question is from the minority, Representative Ferdinand Gaite.
Patungkol sa treatment, ito specific po to sa problema sa PhilHealth.
Kong Gaite, we're discussing, Kong Gaite, we'll discuss that after.
Treatment and capacity.
Yung atin pong flow of discussion, sineperate po namin siya. So last part will be the drugs will not only talk on ivermectin but all other related treatments. So we just want to focus right now yung issues on hospital capacity, and next is the human resource. Then we'll go to drugs. We'll just call you again na lang po.
Opo, pero concern pa rin po ito sa problema nga sa hospitals,
okay,
yung charging ng PhilHealth. Kasi nga po, related pa rin sa hospitals because apparently, pag ikaw ay nailagay pala sa tents, hindi charge sa PhilHealth. So, nagkasakit ka na at nagka-problema ka na, tapos yung temporary facilities, I'm mentioning a case raised by a colleague na nagka-problema sila na nahirapan na nga sila sa pagpapagamot, ganap ng hospital, although this is in the private hospitals. And ang isa naging problem nila is that when they were being charged, the PhilHealth did not cover the temporary tents that were provided waiting for a room to be assigned. I would like to know if that is also the policy in the government hospitals, because that is an additional burden on the part of our families who have to cope not only with the health problem but also with the financial burden. So yun lang po yung concern sa una, Madam Chair.
Madam Chair, can I have the PhilHealth representative to answer the very important points raised by Kong Gaite?
Sino pong nandito sa PhilHealth? Anyone from PhilHealth?
Who do we have?
Ma'am Neri? Ma'am Flor Marasigan.
Tsaka, ka-half day lang Wednesday.
Ma'am Mel Marasigan.
Sure kung matapos ng...
Or Mel Mabagos.
Andun pa, pwede ko naman siya i-present next week. Okay. I mean, kung may time kami sa April na, doon na lang. Okay.
From PhilHealth.
Okay naman na yun. You can, may gagastusin ba kami dyan?
From PhilHealth. Yes. Can we have Ma'am Neri?
I was not able to get the question. May I know the question?
Kong Gaite, can you repeat your query? He's talking about the coverage of PhilHealth for those admitted in the tents.
Yes, Madam Chair. Capacity ay punong-puno na rin. Pansamantalang nilagay muna sila sa mga tents. And when they were built out, apparently PhilHealth does not cover the expense. Medyo malaki rin. Accordingly, 1,000 pesos per hour. 1,000 pesos, 1,000 pesos per hour ang singil nila. Sabi nga, daig pa raw sa ICU. And worse, it's not covered by the PhilHealth. Kasi I don't know, the policy of PhilHealth, only policy of the PhilHealth.
Mary, please respond.
Hello, yes, Madam Chair, I was muted earlier. Kasi po hindi po accredited itong mga tents po.
Ma'am Neri?
Yes. Yes, can you hear me po?
Yeah, we can hear you clearly.
Laksan ka naman po. Yung po, sa ngayon po, hindi po accredited po kasi yung mga tents at wala po standards for that sa ngayon. So, hindi po talaga siya mako-cover yung nasa tents po. Pagka po, napasok na po sa hospital, tsaka lang po i-cover.
Madam Chair.
Yes.
Hindi ba dapat i-revisit nila yung policy na yan? Kasi nga po, hindi na nga nila kasalanan. Parang nga naghihintay na nga sila sa ICU, waiting for a room to be hopefully admitted. But apparently, hindi kino-cover ng PhilHealth. Sabi ko kanina, hihirapan na nga yung mga pasyente because of the health conditions. Then we aggravate the situation by imposing such policies that will negate the benefit they would have gotten from the PhilHealth. I don't know, hindi marok ng aking pag-iisip bakit hindi maisama kahit yung expense na yan.
Yes, thank you po, Congressman. Madam Chair, may I clarify po? Can you hear me po? Hello?
Go ahead, Ma'am Neri.
Yes, opo. Bali po nasa temporary lang sila, di ba po? Na part ng hospital. Ganun po ba yun? Tapos po, eventually, they will be admitted into the hospital. Confined na rin po within the hospital. So,
Madam Chair, that is not the case. When they were billed out, hindi sinama yung expense doon sa waiting nila sa tent. Na sinabi, according to my colleague, umabot ang 140,000 overnight pa lang because of the stay in the tent. And unfortunately, again, this was not covered under the PhilHealth benefit package.
Yes, Madam Chair. Opo. Baka, sige po, I agree naman po kay Congressman na siguro i-revisit na lang namin kasi sa ngayon, hindi po siya part ng pathway or protocol na kasama dun sa package. Pero kung tutuusin po kasi, it's a package rate. So supposed to be yung temporary treatment sa temporary facility na part din ng hospital should be part of the package. Pero po, yun nga, siguro we can revisit na lang po yung policy and yung package para po makonsider itong temporary treatment.
Raised. When we put up temporary hospitals, does that mean they won't also be covered?
Madam Chair, may I po? Ang assumption po, doon sa temporary hospitals, well, assuming na they will get accredited or that temporary hospital is part of a hospital which is already accredited, ang assumption po, if they will be treated in a temporary hospital and they will get the complete care of the COVID treatment, then they will be paid po. So that's yun po yung understanding ko.
Madam Chair, can I just comment straight to this hospital just to make sure that other than the policy
Yes, Madam Chair, we will do that.
Please, so that we can have it addressed immediately, because I cannot countenance a 1,000 peso per hour charge, 2,000 pesos per hour. So if you're there for 8 hours, that's 8,000. Ay, hindi ho tama yan. And meron po tayong benefit package ng PhilHealth. And we have already upgraded these benefit packages to be inclusive of the different level of accommodation. Ano? So kung nag-aantay sila, kailangan bayaran ng PhilHealth. We will have that revisited, Madam Chair.
Okay, you have your time. I think, Kong Gaite, your time is up.
Yes. Yung urgency, alam ko na. But of course, the next problem is how to pay for all these treatments. And I hope that also be considered in our deliberation. Salamat, Madam Chair.
Thank you, Kong Gaite. I think Dr. Liquete from NKTI would like to speak on that coverage of PhilHealth, those patients who are admitted in the... Do we still have Director Liquete? Director? Okay, if none, I'd like to call on...
Yeah, I'm back na.
Yes, Director, you were...
Yes, we have lots of patients in the tents. Sometimes they just die there, no? We have a makeshift ICU, and we have the satellite OR with the COVID. So I don't know, baka ma-return to the hospital din naman, return to hospital then. It happens, no? And
so,
also,
hindi talaga kino-cover ng PhilHealth yung patients?
Hindi pa namin yun kasi baka ma-return to hospital yon. We have lots of return to hospital.
Anyway, the chair of the board ng PhilHealth naman ay si Secretary. Baka lang po pwedeng ma-review, Secretary, within sa board ninyo, no? Parang mali din naman.
I'm going to have this reviewed tomorrow, starting tomorrow.
Thank you, Sec. Okay, next question is if Rep. Sara is not on board, we can call on Representative Franz Castro. I think she has questions on human resource.
Yes, thank you, Madam Chair. Pa-update lang ako, Madam Chair, doon sa mga kailangan nating mga health workers. Kasi when we had the hearing long time ago, siguro last year, October or September, more than 1,000 yung na-hire. And then yung update ni Yusik Vega, parang more than 1,000 pa rin yung na-hire natin ng mga health care workers. So, ganun kaliit, Madam Chair, with the span of almost half a year. So, ganun kaliit yung na-hire natin for our health workers. Ano po kuya ang dahilan aside from no takers? Meron pa po ba kayang dahilan? O paano po kaya mag-move on tayo? Kasi yung number of beds, kahit na gaano man karami yan or gaano karami yung mga natin facilities sa hospital, kung wala naman po tayong mga health workers, ano naman po yun, di ba? So, paano po kaya tayo makakapag-move doon, Secretary, doon sa ating mga human resource na mga health workers? Madam Chair.
Tama po kayo, Madam Congresswoman, Madam Chair. Kinakailangan magkaakibat po ang ating expansion ng healthcare capacity at saka ang health worker density. Magkasama po talaga yan dahil useless naman po kung wala yung isa. So, yan naman po ay tinutugunan ng inyo pong Department of Health at ang Admin and Finance Management Office ang namamahala po sa pag-hire ng ating karagdagan human resource for health workers either for our own increasing demand or for augmentation to the other hospitals na talagang maraming dahilan kung bakit nababawasan ng mga healthcare workers. Yung iba nagkakasakit, yung iba kina-quarantine, ina-isolate. So mag-aantay ngayon ng 2 linggo bago mag-recover. At also yung mga iba din po, ang mga magulang, ayaw na silang pagtuluyin dahil po sa takot na magkaroon ng COVID exposure. So mga desisyon ng pamilya na hindi naman po natin kayang makontrol. Pero ganun pa man ay alam po ng ating DOH Admin and Finance at tinutugunan po ito ngayon. We will just give you a report of the number of healthcare workers that have been hired.
Thank you, Sec.
Madam Chair, isang question na lang po. Madam Chair, na-resolve na po ba natin yung sa sweldo po ng Nurse 1, yung atin pong problema doon sa kanilang nirereklamo na yung iba po na demote, Nurse 2 na dapat, Nurse 3, na-resolve na po ba natin yung mga kasong ganun?
Ang alam ko po na resolve na, but si Yusek Bon Vega or Asek Romy Ong can please respond to the query.
Yusek Vega. Yusek Vega or Yusek Vega. Anyway, Kong Franz will call him later, no?
Madam Chair, can you hear me? Can you hear me now? I was just unmuted.
Yes po, please proceed.
Okay. Tungkol ho doon sa problemang sa nurses po, we already went to DBM to make sure that there is no there is no demotion or there is no contraction of the number of positions. So we have already with DBM Secretary Wendell Avisado to be sure that the Nurse 2 with Nurse 1 is almost similar. We gave them a proposition, ma'am, that the Nurse 1 and the Nurse 2 must be different in terms of their salary grade, and we are awaiting for their response box. So our position is that we don't want to contract the Nurse 1 to Nurse 6 as they have proposed, and we have proposed that the Nurse 2 will be given a higher salary grade than the Nurse 1.
Thank you, Yusek Vega. Okay na, Kong Franz? We'd like to thank you, Kong Franz. We'd like to call on Representative Ruth Mariano Hernandez, our Vice Chair. Kong Ruth?
Yes, Madam Chair.
Yes.
Hi, Madam Chair. Yes, good afternoon. Good afternoon to everyone. Madam Chair, actually, this is a request to Secretary Duque. Because in the province of Laguna po, we have a COVID hospital here designated by our governor, the San Pablo District Hospital. So I would like to request the good secretary if you could help us find additional manpower for our hospital, because right now we have exhausted the possibility of looking for additional manpower through Facebook and other sorts of using social media to find additional manpower, but to no avail, Secretary. So we're asking for your help if the OH can supply additional manpower or additional health workers for our designated COVID hospital for the province of Laguna, which is the San Pablo District Hospital. Because right now, all our hospital is full, Secretary, and we are thankful to DOH because you helped us with our equipments and facilities. I was told na binigyan po kami ng mga hospital beds, ventilators, approved naman yung request namin, and even the patient monitor system we are given na. Kaya lang po, yun po yung problema namin, additional manpower, kasi outside the hospital, kung wala po kaming additional manpower and additional health workers, Secretary Duque. Thank you, Madam Chair.
Maraming salamat, Kong, Ruth, and Madam Chair. Yes, I think Yusek Bong can answer that in terms of interim measures to augment the human resource for health requirement of certain LGUs where there are available facilities pa, no, or beds, pero wala lang mga tatao. So, Yusek Bong, meron kasi tayong programa. You might want to elaborate on that sa augmentation.
Yes, Ma'am Ruth, no, we can actually give you the necessary, the DOH can give you the necessary augmentation for your healthcare workers. You just write us your need, and then the region of region 3, region of the CHD will validate this number of personnel that you're requesting, and we will just download the amount that is, or the budget needed for the human resource augmentation. So it's that easy, ma'am.
Thank you. Thank you very much. Thank you, Madam Chair. Thank you very much. That's all. Thank you.
Thank you, Vice Chair Ruth. Sec Duque, the House of Representatives has already passed the proposed Medical Reserve Corps on third and final reading. So it is now pending in the Senate. Hypothetical question, sir. Suppose we pass this into law right at this very moment. Do you think there's a need to deploy MRC at this point?
Can the Medical Reserve Corps are already licensed physicians, Madam Chair?
Yes, sir. But doon po sa list namin, order of list, the license, meron din po, isinama din po namin graduates of. So which means hindi po license, the retired one, or those who are not practicing actively in the health facilities, like, for example, nurses working in the banks or call centers, and all allied health medical professionals.
In principle, ma'am, we support naman that. I think, we supported it, no? Yung inyo pong panukala. But where to actually assign them is really going to be a function of what level of competencies these people possess, and they have to be matched to what particular functions need to be carried out. So we will do a parang staffing pattern. We will see a surge of COVID cases. Any additional manpower is always welcome. So tignan po namin yung profile ng cadre of this medical reserve corps, and I'm sure, I have no doubt, we will be able to find a place for them to optimize their competencies.
Thank you, Sec. We will now proceed on, I think, the most awaited topic for today's hearing. No?
That's it.
Okay.
It will be nice.
Okay, thank you.
Very hot ang debate, no, ng ating mga medical professionals, patient groups, and other stakeholders on the treatments, no?
Thank you.
Bye-bye.
Bye-bye po, Sir Jerry.
Can you mute? Okay. On ivermectin, the Chinese medicine, which is the Lingua Qinwen, remdesivir, dexamethasone, and plasma, no? Hindi lang yung availability, access, but of course yung affordability, no? Kasi nagbabari yung prices po, like ng remdesivir, tocilizumab, no, from private hospitals and government hospitals. So I think yung issues on regulating the prices of these medicines, like hospitals ng DOH, also vary yung prices po nila. So before I call on the first interpellator, I think there's a request from one of the guests, 17 congressman who wanted to ask questions on this issue. Kindly
Yes.
make a brief presentation, sir.
Okay, let me open the PowerPoint then.
Can you please introduce yourself po, and
Okay.
from what organization or facility you are attached?
Okay. Good afternoon, distinguished ladies and gentlemen. I am Dr. Alan Landrito. I graduated from De La Salle University in 1991. So I am in 30 years in practice. Recently, I have been working for the government. I was employed in the City Health Department of Muntinlupa. I just resigned voluntarily last Friday. But during the whole pandemic, I was working for the City Health Government of Muntinlupa. I've been on the front line. And I'm now with the group called Concerned Doctors and Citizens of the Philippines. I have an experience handling patients on COVID. I will discuss it through my Zoom. Okay, let me first have the presentation, the PowerPoint. I'll go through this fast. No? Can I have the first slide, please?
Sir, did you provide us your presentation?
Yes, I provided already. Harold, is it provided?
Dr. Alan to share his presentation.
So I will be discussing on ivermectin.
While waiting, sir, can you just proceed and discuss?
Okay. Now we are having all-time high in Metro Manila, in NCR, and also in Bulacan, Cavite, Laguna, and Rizal. But before that, if you can remember, way back February, it was Davao. No, why now the Davao? I think that 2 weeks ago it's only 350 a day, and now I think it's 150 a day. You know why? It was intensified that I provided Davao with ivermectin. So the numbers really went down. No, it may be attributed to that. It may be attributed to many other things. No, and one thing I've been hearing all the things that went from the beginning until now. There has been lots of proposal on, increasing augmentation on modular hospitals, on procurement of medicines, and all these ECQs and all this. These are all appreciable. These are all
difficult task to do. And one thing I will tell, if we keep doing the same things over and over again, even augmenting it, are we going to expect to get a different result, or we will get the same result? No. So what I'm saying is, what in corollary with the Honorable Senate President Tito Soto said in the Senate on February 22, after he was able to talk to us, we should be looking into preventive and cure. No. So that's why we have experience on ivermectin. I will show you. Can I have the first slide? Now, we have already this figure, US number 131 million, and the Philippines is 731 with 13,000 deaths. I showed you this one to show you what we have for China and for South Korea. China was number 1 during the pandemic, and expectedly, had they have not controlled and contained the pandemic, they're the most populous country. They would have an exploded number, but now they only have 90,000. And comparing that with US has 31 million. What is that number, diba, in comparison? The same way with South Korea, they have only 102 total cases and only 1,700 deaths. In Philippines alone, we have 13,000. You can see the numbers, no? These numbers are telling us there is really prevention and cure. And China is using chloroquine sulfate, the antimalarial, and it's doing good. And South Korea is using hydroxychloroquine. It's also doing good. And in a way, they have already contained, and maybe there are no lockdowns anywhere in their country. Maybe the face mask is not even necessary with those kinds of numbers. No. So what I'm saying is, why don't we use this more effective, more efficient, and almost no side effect agent called ivermectin, and look what other countries have achieved using this. Next slide, please. Here is ivermectin. It's a macrocyclic lactone. It's a natural product. It is coming from a certain bacteria. They were able to isolate it, and then they discovered this bacteria is giving off this ivermectin to protect itself from other viruses, from other bacteria, from fungi, even from parasites. So it's a protective mechanism by this bacteria, and they were able to isolate it. It was way back in 1975. Now it's turning out to be something that will have its usefulness for this COVID-19 today. Next slide, please. So it was discovered in 1975 by a doctor from Japan, Dr. Satoshi Omura. His intention was to look for a medicine that will serve humanity. No? He partnered early on with Dr. William Campbell. They tried to discover whatever properties this byproduct of an isolate, which they called later on a streptomyces vermiculus, and the product is ivermectin. And so soon, as a matter of ethics, you have to do experimentation first on animals before on humans. So already early on, they were able to find that it produces early on products, corresponding human products. No. In 1995, because it has been proven to be a very potent anti-parasitic agent, the World Health Organization itself initiated this program called APOC, African Program for Unconscious Control. It was a 100-year scourge that these African countries in Africa, 19 countries, they were getting blind because of particular parasite that is being introduced by a bat of a black fly that thrives on rivers. Near rivers. No, that's why it's called the river blindness disease. And soon enough, when they started this, they gave people massively, without selection, everyone were given ivermectin. So that is how safe it has become, just so they can eradicate it. And for 20 years, it's been given to them. And soon enough, in 2015, the whole 100-year scourge was eradicated. It was declared eradicated. And so 2015, Dr. Satoshi Omura and William Campbell won the Nobel Prize. This is the most prestigious prize one can ever get. That's a Nobel Prize in medicine, in medicine and physiology in 2015. But even earlier before that, ivermectin was researched as an antiviral agent. It has so potent property against dengue 1, 2, 3, 4, Zika, chikungunya. I will show you the list later on. And even SARS-CoV-2. It is the best antiviral agent there is. No? And then, so what makes it so good for humans is because it has a zero impact on human biochemistry. You can give it to hypertensive, to diabetics, to people with poor kidney, poor liver, there won't be any effect on the disease process. It won't be detrimental. There are very few drug-to-drug interaction. Being tested on 3.7 billion doses among the Africans, no, makes it really stand out among one of the most safest drugs there is. It is approved in the US, approved in the Philippines, FDA, and other countries. It is included in the Philippine Drug Formulary. It is there categorized as antiparasite. It has always been there in the World Health Organization's model list of essential medicines. So if it's there, it should be effective, it should be safe, and it should be essential, needed. Without it, humanity is deprived of something good. No? And it also won the category of wonder drug. It is one of only 3 wonder drugs in the world. First one is penicillin, second is aspirin, now ivermectin. Next slide, please. These are the properties of the ivermectin.
Dr. Alan,
Yes.
I have to cut you. Can you at least summarize your presentation? Because I was advised you have 30 slides. Kindly summarize, sir.
Yes. So it has an antiparasitic property. Next slide. It has an antiviral property. Next slide, please. Antiviral, you can see the list there. And I added SARS-CoV-2. It has even a good effect on human immunodeficiency virus. Next slide. It is an immunomodulator. It can handle autoimmune diseases, no, like even psoriasis. And next slide. It is a potent anti-cancer drug with no side effects. No. Next slide are the 6 mechanisms of action. You can see it is very scientific. It is specific for SARS-CoV-2 and COVID-19. It inhibits the spike protein, thereby the virus is hampered from entering the whole cells, thereby it cannot replicate. Number 2, it inhibits a helicase enzyme. Therefore it cannot initiate to self-replicate. Number 3, it inhibits the important alpha beta 1 heterodimer. This is very scientific already, and it goes into the nuclear membrane and then suppress immune responses. But ivermectin will prevent the virus from doing that as well. Number 4, these are the host-directed effect now, and it will be by this mechanism, it will prevent cytokine storm. Cytokine storm is one that leads to the severe acute respiratory syndrome that causes the death of most COVID-19 patients. And ivermectin practically stops this process. Number 4, it increases the production of interferon and enhances the effect. These are the munitions used by immune cells to counter the viruses. And lastly, number 6, it prevents the hypercoagulative state. In England, in Italy, they first discovered that people were dying not only from SARS but also from hypercoagulability. Means the blood is becoming so thick it cannot circulate anymore because the virus is affecting that CD147, and ivermectin practically inhibits that. Now, there were already more than 70 clinical trials all over the world, from Argentina, Egypt, Bangladesh, Brazil, US, Mexico. You have the list there. Pakistan, Peru, yeah. There were 70. No? Now, they have made it national policy to use ivermectin in Belize of South America, in Zimbabwe of Africa, next slide, and also in Slovakia of Europe. Now they're trying to do it in Bulgaria, and now they're clamoring to make it over the counter in Bulgaria, and I hope they will do. No? In December, the FLCCC, this is a group of intensivists, people who are the best doctors in the high end on the intensive care unit. These are pulmonologists, cardiologists, internists who are working on that area. They are seeing its effect. Adding ivermectin to their treatment is giving a good result. And they were saying here, why don't you use it even in prophylaxis and even in early treatment, so we get less and less of the patients here. And so that is their proposal with the US Senate way back December 8th. And the WHO itself also made a meta-analysis of all the clinical trials available. Then there were 54 in December. And the slide before that, the WHO, please go back to that slide. You can see the WHO's result of the meta-analysis saying 80% reduction in COVID-19 mortality. Now, my experience in the Philippines is this. Next slide, please. I was able to give it to 8,000 patients from July up to the present time through Zoom meetings 3 times in a week, 6:30 to 12 p.m. I'm answering all the questions to these patients. No? Next slide. With regards to safety, These are the side effects. Only out of 8,000, 50 to 100 with watery stools, with 10 with cramping, and only a few with rashes. No drug-to-drug interaction, no adverse reaction. For my success or efficacy, I will have say for prophylaxis, it may be 90 to 99%. No, literature, the other meta-analysis saying 89% for prophylaxis. I say, in my experience, maybe 99, if not 100. Early treatment, I get people already having COVID, and I give ivermectin, lesser hospital stay. And this is what I was mentioning earlier. It was presented by none other than our Senate President, Tito Soto, and hope.
Salamat, Dr. Microbiology and Infectious Disease, Dr. Marisa Alejandria. Dr. Alejandria. Do we still have Dr. Alejandria? Doc? Okay. Pierre Corey. I think he's from FLCCC also. Is he with your group, Dr. Alan?
Yeah, I'm with his group.
You're with his group. Okay. You are now recognized.
Hello. Good evening. Can everyone hear me?
Yes, loud and clear.
Okay. I'm going to share my screen. I'm going to go through some slides. Dr. Landrito really covered some of the information that I want to present. I'm Dr. Pierre Corey. I am a lung and ICU specialist. I've been battling on the front lines of COVID-19 since the beginning. Myself and my group, our only mission has been to develop the most effective treatment protocols for COVID. I first testified in the Senate back in May, and I strongly recommended to the world that corticosteroids were life-saving and critical in the treatment of COVID-19 at a time when the entire world, every national and international healthcare agency recommended that corticosteroids not be used in COVID-19. After I made that recommendation in early May, I was attacked, ridiculed, and dismissed for my recommendations, which comes out of expertise. And there were many reasons why we knew corticosteroids were critical. And that turned out to be the standard of care worldwide in COVID. Corticosteroids are now the standard of care worldwide in the treatment of moderate to severe COVID. I then went before the Senate again in December, recommending that ivermectin be used as the standard of care worldwide in COVID. Data-based, evidence-based recommendations. I am only here to present the science and the data behind ivermectin. It is critical that we use it in the treatment of COVID-19. My review paper, of which I'm the first author with my group, has been accepted and will be published in a couple of weeks in the American Journal of Therapeutics. Its conclusion, after reviewing all of the data, is that ivermectin should be deployed systematically and globally in the prevention and treatment of COVID-19. This paper was reviewed by 2 senior FDA scientists and 1 senior scientist that works for the Department of Defense in the United States. These are clearly leaders in their field, and they supported my conclusions. Now, briefly, Dr. Landrito, he went over the history of ivermectin. Yes, it's an antiparasitic drug, but for about 10 years, viral infections in the lab. In fact, since 2012. Now, we are sitting here now in March of 2021. Many trials, clinical trials, have been posted and published on ivermectin in COVID-19. And if you look at the bottom of this slide, the clinical trials repeatedly show that it prevents transmission and development. So it's a preventive agent. It hastens recovery and prevents deterioration. It can be used in early treatment, and it also can be used in late treatment. It reduces mortality. Like Dr. Landrito said, the mortality reductions are some of the highest that you can accord to any medicine in any disease model. It absolute risk reduction of over 80% of deaths. This is critical that this be used in COVID-19. This is from Dr. Andrew Hill, who is the lead researcher of the Untitled WHO team. He has not given a public talk on the most recent data since end of January, but when he was giving public lectures on the preliminary meta-analysis, these are some of the statements that he has said. The purpose of this report is to forewarn people that this is coming. Get prepared, get supplies, get ready to approve it. We need to be ready. The probability that the measured impacts on survival of ivermectin is due to chance is 1 in 5,000. And also millions of vaccine doses were manufactured, purchased at risk by countries before efficacy was concerned. Can we start to upscale ivermectin as well? It is critical that our leading public healthcare agency start to amass and deploy ivermectin as a public health initiative. This is a crisis. People are dying. This is a life-saving medicine. The data, I don't want to go over it too long because I know everyone is pressed for time. But we now have, and I will tell you, Dr. Hill right now, his scope of work in researching ivermectin is only looking at randomized controlled trials, and he has the results of 26 randomized controlled trials from around the world. All of the evidence showing over and over again the massive clinical benefits of ivermectin. This is a table just looking at prevention. These are multiple randomized and observational controlled trials. And when you give it to people who take it regularly, either no one gets sick if they take it once a week, or in post-exposure prophylaxis. If you have someone in the household who falls ill with COVID, if you give it to the rest of the family, very few get ill. You can protect the transmission once someone gets sick. So you can do a major public health benefit by distributing ivermectin. This is what's called a meta-analysis. This is a forest plot for you non-scientists and non-physicians. When you look at the center line of 1, when you see a treatment effect that's centered on the number 1, it means that there's no benefit. Here, this is just in the prevention. When you look at the repeated trials, the treatment effects all center around reducing the risk of getting COVID to superior to vaccines. In some cases, 100% protection, and in others, the low 90% protection. And like Dr. Landrita pointed out, this is a extremely safe medicine. 4 billion doses have been given. And in the words of one expert toxicologist who just repeated a review, severe side effects associated with this medicine are unequivocally and exceedingly rare. I'm going to repeat myself. Unequivocally and exceedingly rare in accordance with ivermectin. So it works in prevention. This is in mild to moderate illness. It reduces the time to viral clearance, time to clinical recovery, rates of hospitalization, rates of deterioration, and mortality. In hospitalized patients, 6 randomized controlled trials reduces mortality over and over and over again, large reductions in mortality. And so the real world evidence is some of the most striking. And Dr. Landrieu mentioned some of the countries that have adopted it. But if you look, this is a paper that's under peer reviewed now, a group of analysts. They looked at 8 regions in Peru. The shaded areas of the graph is before they distributed ivermectin to the population. That coincided with a peak in excess deaths amongst the population. Once it was distributed, the excess death rates plummeted to near pre-pandemic levels when ivermectin was widely distributed. This is what's called the case fatality rates. The shaded areas to the left, and this is only in patients over 60, both of these graphs, only patients over 60, to not be confounded by young patients. But if you look at this, back in April, May of last year, if you were over 60 in Peru and you got COVID, you had a 40 to 50% risk of dying in this one state. After ivermectin was distributed and widely used, the chances of dying if you were over 60 from COVID plummeted to single digits over and over again in multiple states in Peru. This is a life-saving drug. So much so that the military in Peru was engaged to go through the countryside and distribute to all of the old and most comorbid. During an 11-day period when they distributed it, it rapidly reduced the excess deaths in many of those regions. This is a slide showing Lima in red behind the 8 states where they widely distributed. Lima, the big city, the capital, did not believe in ivermectin, did not believe in it, because all of the scientists in the big cities thought it was the people's drug and thought it was nonsense. They did not employ ivermectin. And if you can look, the case counts and deaths in the big cities did not do what it was doing in the countryside. And so this has been shown. I'm going to stop here. I have 1 more minute. I'm just going to show this is one city in Brazil. This is in Paraguay, one state in Paraguay in blue, after they widely distributed ivermectin. And this is one state in Mexico in Chiapas, some of the best performing regions in the world in terms of death rates. This is most recently 2 months ago. The healthcare agency, the National Healthcare Agency in Mexico, adopted what's called a test and treat strategy, which I think is the ideal for treating COVID. You test and then you treat. And in Mexico City, in all 250 testing locations, they use rapid tests. Anyone who tested positive got ivermectin. Look what happened to the hospitalizations and deaths over time in Mexico City. They are conquering COVID. And my recommendations, my peer-reviewed manuscript is also supported by the international collaboration in Britain, where they brought together 65 specialists. They reviewed the data, and they found the data to be credible. And they recommended, here at the bottom, the strongest recommendation Oxford for ivermectin to be adopted in both prevention and treatment around the world. This is multiple expert groups around the world are finding this. And many, many countries recently have adopted it. I don't think the Philippines has. In fact, what I've understood is Philippines has made it illegal for doctors to prescribe it. And I find that to be atrocious, unconscionable, egregious, and it's going to directly lead to the death of many, many patients. You need to follow the data and follow the science, and ivermectin should be adopted in the prevention and treatment of COVID-19. Thank you.
Thank you, Dr. Pierre. Okay, do we have Dr. Alejandria? Dr. Alejandria? Okay, while waiting, I'd like to call on Representative Eric Pineda. Okay. Yusek Rosette.
Yes, Madam Chair, good evening to all of you again. And since Dr. Alejandria is not here, we have this group called Living CPG, and this is comprised of various experts across the different medical societies of the Philippines, including the Philippine Medical Association, PCP, PAFP, POGS, PCEM, PSGIM, PCCP, and PSMID, together with the UP and IHIs. And in here, FDA and DOH joins them in these different activities where we try to evaluate studies for the management and treatment of COVID-19. So, Madam Chair, I am not here to debate because I am really not an expert on this. I just like to read the statement on the use of ivermectin as treatment for COVID-19 based on the evaluation done by these experts. A systematic review of 6 randomized controlled trials of good methodological quality shows that, first, the use of ivermectin for the treatment of COVID-19 does not reduce mortality risk. It is also not associated with a definite benefit in terms of other clinically important outcomes, such as clinical improvement at days 6 to 10, clinical deterioration, nor need for a mechanical ventilation. Furthermore, it does not significantly reduce the duration of hospitalization and the time to resolution of symptoms. The rate of hospital discharge at day 10 to 14 does not differ significantly between those given ivermectin and those who receive standards of care or placebo. The adverse events reported with the use of ivermectin, although not significantly increased, includes dizziness, headache, rash, and gastrointestinal symptoms such as nausea. Based on the current evidence from the randomized controlled trials, we do not recommend the use of ivermectin for the treatment of COVID-19. It has not been proven to significantly reduce mortality or improve other clinical outcomes. This recommendation will be updated as more evidence is generated from our ongoing trials. So, Madam Chair, I am just stating this, reading this from the statement coming from this Living CPG group. I am not here to debate. I am not an expert, just stating this, and the DOH has adopted this because we are part of that group. Over to you, Madam Chair.
Thank you. I'd like to call on Representative Eric Pineda. Kong Eric?
Yes, thank you, Madam Chair. Can you hear me?
Yes po. Please proceed.
Good evening po. First of all, thank you to Dr. Corey. I believe he's answered most of the questions with regards to the efficiency of ivermectin. I will just make a manifestation and just leave the questioning to my able colleagues, Madam Chair. We are in ECQ yet again, as COVID-19 cases in the Philippines have been reaching all-time highs. Almost new cases in a single day are now in the 10,000 region. In fact, there were 10,016 additional cases yesterday, despite of the government's declaration of enhanced community quarantine for the Greater Manila area. Hospitals have been announcing full capacity status, and our medical frontliners are exhausted. It is frustrating, I know. Madam Chair, ivermectin, an anti-parasitic drug, has been shown to reduce the effects of COVID-19 in infected patients when used. Ivermectin is more cost-effective compared to remdesivir, the current drug being used to treat COVID-19 infected patients that costs 28,000 pesos per IV and must be administered twice daily until such time that the patient is discharged. On the other hand, ivermectin costs around 35 pesos only. To be administered the minimum once daily for 3 days or a maximum of 5 days. Many patients made full recoveries which would make everyone consider the said drug beneficial in this time of global health crisis. And I can attest to that, Madam Chair, because a few weeks ago, my son pleaded to me to find a hospital for his best friend. To no avail. We called all the hospitals and there was none available because his friend was already in a very severe situation. He could not breathe. He has fever and he's coughing. And he was just asked to go home. So I asked friends and they were able to patch me through Dr. Landrito, who gave me this drug. And I told my son to just trust in the drug and give it to his friend. He gave it to his friend and what can I say? After 3 days, Madam Chair, he was well already and without any symptoms. That I can attest. To continue, in Virginia, Madam Chair, ivermectin is already, Virginia, United States. It's being used already by medical practitioners to treat patients. Likewise, to prevent transmission, doctors are administering a tablet of ivermectin once every 2 weeks to vulnerable individuals.
Kindly wrap up.
We have witnessed astronomical hospital bills incurred by COVID-19 patients. Most of the time, the patient is unable to come up with the payment even after the whole family's saving has been depleted. From my experience, Madam Chair, I also am a COVID survivor. I was hospitalized for 5 days and I paid 750,000 pesos. Can you imagine? And now, with the spike in infection rate that we are experiencing, despite of the vaccine rollout being implemented by the government, one can only wonder where this pandemic will lead us to. That is the sad reality that we are in. However, Madam Chair, my esteemed colleagues, I believe there seems to be hope given by ivermectin. This drug can be a game changer. Dr. Alan Ladrito, as well as other medical experts, have found success in treating COVID-19 infected patients with ivermectin. Contrary to what Yusek Domingo stated, I was informed that they applied for FDA approval sometime in February 11 and applied again in March 11 and March 20. A stark contrast to the claim FDA has made to the nation. They even released an advisory banning ivermectin and that such is only used for animals. Some of our medical practitioners would beg to differ to that, Madam Chair. Contrary again to the pronouncement made by DOH and FDA, Ivermectin is in the essential medicines list of the Philippine National Formulary. According to the World Health Organization, essential medicines are intended to be available within the context of functioning health systems at all times in adequate amounts in the appropriate dosage form with assured quality and adequate information, and at a price an individual or community can afford. Yet, the FDA has ordered Dr. Ladrito to stop treating COVID-19 patients with human-grade ivermectin, which he is supplying now out of compassion for the poor. Madam Chair, ivermectin has shown so much potential, and 22% of the world, including India, South Africa, and South America, is already utilizing the same as COVID treatment and prevention, wherein its administration is guided by medical practitioners. The ivermectin manuscript prepared by United States Dr. Pierre Corey has been accepted for publication, and the same concludes that ivermectin should be immediately and globally deployed in prevention. Yes, ma'am.
I have to cut you. Can you wrap up, because we have like 17 members who wanted to ask questions?
Yes, ma'am. 3 minutes na lang po. In my opinion, although I'm not a medical expert, ivermectin is a miracle drug, bottom one, and I'm basing this from my experience. I'm imploring to the DOH and the FDA that those developments be considered, while hoping that it will be eventually be allowed by the FDA as treatment for COVID-19. Lastly, I filed a resolution to this committee to investigate on the acts of the FDA, and this means ivermectin as a drug for use to treat COVID-19. However, the same has not been referred to the committee yet. Be that as it may, Madam Chair, distinguished colleagues, let us have an open mind and hear from the medical expert present in our meeting today. I believe they are the best resource we have with respect to information on ivermectin. Likewise, I would like to thank Speaker Lord Alan Velasco for his effort and support to give this drug a chance to be given attention by our government agencies concerned. Thank you, Madam Chair. That's all.
Thank you, Chair Eric. Do we have Director General Dr. Eric Domingo?
Yes, ma'am. Madam Chair, I'm here.
Can you clarify that? Because I heard this morning from the radio, a certain doctor was interviewed, and they were saying that they filed already an application with FDA. Can you at least answer that?
Yeah, I have to make it clear. Now, we've checked every day for the past week, and there is no application for compassionate special permit, for emergency use authorization, for certificate of product registration, or for any form of authorization for human preparations for ivermectin. And just to make it clear po, yung ating nilabas na advisory is pertaining to the fact that there's no registered human oral preparation for ivermectin with FDA. Ang meron lang pong nakarehistro na ivermectin sa Pilipinas ay mga veterinary products. Kaya sinasabi po namin sa mga tao, mag-iingat po kayo, huwag kayong iinom ng veterinary products. Pero hindi po kami anti-ivermectin, we have not prejudged it. We're just saying that hindi po kasi pwedeng magbenta ng unregistered product sa Pilipinas. Kailangan po authorized, bawal po kasi sa batas ang unregistered product. And so far, there's no registered ivermectin for human oral intake at wala pong pending na application sa FDA.
Thank you, DG Eric, for clarifying that, no? Kasi I think that's the parang nami-mislead yung ating mga kababayan when it comes to doon sa information doon sa ivermectin, no? But kanina nagulat ako doon sa narinig ko sa radio na sinabi na nag-file na sila even I think last year. And then we had that conversation few days ago clarifying issues on ivermectin, and you said na wala pa ngang nagpa-file. So can we hear from Dr. Landrito? I think he's raising his hand. Dr. Alan?
Certainly, I have not filed certificate of product registration because a prerequisite for filing that is the license to operate. I have filed my license to operate. I have completed my requirements. They are delaying and delaying. We have to get ARTA to look into it. So this morning, ARTA looked into it and they should give me my LTO. Then after, I will file for emergency use authorization. That's the whole story of it.
Dr. Alan, when did you file your license to operate?
Way back February 11 po, I completed the requirements.
11 this year or last year?
This year po, February 11.
Yeah, and today is March 31, so it's like...
It's much more than 20 working days already. They should have issued it already. That's why we have to get the help of ARTA to check on why they are not approving of it. And they are bluffing the people that in saying I'm not filing for certificate of product research. Certainly, I will not be filing because it's a LTO is a prerequisite for that, but I will have to file.
You are applying license to operate as a manufacturer or distributor?
As a trader, pharmaceutical trader.
Pharmaceutical trader.
Trader. And I have already, ongoing deal with the pharmaceutical manufacturer who will manufacture it for me. I just need to have the trader license so I can market it then.
Okay. Can we go back to Director General Eric Domingo with regards to his application? DG
Yes, I think our director for the Center for Drugs is here, Director si Runay. But I would think that would be the hirap. Minsan nga po, lalo na ngayon na medyo hirap yung mga inspection. Pero like I said, wala po talagang application for CPR or CSP or authorization for the product.
Yeah, CPR is fair because your instruction for CPR is 6 months session after we get the LTO, license to operate.
Okay. Can we hear from Director si Runay? Is she on board?
Muted.
Yes po, Director. You're unmuted
okay. Thank you very much. Ma'am, we will check. I just knew of this application in this meeting. We will check and I will update DG Domingo immediately. We are checking it now.
Director Sirunay, kasi parang the last month na po na may mga debate about this ivermectin. No, so please check yung status ng application ni Dr. Alan Landrito. Okay, I'd like to call on Representative Mike Defensor for his interpellation. You have 3 minutes, sir.
Thank you, Madam Chair. Madam Chair, if I may share screen at sasagutin ko rin po yung mga assertions ni Dr. Domingo regarding this. If I may, Madam Chair.
Sylvia or Ma'am Dayan, can you allow Kong Mike to share his screen?
Sorry, Madam Chair. Hindi po yan yun. 1 minute, Madam Chair. Is it shared already, Madam Chair? Not yet?
Not yet po.
Maybe, Dr. Domingo, you have forgotten to be a doctor. You have not been seeing patients. If you're in the middle of this pandemic, you will see a lot of patients who are suffering. Yes.
Dr. Alan,
yes,
please don't speak when the chair didn't recognize you.
Sorry, Madam Chair. Medyo nahirapan po ako mag-share screen.
Okay. Well, wait. I'd like to call on Representative Mickey Biolago. Do we still have Kong Mickey? Okay. DS Bernadette Herrera D. DS?
Yes, thank you.
Please proceed.
Thank you very much, Madam Chair. Hello, can you hear me? Madam Chair, gusto ko lang i-clarify yung kanina because the statement previously was that clear ni Yusek Eric. I think si Yusek Eric ka-text ko siya since last week pa na yung sabi niya sa akin it's for animals. Pero kanina, yesterday I saw a release wherein pinapayagan na nila for compassionate use. So ano pong ibig sabihin? Does that mean that you already agree that it can be used for COVID already? Kasi I saw a statement that you can use it now for compassionate use for COVID treatment. I would just like to clarify that one.
Unmute. Yes, ma'am. Opo. Ang sinasabi ko po, ma'am, dati, yung mga registered products natin na existing are for veterinary preparations. So yung mga nandito po ngayon na binibenta ngayon sa mga pharmacy natin, veterinary products, so hindi yun pwede sa tao. Ngayon po yung compassionate use, ang in-expand po kasi natin ngayong panahon ng COVID-19 yung compassionate special permit. So if a drug is actually being used as a clinical trial drug for the treatment of COVID-19, pwede po yan i-apply ng compassionate use. Meaning, you get a product that is registered, for example, in another country, in the US, the human preparation po, no? Hindi veterinary preparation. Human ivermectin na for use, for example, na registered sa US FDA, and then you can import it here and use it under the compassionate special permit. So pwede po.
So, Yusek Eric, so ngayon, consistent na tayo na if it's for human use, ivermectin can be used for COVID prevention and treatment.
Under compassionate special permit po, meaning the doctor takes full responsibility for the drug and they explain to the patient that this is originally designed as an antiparasitic, but I have reason to believe we can use it for COVID, and then the patient is willing to take it. Ganun po yung Pero sa treatment guidelines po ng DOH, hindi pa po siya kasama ang ivermectin for the treatment of COVID-19.
So, paano po natin, so since sinasabi niyo naman that you agree that it can be, dahil siyempre kung papayagan mo na siya compassionate use, meaning naniniwala din kayo that if the ivermectin, kung gamitin siya for human or yung timpla niya is for human, kaya na pwede. So, pwede ba natin siyang mabigyan ng permit para magamit na siya ng hindi kailangan for CSP, for compassionate use? Sorry.
Well, mag-a-apply po sila ng CPR. That would be a certificate of product registration. And that means you really have to complete all of the requirements for a CPR, meaning completed clinical trials and all of that, all of the necessary po na lagi natin hinihingi for CPR if you want a marketing authorization.
And we will be open to this, Doc.
Yes, ma'am. Kami naman po, tinatanggap namin lahat ng applications and we evaluate it, no? We evaluate the quality side and then of course the safety and efficacy side. But if there's no application, we cannot evaluate it and we cannot make a decision.
Pasensya na kayo, Yusek Eric, di ba? Kasi syempre tayong lahat dito, we're trying to find a solution. And even when I was asking you about ivermectin, I feel na meron ka kaagad resistance towards it eh. But I know naman that you know na yung kumakalat din na prescription or yung kumakalat na ivermectin sa public, you know also it's not the one for vet, di ba?
I do not know, Madam Chair, I do not know because it's not registered with the FDA. So I do not know what it is kung yung kumakalat.
Okay. So anyway, basta ang amin lang naman is please be open na pwede na sila kasi ang naririnig namin is they're having a very difficult time. And then kahit yung compounding pharmaceuticals na trying to accredit it with you. So ngayon ang tanong ko, Doc Eric, dahil sabi mo kanina you're not banning, FDA is not banning the sale and use of ivermectin. That was your last statement during your slide. So pag kunwari, nakunwag naman, ako nagka-COVID, lumapit ako sa doktor, and humingi ako ng ivermectin, can they give me?
If the doctor gets a compassionate special permit for you,
How long will that take?
Ang CSP po namin 24 hours to 48 hours.
Hindi po kaya mamatay na ako within those 24 hours, Doc? I mean, what if
Hindi
I'm
po,
very...
yung CSP po kasi wala naman siyang evaluation. Kailangan lang meron kang importer, kailangan lang yung product mo license siya sa country na pinanggalingan, and alam naman po natin na merong ongoing clinical trials. So mabilis po ang CSP applications kasi hindi siya license, hindi siya marketing authorization. It's really just for a patient.
Pero kung pinapayagan nyo ang CSP for COVID, then you actually agree that it is effective for COVID. Tama po ba?
It might be effective. Ang sinasabi naman po natin, hindi naman tayo pa nagkaka-conclude kung good siya or bad. What we're saying is, wala pa pong data, kaya pa po siguro walang enough data to register it as an anti-COVID drug in any country. Wala pa po sigurong bansa na may CPR siya for anti-COVID because it's still an investigational drug.
Pero papayagan natin siya for a compassionate use drug.
Yes, and an investigational product, pwede rin po kung magki-clinical trial. May mga paraan naman po talaga na magamit siya. Pero
So meron
kailangan
bang shorter than 24 hours, Doc? I mean, paano po for prevention? So ibig sabihin, papayagan nyo pa lang siya kung may COVID na. Paano po yung prevention? Paano yung mga naniniwala na if you take one in every 2 weeks, you can be prevented? Paano makakakuha ng permit sa inyo?
Well, yung CSP po is for treatment talaga, no? Kung if you want to use it for talagang marketing authorization, then ano na po talaga yon? CPR na po talaga yon.
Is that possible? Can they get a CPR? Kung sinasabi niyo maraming absence pa ng kung ano-anong dokumento.
Well, if they have complete requirements po, talagang meron po standard po kasi globally ang requirements for a CPR. And as long as those are all met, then po pwede naman po talaga.
Yes. Yeah. Last na lang, Sir Helen, I would just like to bring this up. I'm very concerned lang with dun sa tocilizumab na drug because we're just not naman on ivermectin. Last week, meron akong dinadala sa ospital na naghahanap ng tocilizumab and wala talagang makita sa kahit saang ospital. And I learned that private hospitals have it, yung mga mayayamang private hospitals have it, but not any government hospital has it. So, I heard the presentation a while ago. I would like to know ano na ang concrete plan natin to have this medicine because people are dying dahil wala daw nitong drug na to. So bakit yung ibang hospitals has access to it? How come government does not have an access to it?
Well, both I think both DOH and FDA, Madam Chair, have been reaching out to the manufacturer of tocilizumab. Talaga pong meron daw shortage and some hospitals, I guess, pre-ordered before the surge. Kaya may natitira pa silang konting supplies. Pero mukhang nationwide po talaga yung yung kanyang shortage. But they promised that they will be diverting some supplies from other countries to the Philippines at itong after Holy Week, magkakaroon na daw po ng mga deliveries dito sa atin.
Yes, Madam Chair, kasi anticipatory nga ito Like you said, yung iba nag-pre-order. So bakit hindi tayo handa? Why didn't we pre-order this? So yun lang naman yung akin. Sana mas maging proactive po tayo. Yan lang naman ang pakiusap namin. Dahil syempre, hindi maganda na napaka-helpless natin when you try to look for these medicines. Even our government does not have it. And I would like to put that on record, Chair Helen, na sana nga after Holy Week, we really have this drug on our stocks para naman pag may naghanap, it's readily available in our government hospitals.
Thank you, DS.
Thank you, Chair.
I think yung need po natin for remdesivir, tocilizumab, and other medications being used based on the treatment protocol, talagang kulang na kulang ang supply. Ngayon pa lang po, while we are conducting our hearing, 3 patients na po sent to me prescription of toci and remdesivir. So, mahirap po talaga maghanap. Sana matulungan tayo ng DOH on procuring siguro. Meron lang akong question, DG. You mentioned on special compassionate permit. DG,
yes, ma'am. Yes, ma'am. I'm here, Madam Chair.
Kasi that's different from CPR, Certificate of Product Registration. Iba din yung permit for compounding. So, gusto nating ma-clarify. Kasi kanina, si Dr. Alan Landrito, he said he's applying an LTO, license to operate, as trader. Tama po?
Opo. As a trader, that means that you can, for example, contract a manufacturing company to manufacture a product for you and then you can sell it.
Importation is also included doon.
Meron pong LTO, ma'am, for an importer and distributor.
Because you mentioned earlier, wala pa in the Philippines nag-manufacture or nag-produce ng ivermectin for human use.
Well, so far, Madam Chair, wala pa pong manufacturer dito sa amin na nagba-manufacture. Now, we had a meeting earlier with the ARTA and yung Pascual Lab and si Lloyd Pharmaceuticals showed some interest in manufacturing here.
Okay, so my next question is to Dr. Alan Landrito. He said in his presentation, he was able to sell 8,000 ivermectin.
Yes,
Dr.
I was able to give more than 25,000 bottles. So I'm divided by maybe 3 for a patient. 8,000 patients is very conservative number.
Sir, where did you get this ivermectin?
I compounded it myself. I bought pure ivermectin from an importer and compounded it myself and gave it to my patients.
But you don't have the permit. Did you apply for a permit on compounding?
I went into the definition of compassionate drug use. It states there using a medicine before even getting an FDA permit. If it is badly needed by the people. We are in the middle of the pandemic. I cannot have scope of time to apply for any of those permits. My patients are begging me to treat them. I'm just giving treatment to patients, prophylaxis, early treatment.
Okay. Anyway, I just want to clarify that, sir, because of course we have policies or laws that we need to follow.
Yes, that's true. It has something to do with the safety of the patients. I haven't harmed any of my patients, and I have been helping a lot of my patients. If they want to put me behind bars for this, it doesn't matter. No, many people whom I have helped will clamor for the legality of all these things. No,
Dr. Landrito, you have partners abroad. Di po ba?
No, I don't have. No, I don't have.
Okay, so the one that you gave is you compound it.
Yeah, it's not even a matter of compounding. There's no chemical reaction. I just mix it with an inert ingredient, nothing more but dextrose and hydrose. Give the right proportion, provide the 500 milligram, exactly 15 milligram ivermectin there, and it's working good for the patients.
Okay, thank you, Dr. Alan. May I call on Kong Mike Defensor for his interpellation?
Gusto ko lang pong una sabihin na I want to refute yung mga statements po ni Dr. Domingo. And napakahirap po ng sitwasyon natin ngayon. And if I may go to the slide, 10,000 cases po tayo kahapon, malaki na lumalaking numbers, pagkatapos para bang, sige mag-apply kayo, 6 months, 7 months, 7 months, maghihintay tayo. Alam nyo, Madam Chair, ako po ang isa sa mga naging beneficiary ng ivermectin kasi nung nagkasakit po ako, inom ko rin po yan along with other meds, along with other vitamins and supplements nung ako po yung nagka-COVID. In fact, I do not know, no? But it made me better. Wala po akong naramdaman on the first day that I drank it. Nung inom ko po yan, initially, ang akin pong tinitinan, ito pong report ng WHO. Kasi siyempre, safety mo muna eh. I did not do any deep investigation or research on this. At malinaw po, walang side effects. Safe siya and can be used on a wide scale. Bagamat ginamit to sa river blindness, yung onchocerciasis, which is river blindness, sinasabi talaga ng WHO na safe to. Accordingly sa Barcelona Institute for Global Health, sinasabi nila approve. To date, more than 3 million treatments have been distributed. Donation po ginawa nila yan sa maraming African countries. Sa National Institutes of Health, yan po yung sa FDA, yan po yung governing agency sa Estados Unidos. Sila din po sinasabi, generally well-correlated, adverse effect, dizziness, pruritus, nausea, diarrhea. And dito po sa atin, sa report na to, 3.7 billion na po ang paggamit ito. Mismo naman si Dr. Domingo nagsabi siya, safe. Wala silang nakikitang masamang side effect. Ngayon ano yung Philippine National Formulary? Ito po yung mga gamot na pinapayagan, list of essential medicines that are registered with the FDA. At kung titingnan nyo po dyan, ivermectin nandiyan po, 3 to 6 milligrams, pinapayagan po siya. Nasa pulmonary po natin dyan, nasa PhilHealth din po yan. Si Judith Semenkiewicz, 80 years old, 20% na lang po siya. Binigyan po siya ng unang dose, nag-improve po sa kanya yung health niya after 2 days, nagde-deteriorate. Ayaw na humbigyan ng ospital. Nag-appeal ang pamilya, ayaw nilang bigyan, nag-file ng case. Kaya po ito yung first legal case. Si Judge Henry Nowak, sabi niya, ituloy ninyo. Nag-survive po yung patient Judith at dyan pasok yung kaso. Si Dr. Cory is here. Dr. Cory, thank you for joining us and for giving your inputs. Si Dr. Cory, lumabas po yan sa Senado at yan po yung naging resulta na nagbago. Kasi po noong August of last year, if I'm not mistaken, against po FDA sa US. Ngayon po, neither for or against. And because of that, ang mga doktor po ng Frontline Critical COVID-19 Care Alliance, pwede po silang mag-prescribe. Pag sinabi na pwede kang gumamit ng gamot, papayagan ka po nila. Ngayon ang sinabi po si Dr. Landrito, ginagawa na. Si Dr. Homer Lim, ginagawa na. Imbis po ang attitude ng gobyerno natin ay gumawa tayo ng study at tulungan natin yung mga tao, baka ito'y makatulong at mura. Sabi na hindi, mag-register kayo ng gamot. 6 months bago ka mag-register ng gamot. Kung hindi ka operator, katulad ni Dr. Alan Landito, 1 month, 7 months po yan. Si Dr. Homer Lim po, pinapayagan siya mag-produce. May compounding laboratory siya. Pinuntahan din po ng FDA. Hindi ko alam kung anong gusto nila, pero ngayon ayaw na niya mag-produce. Ito po sinasabi ng Republic Act 3720 at Republic Act 9711, yung pag-amend niya. Pwede pong gumawa ang written prescription practitioner licensed by law to administer such drug. Pero ito po yung mabigat, yung number 3. Ang secretary may be, by regulation, remove drugs subject to Section 19. Such requirements are not necessary for the protection of the public health. Ang mga dito po sa atin, maraming pwede mag-produce. All that FDA has to do is to ensure that they're doing it correct, tulungan po nila. I-record ang data, imbis na ipasara at patigilin. Kasi kung nandun naman yan sa formulary, may existing yan at pwedeng gawin, tingnan lang nila kung tama ang timpla, imbis na hinto nila. And Dr. Domingo, DOH, I'm warning you, hindi nyo mahinto to. People will still, ang daming humingi, ang daming may gusto. At imbis na kayong maging hadlang at sana maging proactive tayo. At i-accommodate natin, i-assist, hindi yung attitude. Kasi alam niyo ho, Madam Chair, yung ginawa pong aral na pinapresent ni Dr. Cory, iba-iba hong lugar yun. We have a chance to do it in the Philippines. That we can make a study using ivermectin. At tingnan natin kasi ngayong panahon sinisimulan to. Ang DOH din, pwede yung off-label drug. Sabi po ni Undersecretary Bergeres, sabi niya, that the department will be tested, that off-label drugs are used to treat other diseases but will be tested by hospitals and doctors. Kung yung ibang droga ho, pinapayagan natin to test, baka hindi natin payagan to. Bigyan nyo ng approval kaagad si Dr. Landrito. Si Dr. Homer Lim, pabayaan nyo siya mag-produce. Yung kausap ng ibang drug manufacturers, pabayaan nyo po sila mag-produce. At i-monitor natin para makatulong tayo imbis na makasama. At sinabi ninyo, doktor, sinasabihan ninyo, huwag kayong gumawa ng prescription. Choice po ng mga tao yan eh. Bayaan mo natin sila, do we still have to file a case? Kung safe naman po pala yan, wala naman yung problema. Ako, I'm a living witness of someone who drank ivermectin. Ba't hindi mo natin payagan yung iba? Mag-prescribe ang doktor at makabilis lang makakuha at magamit ng mga tao. Ito po mga ivermectin initiative. Andiyan si Dr. Cory is there, FLCC, UK, yung BIRD, British Ivermectin Recommendation Development. Dito po sa atin ang CDC. Marami po sa Australia, sa India, South America, may ivermectin initiative. And they're doing the studies. Ito po yung lumalabas. Ito po yung galing kay Dr. Cory sa FLCCC. 89% prophylaxis. Early treatment, 79%. Yung late treatment mo, 50%. Mortality, 76% improvement. Kaya lang po hindi tinatanggap ang study na to kasi nga, iba-iba, hiwalay-hiwalay. And that is the explanation. But if we can really do a study coordinated with WHO, then it can even help not only our people, pero nakatulong po sa maraming bansa. Ngayon sabi nyo, compassionate use, binabanggit nyo kay Congressman Herrera, talaga niloloko nyo yung mga tao. Kanina sabi nyo, mag-apply kayo ng gamot, 7 months. Dito kayo no, sa special permit, alam nyo, babayaran nyo ha. Yung doktor, magkakaroon ng waiver, pagkatapos magbabayad 500 pesos. Eh yung treatment ko, wala pang 105 pesos, 35 pesos per tablet. Kailangan nyo gawin 24 hours, 24 hours. Mali mo to. Mali yung ginagawa ninyo na pinapahirapan nyo yung mga taong nagpuproduce nito at mali yung ginagawa ninyo na kunyari pinapayagan ninyo yung compassionate permit na gusto nyo, ganyan po katagal yan. For the individual patient, ganito katagal. Magbabayad ka 500 pesos and then sa institutional use. And last but not the least, yung linwa pinabayagan nyo, ininom ko rin po yan. And I'm not against linwa. Pero yung gamot na 4 decades, 40 years nang existing, walang sinasabing masama, ayaw niyong payagan. Yung linwa na bago pa lamang, pinayagan niyo na as a traditional medicine. So, Madam Chair, gusto ko po sagutin na point by point kung ano yung raise ko. Huwag niyo na sabihin na magre-register ng gamot. Dr. Domingo, DOH, Secretary Duque, you have to be proactive. We have to do something. Marami na yung namamatay. Marami yung tumatawag sa akin. And people are not earning from this. Ito po'y tulong sa ating mga kababayan. Thank you, Madam Chair.
Thank you. Kong Mike, may we hear from DG Domingo and Secretary Duque if he's still around?
Yes, Madam Chair. Yun naman po talagang sa compounding, pinapayagan po yun, meron lang pong standards na kailangang sundin. Kaya meron po tayong inspectorate na titingnan at to make sure yung quality po ng mga products na ilalabas nila. Yun pong CSP, hindi naman po per patient yun, yung iba nga po per hospital sila kung humingi sa amin. So hindi naman 500 per patient yun, kung hindi per per application. So some hospitals, for example, would apply for 100 patients all at the same time. At mabilis po yun. But at least at the very least po, it is going to be an authorized product. Wala po kasing wala po kasi talagang paraan para magbenta na hindi unauthorized yung product or hindi po siya registered dito sa atin. Unless meron pong batas na mag-a-allow for us to do it, hindi na po kailangan dumaan sa amin kung gano'n, Kaya lang, kasi po kami, ang mandate talaga namin is to assure that all products that are available out there are authorized by the FDA. Kami naman po, gumagawa lang naman po kami ng trabaho namin at kapag nag-apply naman po ang isang produkto, aralin naman po namin lahat ng isusumiti sa amin na data ng product quality at saka all of the scientific data. Lahat naman po yun titingnan objectively and it will be evaluated.
Madam Chair, alam niyo ho dapat ang DOH nagsabi bawal mag-prescribe. Ang FDA pinahinto yung mga production. Ang sinasabi ko, Director Domingo, nag-agree ako may trabaho kayo. Pero meron tayong mga batas na pinapayagan itong sitwasyon natin sa ngayon. Dapat hindi kayo mag-act na papatayin ninyo yung ganitong initiative. Ang DOH, kasama kayo, magtulong-tulong, pati nga mag-prescribe, bawal na ang doktor mag-prescribe O kaya si Dr. lang dito, minto. Imbis na tulungan ninyo, na sige, we will allow you produce, Dr. Homer Lim, we will allow you produce, ginigipit ninyo. So Dr. Domingo, that's the point. Tapos sasabihin ninyo, hindi kasi wala namang in-approve dito, walang nakaregister. Paano nga mamamatay na lang yung mga tao natin, kababayan natin? Hindi naman to simpleng cosmetics, hindi naman to simpleng isang gamot na ipapasok ngayon. We are in a very critical situation. So Dr. Domingo, the attitude should be that you look into the law. Pag-aralan nyo yung batas. And you have the FDA law, along with the DOH, ayusin nyo yung policy and help the producers of ivermectin and do a study on this.
Kong Mike, that will be your last question. Relax. Tingnan ng malalim. Okay. I think ito pong hearing na ito ay ginawa naman natin para pakinggan both sides from the regulatory agency and our advocates from medical experts nandito rin po so that we'll come up into a sound resolution or solution on this problem. Definitely isa naman po ang layunin ng lahat. Kung ivermectin nga po talaga yung ating makukonsider na miracle drug to prevent and treat COVID-19, I think lahat naman po ay susuporta doon. So, do we have Secretary Duque? If he can respond, or anyone from the DOH?
Yeah, Madam Chair, and Congressman Mike, magandang gabi po sa inyo. Titingnan po natin ito, no? Titingnan natin yung provisions na kung alam natin na may sapat na datos para suportahan yung mga sinasabi na nakakapagpagaling itong gamot na ito. Pero ang DOH po kasi, ang proseso namin, meron po kaming mga experts, no? Na mga yung technical advisory group of experts na yan po, dinudulog namin sa kanila itong mga issues na pandemic to be science and evidence-based, no? So, hindi naman namin po sinasabi na walang magandang maidudulot itong gamot na ito in much the same way na ang amin po mga experts ay talagang tuloy-tuloy ang kanilang paghahanap at ng mga datos para suportahan talaga. In the end, malinaw naman po ang direksyon. Kung makakatulong ito sa paglatag ng lunas, paglapat ng lunas para sa mga COVID-19 patients, maganda naman po yung layunin. At ako po ay sumusuporta sa posisyon ng ating po mga mambabatas, pero gawin po natin sa tamang pamamaraan. Gawin po natin na sumunod po tayo sa batas na wala naman ibang gumawa ng batas kundi ang Kongreso din po, no? At ito ay dumaan sa mga hearings, ilang beses po yan, yung RA 9711, ito po ay produkto ng Kongreso. At kami po sa ehekutibo, alam naman po ni former Secretary Defensor Ian, na dati po kasama ko sa kabinete, na tayo po as implementers and executives of the government, talagang we have to do a faithful implementation of the law, which is a product of Congress that went through, very broad and deep study, no, of the provisions of this particular law. But let me just reassure the good chairperson and the good congressman, we will look into this right away, and we will see how we can bring to fore the use of this particular preparation, the ivermectin, but at the same time ensuring that there are enough safety data, no, as they claim. So, yan naman po ang ginagawa sa ngayon ng ating pong mga nagpakadalubhasa, ang Technical Advisory Group of Experts. Sayang, wala si Dr. Isa Alejandria. She's the one who has been into this, no, for quite a long time. But let me just reassure once again, we will look into this immediately, Madam Chairperson. Thank you, Congressman Mike. Maraming salamat po.
Thank you, Sec. I would like to call on Deputy Speaker Christine Singson Mihan to ask question.
Yes, good evening po. Good evening, Chairwoman, and everyone here that's here today. Kay Secretary Duque, people from DOH and FDA, and my fellow members. In the line of questioning of BH and pati na rin yung mga binanggit po ni Kong Mike Defensor, na mention niya na nasa pandemic po tayo. So in the sense of urgency po, pwede ba natin kalimutan na yung mga process na nag-fail tuloy itong mga doctors who's applying for ivermectin, at paano po tayo magtutulungan lahat ng agency nito, and paano natin mabigyan ng LTO rin? Example, si Dr. Landito na nag-apply, hindi siya maka-FDA application kasi walang LTO. Pero paano tayo magtutulungan para makuha na nila yung dapat nilang makuhang permits? You mentioned about the compassionate special permit. Paano nila magagawa na sana in a month's time? Pwede bang mag-commit yung mga nandito ngayon na kaya natin na in a month's time or 2 months time meron na tayong mabibiling ivermectin for human grade consumption? Yun po yung tanong ko po.
Yeah, Madam Chair, kami naman po basta po nag-apply sa amin, we will prioritize basta naman po for COVID-19 eh. Pag sinabi po ang product ay for COVID-19, pina-prioritize po yan ng mga director natin, yung sa Center for Drugs natin, tsaka yung ating inspection. So yun naman po ang pwede namin i-assure na kapag nagkaroon po kami ng application that we will treat it quickly and that we will do the processing quickly.
In the sense of urgency po, pwede ko bang makuha yung sagot na pag nagtulungan po tayo to really help them para nandyan na yung ivermectin, in a month ba nandyan na siya or in 2 months? Yun yung gusto kong specific answer. Wala na po yung pero or kung meron yung mga ganun na sagot. Pero gusto ko lang malaman in a month ba or 2 months, 3 months? Kasi medyo nasa pandemic time, maraming namamatay. So gusto ko makuha yung sagot na yun po.
Basta po ma'am, kompleto ang requirements at sinubmit po lahat yung requirements. Kaya po namin yan within 4 to 6 weeks. Ang Certificate of Product Registration. Ang CSP po, 24 to 48 hours.
Yung po sa LTO requirement ni Dr. Landy, gaano katagal yon? Kasi parang may a month's period na yatang na naka-apply siya. Kasi parang gusto ko makita dahil nga baka ito yung solusyon. Baka pwede tayong magtulungan para mapabilis yung proseso para hindi na kasi natin dapat sinusunod yung tagal ng process na usual. Kasi iba na yung sitwasyon natin na sa pandemic kasi tayo.
Yes, Madam Chair, yun pong sa LTO kasi ngayon lang naman nalaman na may LTO na application kasi po CPR yung hinahanap namin. So I would direct our director for the Center of Drugs, Director Sirunay here, to take a look at it para kung meron pa po mga deficiency, ma-inform agad si Dr. Landrito at within 1 week masettle po yan.
Okay, thank you Madam Chair, and hopefully nga siguro in 2 months time makikita na talaga natin yung ivermectin. Mas mabilis pa, di mas maganda sana. Salamat po.
Yes. DG Eric, you mentioned earlier na meron kayong initial talk with few local manufacturers, no? Drug manufacturers like the Pascual Lab and the Lloyd Laboratories. Are they applying for compassionate use or CPR?
I think, Madam Chair, they will thinking of CPR talaga. No? Kaya lang, medyo maraming ang requirement ng CPR. So I was telling them na if the ivermectin is included in the treatment guidelines, for example, of DOH for COVID-19, then mas madali po kasi pwede siyang emergency use drug. And that will be mas konti yung requirements. No? At mas mabilis po talaga yung processing nun. So, ang usapan po namin we'll see, we will talk within by next week with the manufacturers to see kung ano po yung mabilis na way para pwedeng makapag-rehistro ng produkto.
Yeah. My next question is, kanina, binasa ni Yusek Verheri yung statement of different societies, no? Composed of different societies. And kasama doon ang DOH and FDA. And doon ay nireiterate ninyo that we do not recommend the use of ivermectin for the treatment of COVID-19. So how are you going to, I think, assess, no, or analyze yung mga applications kung at this time ang position ninyo ay you do not recommend. Ang mag-a-apply sila for COVID use, right? Na specific, very specific, lalagay nila yon, compassionate use for COVID treatment or CPR for COVID use. And these are a group of experts and you rely on the comments or analysis, no? Or assessment ng ating mga experts.
Yes, Madam Chair, pero the last sentence naman, this was done a month ago, and the last sentence says naman that, this really will change depending on new data that comes in and that is submitted and will be appreciated. So, Ano naman po ito? Mga scientifico naman po ito na titingin ng datos. At that time, yun yung available. And if there's something available now that can change that, that recommendation, then I'm sure it will change.
Okay, thank you, DG. I think our representative from WHO, Dr. Rabay.
Reports of the efficacy of ivermectin to suppress the development of the SARS-CoV-2 virus originated from a study in Australia where they used a concentration of ivermectin that is a magnitude higher, meaning almost 1,000 times higher than what is normally used in humans. And at this concentration in laboratory, they showed that ivermectin can suppress the virus replication. Now, we've had very small scale studies done following this initial observation using ivermectin that is recommended for human consumption in a number of countries. In all of these countries, the results of the ivermectin trials were statistically not significant. Let me explain. If you're looking at the total number of COVID patients in the world today, many people have yet not got infected. So we could assume that people who drink water are protected from COVID. We could assume that people who took ivermectin are protected, but that's not evidence. It needs to be statistically significant. We had a similar situation with hydroxychloroquine a few months ago, if you remember. And then when WHO did the detailed solidarity trials, none of them had any efficacy in reducing the severity or in protecting COVID-19 infection. This was conclusively shown by the WHO solidarity trials. Now we are dealing with ivermectin. The issue with ivermectin is that based on that initial study and the currently available data, it is not strong enough for us to advocate the use of ivermectin for treatment of COVID or prevention of COVID. We looked closely at the European Medical Association. They concluded the same thing. We looked at the US FDA. They concluded the same thing. Their recommendations is that ivermectin, the available data. What they are recommending is that we look at carefully planned, controlled clinical trials to have a proof whether ivermectin works. That is the global evidence that we have, not only from WHO, but also from very stringent regulatory authorities and medicines authorities, both in Europe and in North America. So where are we with the potential? And we do recognize the urgency to find something, but the mere fact that we use or prescribe either protecting people or making their COVID symptoms better if they are already infected. Without that proof, what we are actually creating is a false confidence in people that if they take ivermectin, they are going to be protected. And that could actually be harmful. That is why it requires a carefully planned clinical study to understand whether this has A, a protective efficacy, B, efficacy as an agent for treatment. And that evidence currently is not available globally. One other issue, there are two kinds of preparations of ivermectin. There is a purified version of ivermectin that is used for parasitic diseases, particularly onchocerciasis or river blindness, which is a very pure form of the drug. And there is another form of the drug which is widely available and which is used broadly in veterinary medicine. Now, the thing with the veterinary medicine formulation is it's not cleared for human consumption because of impurities there. So when we're using ivermectin for trials, we need to ensure that we use those formulations that are prescribed and produced for human consumption. We have to bear this in mind, and as far as we know, those formulations, and maybe DG Eric can correct me, are not for sale in the Philippines. So we have to be very careful that if we want to go and do a clinical trial, it needs to be registered as a clinical trial, it needs to be designed so that it has adequate statistical significant power to generate the evidence or non-evidence whether it is protective or effective. If we can do that, our position is that there is still room to look for that evidence. And if we can see that evidence, then we will be in a better position to decide on ivermectin. Thank you, ma'am.
Thank you, Dr. Rabay, for that inputs. Next to ask question is Representative VG Lacson. Just want to remind everybody that we still have like 13 more representatives who wish to interpolate.
Thank you, Madam Chair, and good evening, especially to my colleagues and our guest speakers. And I'll also like to commend Dr. Alandrino and Dr. Corey for his very enlightening presentation. Well, I learned a lot of about ivermectin, but they call it the wonder drug. No? So I think there's this hope for this, considering na parang wala nang option yung natitira sa Pilipinas. Why did I say that? Nasa height tayo ng pandemic ngayon. Nasurpass natin yung dating 6,000, nasa 10,000 na ang level natin. Then, tinitingnan natin ganyan na nagpipresent sila yung sa vaccines. Up to 2022 pa yung mga vaccine na binibigay natin. Kasi dyan yung natin nilagay yung bet natin, vaccine. We'll get vaccine. Well, that's good. Talagang first option to get vaccinated. But until when? No? Parang, so, ilang years pa, ilang months pa, pero kailangan na natin height of the pandemic. Ano pa? Kulang tayo sa mga quarantine. Ang hospital, puno na lahat. ICU, wala na tayong paglagyan. Sa gamot din, wala rin daw mabilan na ng remdesivir o kulang na sa stocks o yung tocilizumab. Bago na naman yun. Ngayon, kung kailangan na narinig. So, saan tayo pupunta? Well, there's these two doctors saying, we have hope on this. Bakit? Meron naman silang mga pinakikitang proof. And then Dr. Corey, international specialist or expert na nagre-research, frontline against COVID, what do they call their group? PLCC. So, bakit hindi natin pakinggan? Then, bumagsak tayo sa FDA, not approving lang pala. Walang license to operate. So, parang bumagsak tayo ng pure bureaucracy. So, ano ba talaga yung sabi, ayaw natin sa batas. Pero I believe, that saving lives are not a crime. Yan ang primordial obligation o duty ng mga doktor. Mag-save ng lives. No? At this time, tingin ko, we are on our special or a different time ngayon ng pandemic. So we have to resort on all of things na we try it. Kailangan pa ba natin gumawa ng batas para lang payagan?
I have to cut you. Your time is up. Kindly wrap up.
Yes, Secretary Duque and FDA Director. Bigyan niyo ng chance itong gamot na ivermectin. Ibigyan na mag-compound ang mga doktor kung meron silang capacities. And we're talking of the human grade, kasi parang na-demonize na tong ivermectin Sinasabi nila para sa hayop to Meron talagang ivermectin na pang tao. Pinakita nga ni kung Mike na kasama sa essential list of drugs kanina. So, pagbigyan natin, give it a chance. Sabi nga natin, aanin pa natin ang damo kung patay na ang kabayo. So, huwag natin hintay pamatay tayong lahat. 10,000 a day ang cases natin. Simply let this doctor do their work. Huwag natin harangin ng bureaucracy na kumuha ka ng permit, abutin ka ng 6 months or ilang months. Alam natin mahirap yan. Or okay, tayo. It's sinasabi nyo, laws or policies that written by you.
Kung
So, kailangan natin konting leeway.
Kung VG, let's wrap up because we have a long list of interpellators. Please.
Yeah, thank you lang. Ako. It's just a manifestation. And FDA or Secretary Duque can respond to it if they like to. Thank you, Mr. Chairman.
Thank you so much. Thank you, Kong VG. I think your concern has been raised already by previous interpellators. And Eric and Secretary Duque responded already. I'd like to call on Deputy Speaker Mark Coleta. DS.
Maraming salamat, Madam Chair. Can you hear me?
Yes, sir. Loud and clear.
Good evening po sa ating lahat. Napansin ko lamang po, I think everybody will agree with me that we live in a very precarious times. Precarious times need extraordinary measures. I'd like to know from the DFA, or the DOH and FDA, whether the rules can be flexible. We are not living in an ideal time. Napakahirap po ng kalagayan natin, Director Domingo. Halimbawa po, yung nag-a-apply si Dr. Landrito ng kanyang LTO, if the ideal time frame for the approval of the LTO is 2 months, will it be a crime for FDA to at least consider it to be completed in 2 weeks' time, considering the emergency nature of the time that we are in?
Mr. Chair, basta naman po COVID-related, we can be flexible and we promise naman to be quick about it. Kaya po, meron tayo talaga mga special pathway basta po COVID-19 related, katulad po ng EUA, ng mga emergency use medicine. Basta naman po alam namin na yung application is COVID-19. I think that's one thing naman po that I can assure the Chair and our congressmen that applications will be treated with haste and will be treated fairly.
Salamat po kasi kanina, walang galang na po sa inyo, talagang very stiff and rigid po yung mga sagot kanina. Parang kinakailangan kung 2 months yon, kailangan nating i-honor ng 3 months o 2 months. Ang sitwasyon nga natin po peligroso na. Kaya kung po pwedeng, kung magawa nga natin as soon as possible, maybe shorter than 2 weeks, mas maganda po siguro yon sapagkat ang pinag-uusapan natin ngayon ay buhay. Pero kanina nakalulungkot, Director Eric, dahil nung sabihin ni Dr. Landrito na nag-apply na siya at isinangguni mo kay doon sa isang assistant mo, ang sabi niya kanina, titingnan pa lang niya. Ibig sabihin, February pa pala niyang na-submit yung kanyang application. Titingnan pa lamang nung, I forgot the name, parang Lagunsay yata yung sinabi mo kanina.
Si Director Sirunay po, kasi po Mr. Chair, napakarami po naming application ng LTO. Hindi naman po namin alam kung alin yung kanyang application. We don't even know the name of the company. Kaya po talagang pag LTO po kasi hindi naman nakalagay pa kung anong produkto siguro yung gagawin niya o kung para saan ito. Kaya napakarami po, kaya talaga siguro hindi naman nila identify kung ano po yun.
Do we have directors, Unay? Nakakuha kaya siya ng update doon sa application?
Actually, tinatanong nga po sa akin ni Director si Runay kanina kung ano yung pangalan ng company kasi hindi po nila alam.
Can we ask Dr. Alan Landrito? Dr. Alan?
Yes, the name of the company is Dr. Landrito's Health and Wellness Product Trading.
Okay. Director Sirunay, kindly check na ibigay na po ni Dr. Alan.
Madam Chair, can I continue?
Yes, sir.
Palagay ko naman po, Madam Chair, nung isubmit ni Dr. Landrito yung application niya, na-describe niya naman siguro yung pangunahing gamot na gusto niyang mabigyan ng LTO. Nakalagay naman siguro ivermectin. At considering na yung gamot na ito ay lumabas na po sa social media, kahit na po siguro sino ay alam na yan, hindi po ako naniniwala na parang hindi man lang napansin nung staff o yung official na yun na dapat tinitingnan mabuti. Kasi nga, lahat po ng makakatulong sa atin sa ganitong klaseng kalagayan ng ating bansa, bigyan na po siguro natin ng importansya. Who knows, Madam Chair, that this ivermectin, which is originally for veterinary use, could also be used for human consumption depending on how the compounding process can be done. It could be the silver bullet that we are all expecting sapagkat lahat nga po ng mga paraan na ay dapat gawin. Nakikita naman po natin na overwhelmed na po yung capacities natin. Kagaya ng naririnig ko kanina, halos tatlong oras na ako nakaupo rito. Why can we shift our focus on something that could probably help us? Katulad nitong gamot na ito, na marami rin nagpapatunay, Madam Chair, hindi lang naman karaniwang tao, mga experts din naman nagsasabi. Kaya ako po, ang aking pakiusap, bigyan sana natin ang pagkakataon na wag na nating pairalin yung bureaucrasyang masyadong matagal sapagkat sabi ko nga, extraordinary measures po ang kailangan kapag ang mga panahong kinalalagyan natin ay katulad ng ganito. At sana po ay magkaroon ng commitment. Katulad po ngayon, isang oras na po nung banggitin ni Dr. Landrito yon. Ngayon, hanggang ngayon, hindi pa po ba nakikita yung application na yon? Kanina pa po natin pinag-uusapan ito. Kung talaga pong interesado ang FDA at yung official na yon na responsable doon sa pagtingin ng mga aplikasyon may kinalaman sa ivermectin, kanina pa po siguro nakita niya na. Pero hanggang ngayon po, Director Domingo, hindi pa po nakikita ng officialis mo ng official mo, di ba?
Inahanap na po nila.
Yun po yung problema Yun po yung problema. Tatlong oras na ako nakaupo dito at nakikinig sapagkat napaka-importante po nito. Kung talaga pong interesado yung official na yon na may responsibilidad sa bahaging ito, dapat po mga siguro 10 minuto nakabalik na siya at natawagan niya na kayo na kinoconsider na po na niya, na-receive po natin. Dr. Domingo, ang buhay po na masasave natin ay walang katapat Kung minsan po, sa hirap ng buhay, Dr. Domingo, yung pagkain ng aso po, kinakain na ng tao Yung po dog food, nakakain na po ng tao. Ngayon po, kailangan natin yon. Kung sakasakali po, itong ivermectin na to, sang-ayon po naman sa pag-iingat na sinasabi ng WHO official kanina, depende naman po sa pag-iingat, at yan naman po yung nasa formularyo naman pala, pwede naman palang gamitin. Siguro po, Dr. Domingo, kailangan na po siguro nating pagbigyan naman yung magkaroon naman po ang kinalaman sa tungkol sa pagsisiyasat niyan. O hindi naman po ako siyentipiko, wala naman po akong kinalaman tungkol sa bahagi na yan ng mga produkto at mga gamot. Pero in order for us to be able to help our citizens in our hour of need.
Yes.
Para po kasi, Madam Chair, ang
Yes
ang
po. I just want to remind you that your time is up. Kindly wrap up, sir.
Yes, ma'am. Parang nagsususpecha lang po ako na yung pong ginagamit na parang counter ng mga bansa na sinasabi nila na walang visa ang ivermectin, nanggagaling po sa malalaking bansa at mayayamang bansa na kung saan ay nagpo-produce ang mga pharmaceutical nila na mga katulad ng Moderna, katulad ng Pfizer. Parang nakikita ko po na kaya nila binablock ang ivermectin sapagkat magiging kalaban nila dito sa ginagawa rin nilang mga bakuna na hanggang ngayon naman ay hindi natin alam kung tayo makakatanggap pa niyan at kung hanggang kailan pa tayo maghihintay. Sana po, Madam Chair, sa pamagitan po ng pagdinig natin ito at sa inyong pagtataguyod at pangunguna ay mahanap natin yung mga kaparaanan na makatutulong sa ating bansa. At gusto ko lang pong pasalamatan ang aking kumpare, si Secretary Duque, sapagkat isa siya sa nagbukas ng kaisipan ng marami. Meron po akong experience, Madam Chair, kasi kailangan ko ma-share ito. Dahil po na-overwhelm na po yung ating medical system capacity, ang ginawa po namin, yung aking pasyente na hindi na po namin dapat idalhin sa ospital, nakagawa po kami ng paraan na hanapin na lamang yung doktor na po pwedeng pumunta sa mga bahay. Marami pong ganito eh. Imbes na po dalhin natin sa ospital, kukuha na lang tayo ng akmang doktor na pupunta sa mga bahay, meron siyang kasamang isang nurse. Ang totoo po nyon ay naging maganda po ang kalagayan ng pasyente na 85 years old na po dahil nag-improvise po tayo. So ganyan din po yung ivermectin na Madam Chair, kailangan po tayong mag-improvise. Alang-alang na po sa pangangailangan ng ating bansa. Salamat po, Madam Chair.
Thank you, sir. Next to us, we'll call on again later Director Serunay. I think she's checking the status of the application, sir. But while waiting, we'd like to call on Representative Bong Suntay. You have the floor, sir.
Yes, thank you, Madam Chair. Yeah, I just wanted to ask, considering that ivermectin is registered in other countries, would it be, kunyari ako, nanggaling kunyari ako sa Amerika at bumili ako doon ng isang bote containing 100 capsules at inuwi ko sa Pilipinas. Would that be prohibited by FDA?
Yeah, Madam Chair, pag naman po for personal use, personal consumption, hindi naman po tayo stricto dyan. Hindi lang po pwede yung bumili ng marami tas ibebenta for commercial purposes.
So, kaya ko lang naitanong to, kagaya ng sinabi ng madami sa ating mga kasamahan dito, you know, for example, just 2 days ago, a friend of mine was, yung kapatid niya was hospitalized and they needed remdesivir, which was now short in stock in some of the hospitals. So hindi, and yung mga ganyang instances is replicated in, I believe, in other hospitals dahil nga nag-spike yung cases natin at yung mga drugs for the treatment of COVID nagiging short in stock. So gusto ko malaman, kunyari meron tayong mga kamag-anak tiga ibang bansa where ivermectin is registered, kunyari nagpadala sila dito, hindi naman magiging mahigpit ang FDA. Kunyari for personal consumption ng mga kababayan natin dito mahihirap that needs the medicine pero hindi makabili nga ng mga mamahaling gamot.
Meron po tayong limit eh. Usually po for 1 month consumption, for example, for a person na yung kanyang maintenance medicine, pinapayagan po, no? Pero yung magdadala ng isang balikbayan box tas pamimigay, yan po siguro baka harangin na po sa customs yan kasi commercial na po yung quantities.
Yeah, but if it is not commercial quantity, okay lang yan. I just want to make it clear.
Kapag nag-uwi po tayo, halimbawa ng isang boteng vitamins natin, okay lang po yun, hindi naman po namin inuuli.
Okay. So thank you very much, Madam Chair. I just wanted that clarified. Thank you.
Thank you, Chair Bong. Last to interpolate on this matter, I'd like to call on Chair Eric Pineda. Kong Eric.
Thank you, Madam Chair.
Thank you.
I was not able to ask questions a while ago because the FDA and the DOH should really think out of the box. In this time, talagang kailangan po natin yung mabilisan pong solusyon. Kung yung mga produkto nga po ng mga herbal drugs na may nakalagay doon na no approved therapeutic claim, pinapayagan po natin. Sana po makapag-isip po sila ng paraan para mapagbigyan po kaagad lahat po itong mga gusto mag-manufacture nito sa lalong madaling panahon, Madam Chair. Now, ang question ko po kay Dr. Landrito, given the opinions raised, if ivermectin was to become available sa lahat po ng tao, do you think this will solve the problem we are facing in this pandemic po, Dr. Landrito? Dr. Landrito?
Okay, yeah, if we can provide every Filipino with ivermectin. Every Filipino will be provided with ivermectin for in a matter of 2 months, we will cut our cases by 90%. If you extend it for another 2 months, pandemic is over in the Philippines. And let me put here, ang red tape sa FDA ay ganito. Nag-apply ako dyan February 11. After 20 working days, they send me a note, malabo daw lahat ng pinadala ko na requirement. Hindi po pwedeng maging malabo. Scanned copy po yun. Those are scanned copy, PDF copies, lahat ng requirements. And then they will tell me, padala kayo ulit ng requirements kasi napakalabo ng pinadala nyo. Come on, that is red tape. No? So, they are trying to delay the whole thing. No? So, I've been telling Dr. Eric Domingo, I think you have forgotten to become a doctor. This pandemic, I have three relatives died already from COVID-19. People are dying every day. People are getting infected every moment. So we cannot afford to waste time. If you can give me a LTO this week, I will apply for EUA. Please give me in 3 days EUA. We will provide every Filipino with ivermectin. And if you will not be able to do that, I don't know kung anong malasakit mo sa mga tao, sa mga pasyenteng namamatay sa COVID-19. If we give ivermectin to people in 2 months' time, we will cut by 90%. If we give to all Filipino people ivermectin, we will finish the pandemic in 4 months. That's what I think the impact of ivermectin can be. Considering all the 6 mechanisms of action, considering also the 4 meta-analysis that is based on all the clinical trials done around the world.
Thank you, Madam Chair. I would like to ask Dr. Landrito for his comment regarding the studies that were made by the DOH, and they specifically state
FDA, Philippine Medical Association, along with 8 other institutions, made this statement and made 5 bullets there on which to base their recommendation of not recommending. We look into the 5 bullets, they cited 13 citations. All of it are not representative of any of the meta-analysis. None of it. And one was not even peer-reviewed, the one done in Colombia. So, they are so biased into just trying to discourage ivermectin. We don't know the reason for that. And even not me, even a great DOH, FDA, and the ones who provided for that statement. And if I want to say something to Dr. Duque. No, you were telling na you will look into it. No, you never did that. We had this League of Provinces of the Philippines, the governors. I was there, and you sent for USEC Vega, Leopoldo Vega, and also another DOH Napoleon Arevalo and said, we will call Dr. Landed. They never call me. They never ask me. And if Dr. Domingo is saying if it will become protocol of the OH, how can it will become protocol of the OH to add ivermectin into your treatment protocol when you are not calling us, when you are not hearing us? Why don't you see? Aware naman kayo sa ginagawa namin. I presented the same things I presented here. And Dr. Napoleon Arevalo and Leopoldo Vega, these two doctors were telling over the League of Governors, no, that they will look into what I am doing, but never did. They never did, no. We had exchanges in text. It's nothing more than that. They never followed it up. They were not considering it for treatment in the OH. And I doubt if they will do if we go there and tell them. And that is what Dr. Eric Domingo here is saying that I should get, no. But ito lang pakiusap ko. Give us our LTO today. After 3 days, give us our EUA. We will provide every Filipino, and then the pandemic will be over. We can open up economy. We have seen it work to all the people I have given ivermectin to.
Okay. Kong Eric, your time is up. Is there anyone?
Thank you, Madam Chair. One last question, Madam Chair. Is Dr. Cory still around? Is she still on board?
Yeah. I think
Cory?
He's not on board anymore.
Thank you. Because I wanted to ask his take regarding the comments of Mr. Rabi of the WHO.
Okay.
So that's all, Madam Chair.
Thank you, Chair. Last to ask question is Kong Mike Defensor. Then after this, I will turn over the chairmanship or I will turn over to our Vice Chair, Sandra Irigel, to continue the chairmanship of this hearing.
Thank you for staying for these long hours. Ang tanong ko po kay Secretary Duque or kay Yusek, kung sino po kay Vergere, kung sasagot po sila. Because ang sabi ninyo, ang mga doctors natin na mag-prescribe ng ivermectin ay tatanggalan ng lisensya. Tama po ba yun?
Yusek Vergere. I think for the information of everyone, Secretary Duque left already. But we still have Yusek Jose. Anyone from the DOH?
Yes, Madam Chair.
Sorry, Yusek. Kindly respond.
Yes po, Madam Chair. Wala naman po kaming naibigay na statement yata na tatanggalan po natin or bawal mag-prescribe. Ang position lang po ng Department of Health, because we have done this living CPG evaluation with the other experts, and that's why we have adopted that recommendation. And the position of DOH would be, we are open to further study so that we can see the evidence that it really would be providing benefit for our population.
Madam Chair, na-quote po kasi ang DOH tungkol dito, and recently yung Philippine Medical Society was saying this. Ang sinasabi nga nila, doctors prescribing ivermectin as COVID-19 cure is losing license. This was unquoted po dito. We will submit the name, sabi niya, to the DOH statement po to, DOH statement. So, ang sinasabi niya po, this is not true. They can prescribe.
Well, sir, unang-una, siguro po, base yan dun sa batas natin na hindi po kayo pwede mag-prescribe ng unregistered drug.
Ngayon, hindi pwede mag-prescribe. Kahit na po sabihin dito, wala po. Pero si Dr. Homer Lim, siya nagpuproduce siya, nagko-compound siya, hindi po pwede mag-prescribe at bumili.
Madam Chair, if I may.
Please proceed, Yusek.
Thank you po. Sir, Honorable Congressman, we follow the law. Dapat po yung pinaprescribe ng mga doktor natin rehistrado. Kung sakali po mabigyan sila ng compassionate special permit, the prescription will be based on the compassionate special permit and the conditions attached to that.
Ibig pong sabihin, kahit ako po mag-import ng isang drugs na nakuha ko sa ibang bansa because wala po siyang approval dito, illegal pa rin po.
It has to be registered, sir.
Tingnan niyo, Madam Chair, this is precisely my point. kung sinasabi nating safe ang drug na to at nasa formulary natin, bakit hindi payagan? Kung safe naman, I do not know if you can help me or not. Diba? But I was able to get ivermectin. Yes, Yusek Bergere, please reply.
Madam Chair,
Go ahead, Yusek.
yes po, ma'am. It is part of the national formulary because it is used for filariasis.
Yes, but Yusek Bergere, that you can do an off-label prescription and they're doing that in the US. Talo pa natin, Madam Chair. Talo pa natin ng US. Ang US, basta may prescription ka, you can buy. Sa US, kahit na po basta may formulary, nandun nakalista, and they will produce the drug kasi may compounding po sila, may mga pharmacy sila. Do you know, Madam Chair, that even Mercury Drug, may mga pharmacies, they can produce this product. And yet, we have this kind of situation. So, eto na naman po, iniipit tayo ng burokrasya. I heard Congressman Lacson, Congressman Eric, Congressman Marcoleta. This is the kind of attitude that we have with DOH. At kung ito po talaga will help us, tayo po, ito na pong burokrasya natin ang gumagawa ng sitwasyon para mamatay yung ating mga kababayan. Madam Chair, my next question is this sa FDA. Prescription ng mga doktor. So, sitwasyon natin, deadlock po tayo. Ngayon, dito po sa atin sa FDA, pag nag-produce po ang mga operators and they are allowed, no? They are allowed under the law. Hindi po ba pwede silang payagan kahit hindi naka-register yung drug nila since ang formulation naman po ay nandyan sa atin?
DG?
Naka-mute po ako. Pwede po, yung unregistered, pwede po yun mag-compounding. So yung pong pharmacy, kukuha lang po siya ng added activity po yun sa license niya, yung compounding. And they just have to follow regulations to make sure yung quality po ng kanilang produkto ay acceptable for human consumption.
So therefore, DG Eric Domingo, Dr. Domingo, yung sinasabi ni Yusek Bergere, pagka ako nagkaroon ng pwede mag-prescribe ang doktor at pwede kong kunin sa isang compounding laboratory.
Basta po, ang palagay ko lang po kasi yung po siguro sa ano ng DOH noon is kasi nga po yung panghayop po siguro yung naisip na hindi pwedeng ireseta sa tao. Pero kung compounding po, pwede po.
Okay. My last question, hindi po ba Dr. Domingo and DOH can also reply to this? Na pag ginawa natin itong trial and we approve ivermectin, mismo dito sa ating bansa, ay pwede po natin itong isagawa at gawin natin clinical trials kasi totoo po, Madam Chair, wala naman pong sinabi na ng conclusion kung ito'y makakatulong o hindi. Ang pinupunto ko lang po kanina pa dito, safe naman po to. Ginamit ko to, ininom ko po to. At kung dahil safe naman po to at baka sakaling makatulong, bakit hindi natin gawin na magkaroon ng trial on this? So, Madam Chair, yun ang why can't DOH establish this as a trial drug, an investigatory drug, para lahat ng mga problema natin sa permits, lahat na sinasabi ng regulation will be out of the issue and there is a legal recourse on this. And again, we can even help WHO on making this trial. Thank you, Madam Chair. I think Yusek Domingo will answer.
Well, yes, Mr. Chairman, pwede naman po talaga. Di ba sinabi ko po kanina, isa sa mga possible legal ways of bringing in the product, isa sa investigational product. Basta lang po meron tayong clinical trial na approved naman po ng mga technical committee natin. Register ng study, nagre-regulate po kami ng study. So usually po ang gumagawa ng ganitong studies for human health would be PCHRD under the Department of Science and Technology.
And also Department of Health to approve it as part of the overall program for COVID.
I think si Yusek Rosette po wants to say something.
Yusek Verheri. Yusek Rosette, I know you're tired na rin.
Naka-mute, ayan.
Yes, Madam Chair and Honorable Congressman Mike Defensor. Yes po, that's really the intention, and that was what the part of the recommendation coming from our experts, that further studies be done. And a clinical trial is very much open so that we can put everything in order para makita rin po natin talaga kung yung ebidensya talaga directed po na talagang pwedeng protektahan ng ating mga kababayan. So we are not going to oppose that. We are very much open to having a clinical trial which is official and undergoing the formal process.
So will you be doing that, Department of Health?
Usually, sir, Madam Chair, I will respond na po. Usually, Honorable Congressman, kapag po may mga ganito, katulad ng sabi po ni Yusek Eric, sa PCHRD po, dumadaan itong mga clinical trials na ito. Nagbibigay ho sila ng application din sa Food and Drug Administration. Pag natapos po yung clinical trial, DOH po ang end user. Kapag nakita natin na good outcomes po yan, i-adapt po yan ng DOH.
Thank you, Madam Chair. Salamat po. And congratulations again.
Thank you, Kong Mike, Defensor. So basically, we've covered everything from testing, contact tracing, to our hospital capacity and treatment. No. Last question, Yusek Rosette. Na-raise ko na kanina yung discrepancies on price ng current treatment, yung included in treatment protocol like remdesivir to patients na maka-access sa mas cheaper. Kasi yung experience natin sa private hospital, ang remdesivir can be as high as 15,000. In government hospital, nagba-vary din siya. Merong 4,000, merong 5,000, merong 7,000. So, pwede bang i-regulate natin yon?
Madam Chair, before I turn it over to Yusek Eric to provide additional inputs, the main objective po of national government is for us to do bulk procurement so that we can provide our hospitals and the costs will be lower and standardized. But for now, these drugs doesn't have any EUA. Meron po yatang isang supplier or manufacturer na nag-apply ng EUA nung isang araw, pero inaantay pa ho natin yung EUA so that we can have our HTAC review this so that national government can procure and can provide our hospitals. But for the regulation of prices, yun po yung naiisip natin ngayon, bulk procurement, para po magkaroon ng pantay-pantay na presyo ang ating mga ospital kapag ang national government po ang bibili.
Yes, Yusek, I think napaka-important at this time, no? Grabe yung burden talaga with the expenses ng ating mga moderate cases that needs hospitalization. So lalo na yung ating mga nasa ICU, no? ICU patients na nag-incur, I think, around 3 millions, no? Private hospital. So talagang financially draining siya for the family. Okay, we'll now go on with the vaccination program. We have a long list of representatives who wanted to ask questions. We have like 8 congressmen. But before that, I would like to call on our Vice Chair, Representative Sandra Irigel. Do we have Kong Sandra?
Yes, Madam Chair. Yeah, now I'll take the floor.
Chair this hearing, Vice Chair Sandra Irigel. Please proceed.
Okay. Who are we going to ask as the resource person for the vaccination program from the DOH?
I think Kong Sandra.
All right, thank you. Thank you, Madam Chair. My first question is on the target, which I believe is 70 million by the end of 2021. So based on the presentation earlier, we have already inoculated 702,000. And since we started March 1, so the 702,000 inoculations happened in 29 days. So, Madam Chair, that's an average of about 24,228 per day. So, ang tanong ko lang po, Madam Chair, is ano ang latag for the rest of the balance? No? So 70 million minus 702,000 and you divide that by the 270 days. Ang ibig sabihin po nun, we need to inoculate 256,000 per day beginning April 1. So ang tanong ko first is, paano tayo magla-level up from a current level of 24,000 per day to 256,000 per day? Ano ang plano ng DOH or IATF para ang capacity natin ay ma-elevate ng ganung kalaki. And keeping in mind, Madam Chair, na for developed countries like Germany, ang nai-inoculate nila per day is only about 200,000. So yan po ang first question ko po. Ano ang plano ng gobyerno to increase our capacity?
Yusek Bergere, can you please answer that?
Yes, Madam Chair, Yusek Mirna Kabutay is here. She is the head of our vaccine cluster, if I may refer the question to her, ma'am.
Floor.
Good afternoon, Congressman Stella Kimbo. In terms of the plans to upscale the number of vaccination, we are relying heavily on the local government units to do the administration together with our private during the first month, was because we did not really have enough vaccines. No? We had initially 600,000 of Sinovac, but that is divided to two because there are 2 doses. And then we had the AstraZeneca that was available from the COVAX facility. And since our first priority were our healthcare workers, there was the right to first refusal. So that means if the health worker did not want the Sinovac that was available, they can have the right of refusal for the and then get the, it was almost 90,000 to distribute. Yung latag po ng 50 to 70 million, it was presented by Secretary Galvez earlier. Yung mga makukuha pong mga vaccines over the years. So we will now push that vaccines move faster. We will try to limit the handling. So from the central warehouse, diretso na sa LGU, not so much handling. And if they can increase their vaccination sites, the numbers that they are doing, we're looking at mega vaccination sites, and we will work closely with both local government and private sector. But we already had a high of 90,000 at one point that we were able to do the vaccination, Your Honor.
Kindly unmute Kong Stella Kimbo.
Yeah. So, Doc, what you're saying is walang problema sa pag-scale up from the current maximum of 90,000 per day up to 256,000 per day. Ayan ang sinasabi niyo po. As long as dumating ang supplies, kaya.
There will be, Madam Chair,
Yes,
there will be challenges, but I think we have learned our lessons in the slow start on how to scale it up. No, there will be challenges, but if we have the current number of vaccination sites, which is about 2,400, and they are able to do 100 per vaccination, we can do about 200,000 per day, depending on the vaccines that will be available. We all know that not all vaccines can be for all the different types of vaccinees. No, like our Sinovac cannot be used for our
issue, ma'am.
It is an issue, ma'am. We are trying to address it through the comms for one-time accomplishment that we had. There is a clamor for vaccination, and we work together with our comms.
Tested your video. Pasensya na po ha, I've seen it. Pasensya na po ha, it looks like a commercial from the 1950s. May pagka makaluma ang itsura niya. I'm wondering if you have pilot tested this, particularly, with a younger population.
We will check with the health promotion and because it's a coordinated work among the different government agencies.
All right. Let me move on to the delivery schedule and the prioritization list. Kasi kanina pinakita po ni Secretary Galvez yung delivery schedule. And parang tinitignan ko lang po, no, just very quick math, parang hindi po nagtutugma yung delivery schedule with the prioritization. So ibig sabihin, in one slide, naka-indicate na tapos na ang A1, A2, A3 by the end of second quarter. So tapos dapat by June. Pero nung binibilang ko po yung dami ng tao, parang kulang. Kasi if we count A1, which is frontliners, so 1.7 million, plus seniors, 9.4 million, plus individuals with comorbidities, that's a total of 25.1 million. So dapat, tapos na yung 25.1 million by June, by end June. Pero pag bibilangin po natin ang doses, ang lumalabas, so napakalayo ng 7 million individuals versus the 25.1. So parang yun lang po. Nakita niyo ba yung disparity na yun?
Your Honor, honestly, it's the first time that I saw the latag ng vaccines that are arriving. No, but we will check whether the targets will fit, because but I know is that there is simultaneous, there will be a parallel vaccination. No? Hindi na natin hihintayin na matapos yung isang we can go to the next set of priorities as long as in the area meron na po tapos na po yung priority groups na. For example, health workers. Patapos na dito sa NCR. Simula na tayo ng senior citizen. Ganun po yung latag ng simultaneous. We do not wait for the whole Philippines to finish the healthcare worker. Ganun po ang alam kong latag. But we will check, Your Honor, yung number of deliveries versus the number of...
Yes.
Yes, we will
Please
check,
do.
Your Honor.
And keeping in mind, ma'am, that the binding constraint is the delivery. So yung sinasabi niyo pong simultaneous, that will not solve the problem. So sinasabi ko na po ngayon, I am flagging that there's a big disparity between deliveries and planned inoculation. So particularly, by end June, ang planned inoculated individuals is 25.1 million versus, based on your deliveries, ang kaya lamang is 7 million. So ang laki po ng disparity, 18 million po ang disparity or 36 million doses. So sana po tingnan nyo ito ng mabuti kasi that alone will suggest na imposible na makuha natin yung 70 million inoculated individuals by the end of December. So kung hindi talaga natin kaya, kailangan natin sabihin ngayon para magawa natin ng paraan. Because otherwise talagang baka marami pong mamatay. No? So now last question na lang po, Madam Chair. On the funding, kasi based on the 2021 GAA, meron tayong 72.5 billion. So more or less, kapag i-divide mo yan sa 70 million individuals, lumalabas na ang budget per head is about 1,000 pesos. So pwede ba natin, can you just tell us kung kasya po yung appropriation na yun? I know that merong private sector donations, meron ding LGUs na nagbigay ng kanilang pledges. So ano po ang financing plan? Kasi nagpakita na po si Secretary Galvez ng delivery schedule, in which case alam na natin yung brand, alam na natin yung price per brand, mako-cost out natin kung magkano ang kailangan natin for all those deliveries for 2021. On top of that, lalagyan syempre natin ng logistics costs, program administration cost, cost of information, etc., etc. Magkakaroon tayo ng estimate of total budgetary requirements. So the quick question is, kasya ba yung 72.5 billion na nasa 2021 GAA for all of these resource requirements?
Yusek Mirna, are you going to answer that?
Yung kukunin din natin yung sa makabayan. So kailangan din natin
Paki-unmute.
Okay, thank you, Madam Chair. I am not in the best position to answer this. There's a negotiation and there's a procurement technical working group that is looking into this. But we are going to use the loans. We have the ADB, we have the World Bank and the AIIB loans to use for this
Ma'am, hindi po financing. Appropriations ang tanong ko po. Appropriations.
Yes, ma'am. But the appropriations, anong tawag dyan? From the loan, we are going to use the appropriations to pay the loans.
Ma'am, magkaiba po yun.
Yusek Mirna, ang tanong po ay kasya na po ba yung appropriations daw ng 22.5 billion for the vaccines?
As of now, they have not requested for additional, so it depends on what the cost that is being negotiated by our vaccines are. So they have not requested for additional, so we presume that it is sufficient given the current prices and the current negotiations. But you are correct, Madam Chair. We are also banking on the private sector multi-party agreement and local government procurement to assist us in the national government procurement.
Madam Chair, siguro pwedeng hingin na lang natin yung information from the DOH so they can prepare. In fact, hiningi na po namin ito 2 weeks ago in one of our committee hearings ng Econ Affairs. So I just like to reiterate that request again, if we may have the estimate of total resource requirements for all of these vaccines that are forthcoming for the 2021 inoculation program, and to show us as well if the appropriations are sufficient. So yun lang po, Madam Chair.
Yeah. Thank you. Thank you, Congresswoman Stella Kimbo. I'd like to direct the DOH to please submit to the Committee on Health. Thank you, Yusek Mirna. Let's now proceed. The next interpellator would be DS Bernadette Herrera D. You are now recognized, Congress DS.
Thank you, Madam Chair. My question is regards the unified registration. We discussed this together with the speaker, kay Sec Galvez and kay Sec Duque, for their unified registration. Do we have this already? Kasi napansin ko ang registration per municipality, per city, per ganyan. My problem with that is that minsan nagdo-double registration sila. Pag may address sila sa Quezon City, paparegister sa QC. Pag may address sa San Juan, magpaparegister doon. So how do we fix this?
Anyone from the DOH? Yusek Vergere?
No. Yusek Mirna, ma'am. In terms of the, with your permission, Madam Chair, in terms of the registry, the Vaccine Information Management System is under the auspices of the DICT. So it is preparing and doing all the necessary information system and solutions. We have what they call the VIMS-IR. This is the Vaccine Information Management System Immunization Registry that has been already rolled out to the entire country. There are challenges because some cities are more advanced than the others, but they are able to make it interoperable so that there is a registry that is available, but it is not yet 100% working for the entire Philippines. We are using some blended solutions, yung highly advanced cities and municipalities use the QR code. They are highly digitized. For the other areas, we are using the simple Excel and the simple blended solutions. But the VIMS, the DICT has assigned what they call the hand-holding team that will help the different LGUs, the different bakuna centers, be able to register. Yes, ma'am, we are able to look at the duplicates. It's the VIMS-IR is supposed to look at kung ikaw ay na-register sa isang area, the same name, they will be able to duplicate. Ibig sabihin yan that it is already identified in one area and they will give a unique unique code number
Well,
for this
sana-
registered.
Yeah. Sana USEC maging mabilis ito kasi ang napapansin natin, pag nag-double registry, biglang makakancel out siya. Kunwari, hindi siya dadating sa schedule niya because na-vaccine na pala siya dun sa isang lugar. So nakuha yung spot niya ng ibang tao. So nababawasan yung ino-inoculate natin. So we have to make this fast kasi yung double registration can really affect also the number that we inoculate per day. So I hope you'll take, mga kailan po kaya ito? Ano po ang deadline nyo sa DICT?
Yusek Mirna?
Late April, if they can finish all the whole country with we are only talking immunization registry. We're not talking about the administration, which is having some challenges.
Tayong panahon, kailangan po natin itong i-rush. And we've been discussing this for 2 months already. I think Chair Helen also knows that. Ilang beses namin yan diniscuss. Anyway, number 2, I would like just to put on record kasi na-receive ko rin naman yung messages na wala nang discrimination when it comes to private companies who can order the vaccines. So tama po ba hindi na po i-discriminate yung tobacco and milk companies from availing of the program?
Yusek Mirna?
That has been removed from the IRR, Madam Chair.
Okay, thank you. I would just like to put that on record. And then next, register, how can they list down? So I feel na hindi pa rin masyadong laganap ang ating information dissemination as to saan magpapabakuna, paano magpapalista, and all that. So ano po bang ginagawa nating, do we do aggressive steps for this? Sana po mas i-aggressive pa po natin, i-promote po natin yung vaccination program para hindi po matakot yung mga tao.
Yes, Madam Chair, we will look into that, although we have already been pushing, even coming up with our last mile registration because there has been some problem in the interpretation of our A1, who comprised the A1. We have been giving them to our regional vaccine operation centers, even through the DILG. DILG has given directives to the local government units to fast track the registration.
Ma'am, as someone who's in the ground, I'm telling you, kulang na kulang po. We receive text messages every day. Napakadami inquiring kung paano. So, ibig sabihin, marami pa rin po. So, I'm telling you now, kulang po. So, please, sana mas maging aggressive pa tayo dito. Last question. Ano po bang plano natin dun sa mga private companies? I understand some private companies already have vaccines, pero they cannot roll it out because inuuna yata yung public. Hindi po ba pwedeng simultaneous yan considering the public takes care of yung mga nasa priority list natin? Pero if some private companies can already have their vaccines, hindi ba pwedeng sabay-sabay na rin pati yung mga empleyado nila para mas mabilis na safe yung ating bansa?
There is an allocation framework and there is a prioritization framework, Your Honor, and we are following the prioritization framework. But we are in talks already with the private sector. Pwede naman silang bumili and then they're going to meet with the NITAG so that mailatag na yung simultaneous, because with the private sector, 50% goes to government and 50% goes to them. Basta lang walang been finished.
When will this be, ma'am? Kasi the faster, di ba, the private sector can help, the better for our country. Eh sila naman po, may pera naman po sila. Baka pwede po nating bilisan ito?
Yes, ma'am. We are. The Secretary Galvez is in talks with the private sector. There is regular talks, and after they make a proposal, because baka available na yung AstraZeneca purchased initially by the private sector, then we're going to talk with the NITAG to look at paano paglatag ng prioritization framework, and then afterward, this is presented to the IATF for approval, Your Honor.
Yes, please, sana as soon as possible kasi the private sector are very much willing to buy and purchase for their own employees, di ba? So, sana maging simultaneous na to. Well, government is taking care of our own people. Let them take care of their own people kasi gusto nila safe eh. Maswerte nga po tayo, they're willing to do this. And I think some of their vaccines are already there pero may kulang yata na EUI or whatever permit na kailangan nila so that they could distribute it. So ano kaya ang timeline natin, Yusek?
Last question na yun.
Yes, last na yun. Ano pong timeline natin?
Ma'am, for those who that are arriving, we are looking at April to have the first rollout for the private sector, and we will have talks with the INITAG how it's going to be done. But the private sector is amenable to the fact that they will start with the prioritization list in their companies, and then pag nabigyan na yung mga prioritization list sa kanilang company, they can go to the next priority list. Inalaw naman po yan ng ITAG. For example, sa one private company, pagtapos na yung mga A1, mga health workers nila, pupunta na sila sa senior. Yun naman po ang gagawin nilang pagbabakuna. And then they'll go to those with comorbidities. Pagkatapos ng comorbidities, pupunta na ho sila sa mga economic frontliners. Doon na sila. So, mabibigyan na sila by that time. Yun sinasabi natin, nagsa-simultaneous po.
I look forward to that, ma'am. Thank you very much.
Okay. Thank you, DS Bernadette Herrera D. The next interpellator. Yes.
Chair, that of the SBH, no, na-mention ni Yusek Mayor na pwede na yung private. So gusto ko lang i-clarify, Madam Chair, kung yung when she mentioned na pwede na yung private direct 11255 yata yun, yung vaccination 11525, which is the National Vaccination Program. Nakalagay po doon yung tripartite agreement. Are we not following that anymore?
Mirna, kindly answer.
Madam Chair, we're still following that tripartite agreement. We cannot buy from AstraZeneca if it does not go through the Philippine government. So it's a DOH, NTF, and the private sector consolidator and the manufacturer that will do the agreements. The law specifically states that there is a multi-party agreement, and the finer guidelines will be issued from the NTF, the National Task Force on COVID Response, and we are already doing that. We will start to do that as we continue our talks with the private sector, Your Honor.
Okay, thank you, Yusek Mirna. The next interpellator is Chair Joet Garcia. Chair Joet, are you around? It seems that he left. The next one is B.S. Christine Singson Mihan. B.S. Christine.
No, just me, Rose, voice. Magkatabi ba kayo or you're on the phone?
Hi, B.S. Christine.
So
you're now recognized.
Kasi may chance na lumalabas yung voice niyo. Kung naka-zoom.
You have now the floor.
Isipin niyo na lang yung pinagsasabi ni ano.
Yes, Christine.
Madam Chair, you can just call the next interpellator.
Okay. Chair will now
Hindi kayo
call
kinakawain kasi.
Chair Tof de Venecia. Chair Tof.
Yes. Thank you, Madam Chair. Can I be heard?
Yes.
Heard. If they could just kindly mute their accounts. Thank you. Madam Chair, I would like to yield my time to Congresswoman Stella Kimbo for additional questions on the vaccination program. Thank you.
On the second round, okay.
No, Madam Chair, for this round.
For this round.
I would like to yield my time to Kong Stella.
Okay, Kong Stella, are you around? You now have the floor, Kong Stella. Kong Stella Kimbo.
Yes. No, Madam Chair, no further questions.
Ferdinand Gaite of Bayan Muna.
Salamat po at magandang gabi. Gabi na.
Gabi na.
Sana hindi kayo na-curfew. Anyway, mga ilang katanungan lang. First, I'd just like to point out the line of questioning of kung straight na divided by the remainder 9 months or 270 days, almost 260 per day. And according to the Department of Health, kaunting tweaking lang kakayanin na. But I'd like to point out, based on the report of Secretary Carlito Galvez, that the supply is backloaded, hindi front-loaded. Konti yung darating ngayon, mas marami darating sa huling bahagi ng taon. At sabi nga niya, 3 million to 5 million per week between the months of August to December. And again, I did some math. That's 714,285 jabs a day. More than the 260. Again, same question. Are we prepared to roll out that many jabs per day, considering that nabanggit kanina, we're only doing 90,000, at least in the best, one of the best days. In terms of resources, manpower, gender sensitive type, human power, personnel, equipment, cold storage facilities, etc. Kakayanin ba ng existing?
Please unmute Yusek Bergere.
Yusek Mirna po. Yusek Mirna, Madam Chair.
Okay, Yusek Mirna, kindly answer.
Yes, thank you. Our current vaccination sites, ito yung mga number that Bakuna Center is 2,400. We have registered 6,500 total sites. So ibig sabihin, sir, hindi pa nagagamit yung ibang vaccination sites. There will be challenges, but we hope to capitalize our experience. Ano pa ba yung kailangan gawin para mabilisan? And we are relying not only on the local government unit who should be leading the vaccination, but also on our private sector representatives. We are looking at mega vaccination sites where there will be more that will be vaccinated. Our bottleneck will be the post-vaccination area. So they'll have to compute because you need to be observed 15 to 30 minutes to 45 minutes in the area. So kung depende sa in-schedule, yung mga local government unit, they need a bigger area. Nag-practice na po yung ating many of our local chief executive, yung tinatawag nilang simulation vaccination. For example, for the Sinovac, we were looking at 100 vaccinations per team per day. Some were able to do it at 200 to 250 per day. It will vary from area to area, but as I was saying, we hope the experience can help us. We are looking, as Sec Charlie was saying, at 1 million. It will be with very much difficulty, but we will see how we progress as the vaccines, the number of the vaccines that are arriving will be administered.
Okay, thank you, Yusek.
Thank you, Madam Chair. Again, a concern, dahil tulad na nangyari ngayon na nagkaroon ng surge, maraming factors na hindi kinonsider. Kung kaya't we're now facing the problem of inadequate facilities, medicines, and the like. Sana i-consider ito dahil very real, as Kong Stella mentioned. The supply, the rollout, the resources required, so that we can, hindi natin sinabi, definitely there will be problems, but at least alam na ganito yung requirement para makapag-adjust accordingly. If we have to get all healthcare workers to, there's a 1.7 million supposedly na bilang who will be already vaccinated as A1 priorities. Kung kailangang i-call out sila to help and volunteer in this gargantuan effort, then by all means. Ang point, we have to recognize that concrete problem of the large task facing us. Second question, Madam Chair. We have some questions about the a statement of recently by the president regarding the indemnification fund that despite the provision of Republic Act 11525 as mentioned by Chair Helen regarding the policy now is that we will not pay the indemnification fund and government will not guarantee this. I think this throws a monkey wrench in the procurement. Hindi ba magkakaproblema ito? Ano ba ang position po natin ngayon? Because as I understand, that was the prerequisite or requirement before we could start the negotiations. At kung wala nito, we'll be facing a major problem in the procurement. So ano ho ba ang status nito, Madam Chair?
Yeah. Yusek Mirna. You're now recognized. Yusek Mirna. Kindly unmute. Yusek Mirna.
Thank you. Po sa indemnity fund, pinag-aaralan nito, pero yung nasa batas po, kung susundin yung nasa batas, ito po ay i-administer ng PhilHealth with a 500 million contingent. So, gagawa po ng PhilHealth ng kanyang mga guidelines at saka rules and regulations. Kapag gawa noon, i-consider na po yung statement ni President, but we will leave it up to them. But nasa batas naman po, Nakwan, may provided na indemnity fund that PhilHealth will administer.
Okay,
Thank you
you. Kasi, Madam Chair, ang concern ko lang that if that requirement by the pharmaceutical companies is requisite before we can procure, those statements might throw in a monkey wrench. Ibig sabihin, baka biglang bawiin na naman yung kontratang pinaghirapan na makuha. So, yun na nga, I believe also in the said Republic Act, pwedeng bawiin din ito. No? Kaya this is a concern, lalo na ngayon na paulit-ulit na yung problem that the supply, production scale, even with the big pharma companies are still up in the air. Hindi pa ganun katiyak kung yung mga schedules na binabanggit, tulad na binanggit ni Secretary Galvez, ay nakataga sa bato. Kaya isang concern ito dahil kung ito ay bawiin na naman, potential problem naman ito. And ayoko nang sa inyong oras natin, ginagabi na tayo. There was sana nandito pa si Secretary Duque. But about 3 days ago, we had an opportunity to have also a Zoom conference with the good secretary. And one of the concerns that was raised during the Committee on Overseas Work, yung problema na nakabalik na. Ang isang problema ngayon, paalis pa lang. Apparently, many countries require the vaccination of our overseas Filipinos, including sea-based and land-based workers. And due to the prioritization of overseas Filipino workers, I think they are B5, kung hindi ako nagkakamali, no? So medyo malayo pa. And they were seeking an adjustment to A4, I think. Apparently, we asked Secretary Duque what he can through the IATF, pwede ho ba ilapit sila sa A4? I do not know, nag-meeting na ata yung IATF. I do not know if this was raised. If so, ano ho yung naging position? There was a group of OFWs, may doktorado kasama, na gustong pa-deploy na ata sila sa China. And the Chinese government requires vaccination before deployment, including also our sea-based workers. No? Ito yung mga seafarers. So matanong lang kung ano na po yung nangyari doon sa pagpupulong kung meron man. Salamat. Huli na po yun.
Okay. Yusek Perere. Kindly unmute, Yusek Perere.
Nasa A4. But anyway, Yusek will have a rejoinder. Yes.
Yeah, rejoinder from Yusek Perere, please.
Madam Chair and Honorable Congressman, yes po, it was discussed already in the IATF and also during the House of Representatives committee meeting last Friday that those OFWs who are healthcare workers shall be included into the
Healthcare.
A1 priority list, provided that they can recurse. It was proposed by the National Economic and Development Authority that it be part of the A4 or the essential workers, and it has been given a positive consideration by the IATF. They just need to resolve this once this list is finalized. So I think the OFWs will be upgraded into the A4 and the A1 list, sir.
Oh, that's good.
Salamat. Yes, thank you so much for the input.
Madam Chair.
Yes, Chair Helen.
Yes, in relation po doon sa list, no, napansin ko po yung social workers is in letter B. Is it in B list? B list, no? Yusek Mirna. Social workers, Yusek.
Yusek Mirna.
Yung social
A1.
workers po, meron sila sa A1. For those who are providing care in closed institutions and providing the amelioration. The rest of the social workers are in B?
B1. Yusek Mirna, B1.
B1, Your Honor.
Tingin ko po at this time, no, together with our BHERT, no, yung Barangay Health Emergency Response Team, and nakikita ko po sa ground yung ginagawa ng mga social workers natin, even in the hospitals or those employed in the LGUs and the DSWD. Napakahalaga po ng ginagawa nila ngayon, Yusek Mirna. Ang kinakaharap nila ay mga tao na may exposures or members of the families who are infected with COVID-19. So baka lang po mapag-isipan ninyo together with our teachers, no? Kahit naman po naka-online learning tayo. I don't know kung nabalitaan niyo po yung Zambales, wherein the majority of the principals or head teachers were all infected because of that one meeting they held, I think. At lahat yata sa buong Zambales ay nag-attend ang mga principals. So the rest of them were infected. No? So ano lang, for consideration po of IATF, yung social worker, I think very important. Alam niyo po, napakahirap ng trabaho ng social worker. Lahat ng amelioration programs natin, sila po ang kumakaharap for like 12 hours, no? Na nag-PTS doon. And then yung mga nasa hospitals natin. Yusek Mirna, baka po pwede in general yung social workers natin. Hindi na meron pong pa kayong category.
Yusek Mirna? Yusek Mirna?
Thank you, and we'll have a rejoinder from Yusek Rosette because they are the ones who do the prioritization. Ang social workers po, those who work in the hospitals and those who give the social amelioration are part of A1.5 po. Tama kayo, they are together with the BHERTs, Agrino po, yun, A1.5. Yung iba lang na, and then those who are giving social amelioration. Pero yung ibang not involved in the social amelioration are in B1. B1 ano, Dr. Rosette?
Yes, Yusek. So,
But
Madam
kung yung general po, baka pwedeng all social workers, baka naman po yung mga office worker, yung mga kuwan sa B1, kasama po yung mga teachers. Yung mga teachers po, I don't know what is the final recommendation of the NITAG, Yusek Rosette, for the teachers. Nasa B din sila eh, B1.
Madam Chair?
Yes, Yusek Rosette.
Yes, ma'am. Just to add to the response of Yusek Mirna, the teachers and the social workers are part of the priority list for classification B. So we just prioritize those most vulnerable who are those in the A list, that is A1, A2, A3, A4, and A5. But after that, the teachers and social workers are part of the priority po. As to the teachers being recommended before, it was recommended already by DepEd and the other agencies. it was which have done the prioritization for the essential workers based on the evidences that they have based po dun sa mga studies na ginagawa nila. And they've come up with this list of 8 sectors na inilagay po nila dun sa essential workers. And the teachers were retained in the B1 classification, Madam Chair.
Okay. Let's get back to Congressman Gaite. Do you have your last question, please? Please unmute, Congressman Gaite.
Ayun. Salamat po. Doon sa tanong po ni Kong Helen Tan, dahil may mga kausap na kami